Let's close that door. Are we good to start?
Yes, sir, you can start.
Okay. A very good morning, ladies and gentlemen, and welcome to the second day of CIGICON 2021, the 6th World Congress of Cochlear Implants in Emerging Nations under the aegis of GCIN, and the 18th National Conference of the Cochlear Implant Group of India, and the first time ever virtual conference of these two associations. I'm sure you all enjoyed the deliberations we had yesterday, barring a few connectivity glitches, mostly from the speaker side. I think it went really well. The responses have been very good. And like we said, we want to continue that and try and minimize glitches as much as possible. And thank you very much for all your feedback. With that, I just have one or two housekeeping announcements. One is that today, all the common sessions, you would come to Hall 1. If you remember the physical conferences we would have, the Auditorium 1 would be the one for all common sessions. And today, here on the virtual platform as well, Hall 1 would be treated as the Auditorium 1, and that is the surgery hall on your lobby spotlights. You know, the hot spots that you would click on the surgery hall. If there is an integrated panel only between audiology and rehabilitation, it would be in the audiology hall. All breakout sessions, parallel sessions would be in all three halls as you spiced today. With that, I welcome you today one more time to the second day of the CIGICON 2021, and we begin with the third keynote address today, and it is on rehabilitation. And we have Dr. Sue Archbold from the UK who will present her keynote. To introduce her, we have Dr. Shah Garbal. And to introduce Dr. Shah Garbal, I would invite the chair of our rehabilitation scientific committee, Rashmi Deshpande.
Good morning, everyone. A warm welcome to all of you. Can I have Asha Garbal ma'am's slide, please? So it's my great honor and pleasure to introduce Dr. Asha Garbal. She's a senior audiologist and speech therapist, and also a consultant in Sir Gangaram Hospital. She has devoted more than 40 years in the speech and hearing field. She's also the director of Asha Speech and Hearing Clinic, which is the first and the oldest clinic in North India. Her clinic is an integrated mix of experience and technology in the field of hearing and speech impairment. I welcome you, Asha ma'am, and I welcome Dr. Sue Archbold too. I hand over the platform to you. Ma'am, you need to unmute yourself. You will now be introducing Dr. Sue Archbold. We'll get her slide. Can we have Dr. Sue's slide, please?
Yes, good morning, Rashmi. Thank you for wonderful introduction. It's my privilege to join today and introduce such a fantastic and experienced Dr. Sue Archbold. Her career, following a career as a teacher of a deaf, she managed Nottingham Cochlear Implant Program from its inspections in 1989 until 2004. She established a comprehensive database to monitor progress and outcome and development innovative measures of real-life benefit using qualitative research techniques. Following this, she became CEO of the EAR Foundation, leading a team of support, research, education, and services for cochlear implant users of all ages and the families. She has published and lectured widely on this work. focusing on the CI benefits and challenges in real life and using research to influence policy and practices. She gained her PhD from Nijmegen University on deaf education, changed by the Cochlear Implantation, and was honored with an honor Doctor of Letters from Nottingham University for her work in CI. Sue remains passionate about improving access to the best possible serving for all with hearing loss, and is part of the core working group of WHO's World Hearing Forum and coordinator of CIICA, the CI International Community of Action. I welcome you, please. Eager to hear from you.
Hi and welcome. I'm really sorry that I can't be with you in person to present this keynote speech, and it's a real privilege to be asked to do it and to join you in some way. I don't know what time it is there, but when you see this, it'll be 3 o'clock in the morning for me. Hence, you're seeing a recording and not me in real life. However, I do hope that you get a lot out of this presentation, because it's a topic dear to my heart. Cochlear implantation for children, is it for life? Some of us have been implanting children for a long time now, over 30 years. Those young people, they're now young people. What's happening to them? Where are they? Have we got sustainable services? And I suggest that while we are really keen to increase access to cochlear implantation for children and for adults, but we're particularly thinking about children here. When we want to increase access, we really need to think about the long term, about lifelong services and how we're going to deliver those. Well, just two older photographs here with Neelam and I when I visited Pune and had a great stay there. That's some time ago. I don't think I look like that anymore, but we had a great time, and the enthusiasm for us all is still there. And Neelam kindly contributed to CIGICON recently, and we've had a lot of interest from India. So good luck, enjoy your conference. They're always great, full of enthusiasm and lots to learn. So lots to learn and exciting technologies. So why am I going to talk about sustainable lifelong services? Isn't that boring? Well, what I suggest is that some of those exciting technological and scientific developments that you're going to be talking about are wasted unless we can deliver lifelong support services for them. Many parents led the revolution about cochlear implantation, and their children are now young people, like Kez here, the photograph of Kez at WHO in Geneva, advocating for cochlear implants for children and young people. They're experiencing new challenges into the world of work. We've got an obligation to these young people who are advocating for their futures and to support them in their challenges. For example, here's the story of one young man with an implant, had his implant nearly 30 years. He's a geologist. He's off to hunt mines around the world. Here he is at Heathrow Airport in London. He's got his steel-toed boots. He's got his ear spares. He's got a banana. What's his biggest concern? It's not about what he's going to eat. His biggest concern is about his ear gear, as he puts it. Will his ear gear continue to function? He's only got one implant, unilaterally implanted. If his implant fails, or the processor breaks down, or he has a real problem when he's traveling and working, life for him becomes almost unsustainable, really challenging. And Neelam, when she presented at CIGICON a couple of weeks ago, One of her slides brought up this topic too, about challenges for sustainability. What about the maintenance, repair of processes, cost of traveling, upgrades, accessories, implant reliability issues? If we're implanting young children, then they're going to be using their implants for a long time. What about revision surgery that they're going to face in their lifetime? What about funding that? Or more importantly, in some ways, providing the services and the support for that. And she raised this elephant in the room about non-users, which is, again, a topic dear to my heart. What about those non-users of implants? Well, that applies globally, including in India. And it's the elephant in the room that's not discussed and not addressed, and people pretend it's not there when they're getting very excited about access. Why? Well, it's not as exciting as talking about new developments, about talking about new technologies, but it's vital that we do think about these long-term issues of sustainability. Now, these are European figures, but I suspect the proportions and the issue I'm going to talk about applies to India. So if we have a look, these are along the bottom, starting in 1985 up to 2019, in orange. Orange represents the new implants each year, the new children being implanted. Blue represents those children who already have their implants. And of course, that's a cumulative figure, so it goes up each year like this. And what I'm concerned about is, what are we doing about this lot, this number that increases on an annual basis and is going to continue to do so because they're not going away. And if we ask the question about how old are they, these are European figures again, but if we have a look here, 30% of those children implanted are now, how old are they now? Not when they were implanted. Now they're under 10 years. So 70% of the children who've been implanted are over 10 years of age. And 20% of them are over 20. Now, we constantly talk about early intervention and what we're doing with the little ones. That's actually, I suggest, the easy bit. What are we doing about this lot? Well, we need to think about it. Cochlear implants have changed the options for deaf children and their families, and part of many technological developments in recent years. Newborn hearing screening, digital aids, auditory implants, assistive listening devices, change communication developments. We've all been very familiar over the past year or two with the change communication developments, and here I am recording this on Zoom for you to access. And we know that pediatric implantation is safe, and the earlier the better within reason. We know we can give access to the spoken language of the home from the first weeks, months of life. We know about increased language levels. We know about increased mainstream education. We know about increased educational outcomes. But what do we know about the long term? What do we know where all our young people are? Are they using their devices still? Sustainability, again. Neelam put this as the Indian paradox. In a country of over 1.3 billion, with a rapidly expanding economy, a growing middle class with economic independence similar to their counterparts in the developed world, millions live below the poverty line. In fact, 1/3 of the world's poorest people live in India. And into this situation, we're talking about bringing new technologies. But using Neelam's slide here, her photograph, wherever you go in the world, where in low and middle income countries, wherever you travel, people have a mobile phone. People have access to many of the new technologies, and cochlear implants are part of this revolution. And that cochlear implant revolution has been set in this changing context. We live in an increasingly global world. And that's been illustrated, of course, in the pandemic. Communications changing, become easier and technologically driven. All the time and hours that we've spent on Zoom over the past year. It's free or nearly free, or we can access it. We can have automatic captioning. It's so much easier than it ever was. And the pandemic, of course, has increased the pace of change and access to it. We have more mobiles than people in the world. We have social media influencing lives. Who knew that being an influencer was a real job? We've got politics driven by social media and by people who know how to manipulate it. But in the midst of this, there's also a changing attitude to disability and to difference, and I'm sure that's happening in India too. So that parents and young people expect to be involved in decision-making about their care. These are the people that Jerry O'Donoghue calls the internet warriors, who come into his clinic having got so much information from the internet. Increased activism, advocacy, and inclusion are expected of diversity. In Europe, we have the European Disability Forum, and their slogan is "Nothing about us without us." Here they are in Brussels, marching on the European Parliament. Nothing about us without us. People are fighting for accessibility for all, including for those deaf and with a hearing loss. In Europe, we had the Accessibility Act passed, and the group called the European Cochlear Implant Users Group, which has members from well over 30 countries, is heavily involved in arguing at government levels in Brussels for accessibility and for services for those who are deaf and have a hearing loss. The activities of the World Health Organization have been hugely important in driving forward services for ear and hearing care. The World Health Organization's resolution of 2017 asked for all member states to have services for ear and hearing care to be included within their public health service planning. The first World Hearing Forum was in December 2019. Here some of us are, with representatives for India included there, of course. There's increased action on ear and hearing care, as WHO term it. The World Hearing Forum growing in numbers and action and advocacy with online access. There's huge participation online for the World Hearing Forum activities, and if you haven't had a look, do go and join them. World Hearing Day annually on March 3rd is increasing. World Report on Hearing launched in 2021, and I'm going to come back to that in a minute, because the World Report on Hearing is the first one and is a big step forward. There are strong campaigns, particularly with young people from WHO. Make listening safe, a global campaign. Check your hearing. Apple and WHO working together with Why Hearing Health Matters on your iPhone. Big projects developing ear and hearing care globally. Well, just when all this advocacy work was getting going, and we thought we were actually moving, we had a global pandemic, which changed things. A big impact on services and surgeries. The way services could be run, the limitations on surgeries, the cessation of surgical planning in some places. So access to services was more difficult, as we could see. Also an impact on communication getting very difficult with masks. Masks not only hide your face and make lip reading difficult, what they also do is interfere with the auditory signal. Education of children being disrupted. Schools stopping, online services, online education for them. A greater cognitive load for children in education. That was really hard for them. And also increasingly difficult for parents of those children who are living in poverty or living without access to the technology. A great technological divide if you can't provide computers and services for children for their education. Huge global financial challenges for healthcare. Where's cochlear implants in this? The pandemic has eaten away into healthcare budgets everywhere, leaving much less to go on other services. There's also people questioning public health decisions, learning a new language of public health, people questioning how the pandemic is being managed in their countries. On the positive side, we've got greater understanding of the challenges of communication by the public. What I'm seeing is many people saying that people, their hearing friends, for example, are understanding much more how difficult it can be to understand people when you can't hear very well, when you've got masks and screens up, or you've got to keep a distance. Access to services can be easier using the technology with greater confidence. We've all got used to using Zoom and to using applications that we couldn't do before. Recently, we had a KICA conversation in KICA, the Cochlear Implant International Community of Action that we've just established this year, which is growing beyond what we expected. We recently had a conversation on the impact of the pandemic services. There were 3 themes emerging from 8 people on that talk from 8 countries. The first one was funding, challenges for all health services for industry. People talked about the pandemic debt. We have to be very aggressive concerning that for cochlear implants, said one parent, and not let cochlear implants fall behind in the battle for funding. Waiting times longer, growing after the cessation of surgeries, and greater challenges in delivery. What about children's referrals? In the UK, of course, we have newborn hearing screening. But it seems from anecdotal evidence that the referrals for cochlear implantation after newborn screening and diagnosis may be slowing down. What one public health specialist said, I think what's particularly shocking is the worrying trend for smaller referrals for children. Adults, you might have predicted. A huge change, of course, has been remote service delivery, which has both positive and negative aspects to it. There's a growing confidence by all for remote service delivery. As one user said, this time last year, Zoom terrified me. Now it's just what you do. But sometimes I need a real person. Professionals saying we've become better at letting patients take control. The pandemic has forced them to think and act differently. Now, in the UK, we have the British Cochlear Implant Group, a bit like you have your Cochlear Implant Group of India. And the British Cochlear Implant Group collects a lot of data each year, publishes it on their website, which is extremely useful. Back in 2013, we started a campaign for increasing adult implantation by providing some services, by providing data, and starting our Spend to Save campaign. That if we spend money on cochlear implantation, then we can actually save money in the long term. Of course, you need to have some money to spend in the beginning, I understand that. And here you can see with adults over time, you see the increase in adults, a steady increase to 2019. What happened in 2020? Less than half the adults that would usually be implanted were implanted. And what we would have expected was a continued increase. I think we know why. If we look at the figures for children, they're not so stark, but they're there. Here we start 2013, on we go with the numbers over time, roughly stable, slightly going up. 2020, down they go. So the pandemic in the UK has had a big impact on the numbers being implanted. This, of course, has serious implications because the obvious thing that happens is that waiting lists grow and waiting times grow. And we all know that the earlier, the better for children and for adults. So advocacy is needed more than ever. And great things have been happening for which we can use advocacy work with governments globally, including in India. We launched the World Report on Hearing. Here it is, from WHO. We celebrated World Hearing Day with 700 activities worldwide. we launched the Cochlear Implant International Community of Action, KICA. So now think first about the first World Report on Ear and Hearing Care. It's a major tool for advocacy in India as well as everywhere else. And what does it say about cochlear implants? Well, the World Report on Hearing, its implications for cochlear implant advocacy, it actually says the cochlear implant is one of the most successful of all neuroprostheses developed to date. That's a very strong statement in support of cochlear implantation. And remember, the World Report on Hearing has reviewed all the evidence worldwide. What's its relevance then to cochlear implant advocacy work for you and for groups globally? The report makes clear that deafness and hearing loss is a challenging global health and social issue that really must be tackled. As the Director General of WHO said, we can no longer afford to turn a deaf ear to hearing loss. If unaddressed, if we do nothing about it, hearing loss can negatively impact on many aspects of life: communication, the development of speech and language in children, cognition, education, employment, mental health, and interpersonal relationships. So the huge impact of hearing loss on children, adults, families, and society is recognized in the report. The benefits of today's technologies, specifically including cochlear implants, are recognized as part of ear and hearing care across the life course. Cochlear implants are electronic devices especially useful when a conventional hearing aid has little or no benefit or cannot be used. In children, timely intervention with hearing aids and implants leads to better hearing, spoken communication, and quality of life, which further translates into better educational outcomes. So cochlear implants included. Improved access to high-quality, affordable hearing technologies, including hearing aids and cochlear implants, and the services required for their effective use. So the World Hearing Report includes cochlear implants in those technologies that must be available. And the World Report on Hearing, having reviewed all the evidence, states children with cochlear implants have greater likelihood of acquiring oral language, of integrating into regular schools. Their use in children with severe degree of hearing loss has brought substantial benefits to those implanted. Cochlear implants can also have a beneficial impact on learning and educational outcomes, as well as the overall quality of life, though many other factors other than implantation can influence these results. On the left, you can see one of KICA's resources, where we have summarized the evidence that's in the 250 pages of the World Report to bring you in a very short form the evidence from the World Report on Hearing on children's cochlear implant advocacy. The economic case for cochlear implants has been made. Unaddressed hearing loss imposes a global cost of more than $980 billion annually. This includes healthcare, education, lost productivity, and societal costs. Pediatric implantation being proved cost-effective, and as WHO says, the cost of doing nothing is one we cannot afford. So cochlear implantation should only take place where the supportive infrastructure for rehab therapy is in place. This is really important. I've said here, rehabilitation, or whatever we call it, is vital. We can call it education, some people call it therapy, we can call it family support, we can call it services. But one thing's for sure, that following cochlear implantation, we need to provide some support services. Rehabilitation therapy is essential to ensure that people benefit from the use of their hearing aids and implants. It improves the acceptability, effectiveness, and cost-effectiveness of these devices. And in our group in KICA, this has emerged as a priority for both adults and children. So why do we need to advocate for cochlear implants? What do we need to advocate? Well, despite WHO recognizing cochlear implants as one of the most effective neuroprostheses developed to date, they also note that their use has been limited. They note considerable variation and take-up by those who could benefit, including in high-income countries. We know that the gap between those who could benefit from cochlear implants and those who receive them is huge. Only about 5% of those who could benefit do so. They comment that with cochlear implants, there's limited research and data on access and factors limiting their use. And now with the impact of the pandemic, the problem has got greater, and cochlear implants advocacy is needed more than ever. In 2020, Brian Lamb and I carried out a global consultation in 28 countries of users, families, professionals, and industry, asking them about the barriers to cochlear implantation and about advocacy work. There was an overwhelming recognition of the issues with access to cochlear implants and lifelong care. The barriers being considered to be a real lack of awareness of the impact of hearing loss, a lack of awareness of what cochlear implants can do, lack of referral guidelines, and of course, finance. There was also recognition of the power of advocacy groups and individuals about the voice of the user. Advocacy groups and individuals and the users can do a huge amount to change and advocate. They can reach government and affect change, as we shall see. As one person said, the only chance of success for change is the advocacy voice, the use of the advocacy voice with policymakers, influencing decision makers, the voice of the end user. It's too professionally based. They forget the user end of things. And sometimes in cochlear implant conferences, I tend to feel we're just talking to ourselves. The professionals talk to themselves about cochlear implants, and then we complain about lack of awareness. We need to be talking outside our own professional area of cochlear implantation. Well, we established as a result of the consultation the Cochlear Implant International Community of Action, KICA, a network of networks, to develop a global community of cochlear implant groups and individuals with opportunities to share activities, resources, and collaborate to strengthen the user and the family voice. Another goal is to provide cochlear implant advocates with the tools for change they need to increase access to cochlear implant services. User groups and family groups have very little in the way of time and resources. And also the overriding goal to increase access to the provision of cochlear implants and lifelong services globally. So this outcome is KICA. Here's our website, KICA.net. If you haven't had a look, have a look and do join. A really energetic organization led by users and families. In 6 months, we've over 300 individuals. We've got over 70 organizations globally, over 40 countries represented. And we've got the resources, the tools for change, with 2,000 downloads of our resources in 6 months. We have regular KICA live events about specific topics and shorter, small KICA conversation opportunities for small groups of people with a common issue to discuss, to join together and see where that conversation takes them. On the website, you'll find KICA summaries of the evidence from WHO's World Report on Hearing. Here we have the Cochlear Implant Advocacy document, just a very short synopsis. And we've got a children's briefing document. But in spite of all this activity, some things just don't change. So much misinformation. If you look on Wikipedia today, you will find 1/3 of deaf children do not develop a language if they're on a cochlear implant program alone and have no sign language input. I don't think so. This is incorrect, but it's of course where many people get their information from. Globally, there's a rise in autism, more questioning of implantation in children, and misinformation in peer-reviewed journals too. So much misinformation fed by social media. But in all this, the long-term management of cochlear implants remains a big challenge, and it's not in the cochlear implant clinic. If you ask parents, they tell us that the training for local professionals is by far the most common issue. Education, 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 especially in mainstream schools, for teachers and classroom assistants. The need for long-term management, the support into adulthood, better local services and links with cochlear implant centres. This was a survey in 2006 with Cochlear. Have we learned anything since then? Well, a more recent survey in 2016 found many similar comments. In Finland, it's assumed that because he wears an implant, his hearing is normal, when it's not. We've had to fight for everything. It's a huge battle. I've had to fight for the rights of my son. Everything could be improved with better teacher training, more professional help in the classroom. While we're focused on how wonderful all our clinical services are and how professional they are, out in the classroom, that's where parents see the help needs to be. And what about the young people? What do they say about the needs at university and work? If you listen to them, my university is not deaf aware enough. They think because I speak, I can understand everything. If I was a signer, my needs would be obvious. My boss doesn't have time to talk about what I need. I need technical updates. What's new? The fact that it can break down and the fact that sometime in your life you have to have another operation to replace it. I need to talk to someone like me. The young people want to talk to other people who have cochlear implants, who have the same issues to deal with in daily life. Are we listening to them? Are you listening to them? We ask the young people, do you get extra support or help for your implant at school, college, university, and work? At school, most of them got a lot of help, but when you come to the world of work, it's very different. The vast majority get no help. They don't know what the latest technology is that could help them. They don't have access to any services that could support them if they're working in a very noisy environment, for example. We need to think about this and how it can be managed. So what do families and young people want? Well, a while ago, Sheetal Italia and I did a survey amongst children, young people, and their parents and professionals. What was asked for was for long-term cochlear implant users, a technical service that can be delivered via the internet remotely so that the team can spend the time more effectively on managing newly implanted patients in the early stages. They wanted remote programming of patients at home or in local audiology services using telemedicine. They wanted scientists and surgeons still provided by the specialist centre. Telepractice has long been used as a service model in Australia with Kathy Berman and Colleen Bazaras for assessment, counselling, rehab, group therapy, schools. People like and want the services. Singh 2014 reported this, but he also reported that the clinicians were more cautious. But now maybe the pandemic has changed the clinicians to be more confident about what people can do for themselves. The pandemic's taught us a lot. So, making the technology work in the community for a lifetime. If we look here in the clinic, we fit the hearing technologies, programming, provide assistive devices. We support people learning to use the implant, family programs, individual sessions, group sessions, some resources, and then out into the community at home, school, and work, where the implants are used on a daily basis. I suggest we're actually quite good at this bit, but not as good as this bit. How do we make this happen? How do we fund it? This is where it happens on a daily basis. And the need there is still huge. How many of you got out into schools or into the world of work and see what your implant users are doing in the long term? How can we make this happen, and how do we fund it? Well, maybe with the growing access to the technologies such as Zoom, maybe it can be more easily done. Thinking about funding of cochlear implants in India, Neelam showed us how in the 1990s, a lot of self-funding. In the early 20s, private trusts, NGOs, houses providing. And from 2000 onwards, there's a trend towards state and central government. I know still a huge amount to be done, but a bigger recognition of the need. The latest technologies can really be a huge help to sustain these services in the long term and bridge the gap. We can cut the costs, actually, of some of the service delivery. Even in low and middle income countries, the majority of people have a mobile phone. Remote care, online programming, troubleshooting can be cost and time effective. We can empower the users to manage the technology themselves and advocate for themselves. What's often said in counselling is the more you do, the less they do. For example, with young children, the more you do for them, the less they're going to do. Similarly with teenagers, the more you do for them, the less they're going to do. We need to empower them to manage things for themselves and to be independent. It's the only sustainable way forward. We're at an excellent time to move on advocating for sustainable services. There's many examples of successful advocacy. Here's the European Cochlear Implant Users Group in Brussels. The spend to save arguments. If we spend money on cochlear implants, we actually save money. The evidence has been expanded. Here's Beatrice in Italy talking about to government officials. Here in Uganda, Eddie Makaya, who's on the steering group of KECA, has an excellent job. He achieved the waiving of taxes on hearing technologies by the Ugandan government. How did they do it? They marched on Kampala. Now, parents can do that. Professionals can't do that, but parents can march on Kampala. And they actually achieved the waiving of taxes to bring the costs of implants down. And there's more. In Romania, the bilateral cochlear implants financially supported by the National Health Insurance House. That's as a result of NGO action. In the Czech Republic, joined-up advocacy work resulted in free upgrades of processors. In Spain, there's a recognition of cochlear implant advocacy recognized in the Senate. Here's Juan Zamora, working in the Senate House to get recognition of cochlear implants. And here they have messages on all the buses about cochlear implants and hearing right across 10 cities. And here you are in India, with progress being made about cochlear implants and advocacy to cochlear implants. So the way ahead for India, you've come too far to stop. Neelam suggests government funding with the devices being the property of the government, health insurance, and hugely important, continued dialogue with government officials. Of course, the problem with talking to government officials is that they move on and change jobs, and you've just made a relationship and developed work with one when you have to start all over again. So you have to persevere, persevere, persevere. To advocate for increased provision and ensure sustainability, we need clear evidence, we need data that's accessible and shared messages. So do we know how many are implanted in the world? Actually, we don't. Do you know in India? We need to plan and get hold of those figures. European Cochlear Implant Users Group are trying to collect the figures in Europe, and it's not easy even in Europe. We've published on that, and you can see how difficult it is. Do we know how many are using their implants? It's important. Do we recognize this importance? In a research review of literacy outcomes of students with implants, only 2 of 21 studies included information on consistency of device use and appropriate management of the equipment. The shared message is simple. Cochlear implants are safe, effective, reliable, and cost-effective. The challenge remains equity of access and lifelong care and funding. The revolution's happened in implants, they're here to stay. Have we learned how to make the services sustainable? We know that parents and young people and children expect to be partners and to be involved. They want the links between the implant centre and the communities where they live, and bridging that gap has never been easier and will get easier. The pandemic has forced us really to think differently and to provide new opportunities together with the new technological developments you can see during your conference. The strong advocacy happening in ear and hearing care by WHO, including cochlear implants, gives us many further opportunities to advocate and make a noise about ear and hearing care and implants. Well, cochlear implantation is a mature service. We've been around a while. Its long-term support should be out in the community where it belongs. And Archbold and O'Donoghue said that in Ear and Hearing in 2007. Wouldn't it be great if we would make that happen? So cochlear implants in India. These children will grow up. Are you planning for them and planning for their future and making sure that their future is secure? I do hope that you will have some discussion about these issues and wish you very well for the conference, and maybe one day in the future we'll be able to meet up properly. And please do go on the KICA website and you will be able to join very easily and see the resources available and the activities that are going on and contribute, and let's make things happen. Thank you very much, and thank you for inviting me.
Hey, I'm here.
Hello, Dr. Oza. How are you?
Oh, fine, thank you. Nice talking to you and also introducing you.
Volume
Today.
is okay?
Yes,
All
I
right.
can hear you quite clearly.
Okay, thank you. Would you like me to share my screen first or wait for your introduction?
Yes, organizers will do the introduction and then we'll request you to start your presentation.
So no
Sounds
comments
very
for
well.
the
Thank you.
previous by chair. No comments by chairman for the previous talk of Dr. Sue.
You can, Dr. Asha, can you hear me?
Yes.
Go ahead.
Yes, I can.
You got a minute to summarize. Go ahead.
Yes. So that was a wonderful in-depth. She talked about, Sue talked about the cochlear implantation for children for life. We got many good points from her about the World Hearing Forum activity and advocacy program. She also mentioned that how they started working on the adult cochlear implant program in 2013, and it was 600 earlier, and now they've crossed 12,000 limit. I think is very good for India also. We need to work on the adult cochlear implant program. Her another point is about sustainability advocacy, which is a huge way in the forum they have made. And also about the KICA group, the largest group, which they are about 8 emerging countries working together and taking part onto that's a cochlear implant international community of action. So if all the countries join in hand, I'm sure advocacy program and sustainability will increase. She had a great knowledge of, and she mentioned about all India's vision also. She knew and expressed it very well. So thank you for wonderful session by Dr. Sue. It's a good beginning for today's second day. Thank you, Dr. Suni.
Nishita ma'am, please unmute yourself.
Good morning, everybody. Welcome to the second keynote address of today, celebrating the 1 millionth cochlear implant. Where shall we go from here? By Dr. Fang Gang Zheng from the USA. What can I say about Mr. Ramesh Oza, the chairperson from India? He has been the pioneer of the audiology and speech therapy school in India today. He has a master's in audiology and speech pathology from the City University of New York, a Fulbright scholarship in the year 1963, a graduate in diploma and occupational therapy from the KM Hospital, BA in honors from the University of Bombay. He was the director of the occupational therapy school, started the BYL Nair Hospital to the audiology department way back in 1965, where he was the professor and head. And the first training program in Southeast Asia was done by him. He is currently the director of EAR Center and School in Mumbai. He set up a complete audiology and speech therapy department in Indonesia on invitation from the Indonesian Council for Social Welfare way back in 1971. He's a visiting professor at All India Institute of Speech and Hearing, Mysore from 66 to 71, and external examiner for PhD candidates at the University of Mysore. He's vice president elected for the World Federation of Occupational Therapists, Philadelphia, USA, past president of ISHA, CIGI, PTOT, Speech Academy of Therapists, Occupational Therapists Association. He has got a Lifetime Achievement Award by Rotary Club of Mumbai West 2012, and many more awards and paper presentations to his credit. He's been an honorary audiologist and head of the department at Just Lake Hospital from 1972 to 1995. And he has been on many central government committees, including the UPSC, till as late as 2000. Welcome, Mr. Oza, to our panel. You can take it from here. Thank you.
Thank you very much. It's a great pleasure for me to introduce today's, what I would call him as a medical scientist, Dr. Fan Zheng, who has got, to his credit, 3 PhDs, is a leading researcher in auditory science and technology, unraveling the loudness coding and speech recognition while translating research into 2 commercial programs on tinnitus treatment. He has published more than 100 peer-reviewed journal articles with 5,612 citations, and has been scholar October 2012. He is a professor of anatomy and neurobiology, medical engineering, otolaryngology, and director of Center for Hearing Research at the University of California. He is a fellow of the American Institute for Medical and Biological Engineering, Laryngologica, IEEE, and the Acoustical Society of America. It gives me great pleasure to present before you Dr. Zheng. I request him to speak on this most important and interesting topic. I'm very sorry, Dr. Zheng, if I'm not pronouncing your name properly, but that's the way it is. Thank you. Please.
Thank you, Dr. Oza. I hope you guys can hear me okay. And
yes.
Let me know if I needed to adjust my volume. Again, thank you, Dr. Oza, for your introduction. And I would also like to thank Professor Sunil Dutt for the invitation. And I visited India 6 or 7 years ago. And I would love to go back and visit India again in the future. But today I'll be talking about celebrating 1 millionth cochlear implant. And I'll share my screen and get a lot of people ask me, where'd you get the number? We have surpassed 1 millionth cochlear implant worldwide. Okay, my screen looks all right?
Yes.
Okay, all right. Well, this is a research I did myself by gathering information from annual reports from various manufacturers or other literature that I can dig out. Roughly speaking, sometime this year, we have worldwide implanted over 1 millionth user. And where did it exactly happen this year? I don't know, maybe at this very moment somewhere. And roughly speaking, Cochlear, the largest manufacturer, has about half of that market share. And Medel has about 25% of that market share. And Advanced Bionics has about 20%. And the other 5% consists of Neurotron and Oticon, each one of them having about over 20,000 users. So having get this number out of the way, and I'll speaking to you today about three things, more or less from a person who has been involved in developing cochlear implant. We're trying to make the cochlear implant from scratch, right? And we talk about history, because only when we look at the brief history of how cochlear implant was developed, can we appreciate where it is today and maybe project what cochlear implants will look like in the future. Every product has to address a need, right? In this case, a cochlear implant, right, was developed to help people, right, who couldn't hear, deaf or deafness. And we all know we call it deafness is an invisible disability. We cannot really see it if somebody couldn't hear. And it also turns out to be the #1 birth defect. About every 1,000 babies, we have 1 to 3 children who are born deaf. And in the United States, and it's also the #1 disability. And worldwide, that number probably exceeded 1 million or more. If you look at the other end of the spectrum, right, hearing loss is a very significant disorder. Roughly for the elderly who are 65 and older, half of them, right, have some degrees of hearing loss. And if you read the recent Lancet report showing that for 40% of dementia that can be prevented, 40%, the other 60% we don't know, right? But 40% dementia cases that we can potentially prevent, and hearing loss turns out to be the #1 we call the modifiable risk factor, right? And the percentage is 8%, which is greater than the 7% early education, 6% exercise, diabetes, hypertension, etc. And if you look at the overall cost, I think Dr. Sue showed the same number, where annually we spend over about $1 trillion. And the most important things, I think, about the impact of deafness is said by this person. I don't know how many of you can recognize her, but when we were a little kid, we read a book by Helen Keller, who was both blind and deaf. And what she said was that blindness isolated me from objects. Deafness isolated me from people, right? I think this shows you how important it is. Of course, someday we would love to have a biological solution, right, for treating deafness. But right now, the only game or the only intervention available is cochlear implants.
Right.
And as I said, cochlear implants, since its inception, has produced a tremendous impact. And I'm an engineer. I'll talk about numbers, right? And I presented it to you. There's over 1 million users worldwide, and the number is growing, right? And roughly half of these 1 million users are adults, and the other half are children. And cochlear implants, on average, allowed the average user, right, to carry on a conversation on a cell phone. And for children who got implant early on, they're able to develop language, and they will let them or allow them to go to mainstream schools. And roughly, if you look at the revenue of 5 or 6 cochlear implant manufacturers, $2 to $3 billion, and 10 times of the market cap, and still growing very healthy at about 10 to 15%. And most importantly, it's break the stigma of deafness. When you're really looking back, who started these, right? And of course, we heard about Volta story, right? A couple of French doctors, and there's US scientists and Russian engineers. They all tried and demonstrated that it is possible to use electric stimulation to evoke hearing in a deafened person, okay? But when it comes to a medical device, that not only do you have to demonstrate feasibility, you have to say it's safe, right? FDA has to approve it, and you can sell it, right? And we own that to Dr. William, well, we call him Bill House, and I have the opportunity to work with him at the Housekeeping Institute, and I actually interviewed him 2 weeks before he passed away in Oregon. When he was at the Housekeeping Institute in Los Angeles, trying to help develop this technology, and he faced tremendous obstacles, and most of them coming from within the scientific and the medical communities. And you can read some of the quotes that I gathered from the historical literature. And Hal Schucknick is the chairman of ENT at Harvard. And he said at that time about cochlear implants, that otology needs a new operation, but this is not it. And there's a famous electrophysiologist from Germany, Rainier Klink, said, from a physiological point of view, cochlear implants will not work, right? But against all of these naysayers, right, Dr. House said, let's just give it a try. And he told me he had to start really from scratch by selecting which material is biocompatible, so that we can put that material inside somebody's head and will last a long time, right? It took him a while to figure this out, and he started with a copper wire, and this is a single channel cochlear implant. Very simple device. It's just a coil, right? And the 2 wires coming out, and one of the lead coming out, he inserted in the inner ear, and the other put in the temporalis muscle behind the ear. And there's no active electronics involved here. The outside processor is also very simple. There's another amplifier, microphone, and a battery, and they deliver 16,000 hertz carrier tone. However, with that device, he was able to demonstrate it's safe, and he implanted about over 1,000 users in the United States, and received the first FDA approval in 1984. But the efficacy, was in great question at that time. People thought, did a cochlear implant really work? And the question was, did it work better than hearing aid? or it didn't work better than even a tactile aid, right? Vibration, right? And what we try to measure, whether a device works very well, is to measure the sentence recognition in quiet. If you can understand 70, 80% of the sentences, and that will allow you to carry on a conversation. In the earlier days, when Dr. House built his single channel device, and on average, that device didn't provide much, we could open set sentence recognition. It's about a single digit. Maybe a few star users can perform at 50, 60%, but the majority, right, was at 0 or 5, 10%. However, there are two important things for even that simple single channel cochlear implant. One, it allowed the user to better liberate. The single channel cochlear implants plus lip reading will give you about 30, 40% speech recognition, and that's very significant, right? The second usage of the single channel cochlear implant was to provide awareness of environmental sounds. Imagine how important it is. Somebody knocking on the door, a car approaching you, or fire alarm went off. And the debate was basically between Bill House and Dr. Graham Clark from Australia. Dr. Clark was a firm believer in multi-channel cochlear implant. And he looked at the psychoacoustic literature, and it says there's about 22 critical bands, right, functionally. And he said, maybe we should make a 22 electrode cochlear implant, right? And he did, right? And however, the US manufacturer, a company named 3M, didn't really buy it. And instead, the 3M supported Dr. House's single channel cochlear implant for its simpler, safer at that time, right? And perhaps a more effective design. We couldn't really tell at that time whether single channel implant is better or the multi-channel cochlear implant is better. So there's a lot of debate going on. Nevertheless, after 10 years or so, if you look at the speech performance, roughly speaking, the sentence recognition in quiet was about 10, 20, or maybe 30%, right? And remember, all devices have their star users, and the companies will bring in their star users to the conference, and that's really make people confused, which one's better or not. The real breakthrough in terms of improving speech performance came from signal processing, more or less in late 80s and early 1990s. And a professor from Duke University, and he was at Research Triangle Institute, right, Blake Wilson, right? And he changed how the speech is processed and delivered to the cochlear implants. And that make the speech recognition in multi-channel cochlear implant from about 20% to 70, 80%. And that's a magic, a critical number that allow children to develop language. And that's also allow adult speakers, post-lingually adult speakers, to carry on conversation on cell phone. So looking back, and we're trying to justify who contributed what to the success of cochlear implants. And I'll say a little bit more later, but I think these three people I present on the screen for you, I think they probably made the most and deserve the most credit too. And of course, from 0 to 1, and we know that's perhaps the most difficult and also significant. And I will say Dr. Bill House was, no question, was the person who brought electric stimulation, right, and make it feasible and safe, right, for the development of modern cochlear implant. And of course, the hardware development from a single channel cochlear implant to 22 multi-channel cochlear implant. Dr. Clark deserves that credit. Right? And then improving speech performance to a level that allow open set speech recognition. And Blake Wilson, among others. Now I'll say a little bit more in the next few slides. Right, deserve that credit. So idea 0 to 1, Bill House, hardware single to multi-channel implant, Dr. Clark. Speech performance from 10 to 100 or 70, 80%, Dr. Wilson. Now, looking at where we are now, and then look back and why cochlear implants becomes the most successful neuron prosthesis, right? And what are the failures? And I know today I'm talking perhaps mostly the ENT doctors and audiologists, but I'll give you maybe a flavor from the engineering point of view, and hopefully you would appreciate it. The first thing I would say, the success of modern cochlear implants is deeply rooted in speech science. And in this case, if you're a speech scientist, we can divide speech into envelopes and what we call a fine structure. And Professor Gunnar found, right? He was the person who kind of figured this out. And this is your 1 minute speech production class. The way we would talk, right? There's a source. Either we vibrate our vocal cord or we push the air out without vibrating it. So you have either noise source, we call the voiceless sound, or you have a voice, then you're vibrating, right? That's the source, that's the fine structure. And the so-called speech envelopes, right? They are your vocal tract, depending on the tongue position, whether you close your mouth, you open your mouth, and where your nose is. The nasal cavity is closed or not. And that gives you the different resonance frequencies. We call the formants, and which is described here. Now, in this case, maybe a vowel like ah, right? It comes out without any particular resonance. But after passing that source through the vocal tract, and you will have a different resonance. The smaller, the higher the resonance, the bigger the cavity, the lower the resonance. And this is a spectral envelope. This is what we call source filter or fine structure envelope speech production model. And Dr. Gunnar found demonstrated in 60s. He said, speech quality is determined by mostly the source, the fine structure, whereas speech intelligibility is mostly determined by the speech envelopes or the formants. And I'll present a sound. In this case, is original, and I'll make sure you make your volume not too high or too low. I'll play it.
A large size in stockings is hard to sell.
So this is original speech, right? And we can keep the spectral envelope identical, but we can increase the fundamental frequency. And in this case, what you're going to hear is a voice, maybe more sounding like a female, but the intelligibility is unchanged. And I'll let you hear this simulation of doubling the fundamental frequency without changing the formants or envelopes.
A large size in stockings is hard to sell.
Right. And of course, I can replace this source vocal tract vibration with a noise. And that turns out to be what we call whispered speech. And it may sound a little bit like a whisper, strange, but when it comes to understanding of speech, and you shouldn't have any problem.
A large size in stockings is hard to sell.
Right. So that's a simple demonstration. Said that if you just want to deliver speech recognition, you can forget about the speech quality. You can just focus on the speech envelopes. And that's the early strategy that the cochlear implant developers focused on. And that wasn't very successful. And the reason for they're not very successful, and I'll give you a clue, but I'll tell a little more. It's the mismatch between the electrode array and the tonal topical organization in the ear. So even though we know from speech scientists like Gunnar found, speech envelopes carry intelligibility information, but implant users didn't do very well. We're just scratching our head, and then we went to a different route. The different route was instead of looking at a spectral envelope, the envelopes in frequency domain, maybe we should look at envelopes in the time domain. And that was the time we look at. And anytime, when we say temporal envelopes, it's essentially the energy fluctuation. Sometimes a little more energy and a little bit less, right? And if you just look at it, replace this temporal envelopes and then modulate that envelope to a noise. And this is a spectrogram, says ShuCAD. And originally, you will see the harmonic structure like ooh, and the formant transition here and formant transition there, okay? But if you can extract the envelope, but modulate a white noise, for example, and the spectrogram will look like that. Of course, when you have energy, more energy here, and the noise seems to have more energy, and quiet, you will have a quiet, before there's nothing there, right? But if you look at these, one channel or one band, temporal envelope, and you'll say, where are the harmonic structure? Where are the formants? Where are the formant transitions? I don't think you will find any, right? And do we need like 100 channels? Well, when Dr. Shannon and I at the house, we did that research, and we just said, let's do one, and we can split this into 2 channels, low or high. Even 2 channels, you can see like a shh, mostly high frequency. Hey, and you can see this is tell you this is probably like a high frequency, and it's more likely a frictive. Or we can do 3 or 4, even with the 4 channels. And if I ask you, tell me the harmonics, tell me the fundamental frequency, tell me this formant transition. Now, none of them is represented, right, in this 3-4 channel envelope, temporal envelopes. But what surprised us was that you don't need a lot of channels. And this is the data. Just focus on sentence recognition, panel C here. Percent correct from 0 to 100% as a function of number of these channels and a spectrogram showing on the left. With the 1 channel, and this is very similar to Dr. Bill House's cochlear implant results. You get about 5 or 6, single-digit percent correct. 2 channels, not much better. But what really surprising, really surprising to us and to most people at that time was you only need 3 channels, maybe 4. You get almost 100% speech understanding. That's very important. It basically tells the cochlear implant developers focus on temporal fine, forget about a temporal fine structure, just focus on temporal envelope cues. And 3 or 4 channels, if you can deliver that independent channels, you're okay. And that's what motivated. And of course, that time was very exciting. I remember, we went to meetings, everybody just presented data hot off the stove and showing compare notes, right? And Blake Wilson and colleagues, right? And they say, how do we use that speech knowledge right, to actually implement the temporal envelope cues in the actual cochlear implant. It's not as simple as we thought. And the earlier researchers, and some of you guys, if you're old enough and you heard about InterRate, right, the analog device, and you can just say break speech into 3 or 4 channels and deliver the analog waveforms, and that didn't do very well either, right? So what Blake, he had, and the colleagues, they had to do. First, you have to divide speech into different bands, right? And you have to be able to accurately extract the temporal envelopes, because speech dynamic range is much bigger, 40, 60 dB, but a cochlear implant dynamic range is much smaller, 6, 10, no more than 20 dB. So you have to compress. How do you compress, right? Logarithmic seems to be the magic mapping. And then the electric field, they will interact with each other. So you may have 22 electrodes, but the electrodes crosstalk, right? They interfere with each other. How do you overcome that? And Wilson and the colleagues, he said, well, maybe each time I'll only present one electric pulse, and then the next electric pulse will have to come on after the end of the first one. So they stagger them. They call it interleaved. And that's a very smart way, right, to avoid simultaneous electric stimulation, right? But then, yeah, I mean, now looking back, it all seems easy. But they say, well, you got your envelope, but how do you accurately represent that? I talked about the logarithmic mapping. And the carrier frequency, right? There's this Nyquist theorem, right? The carrier rate has to be 2 times of envelope frequency. So all of the details, right? None of them, if you don't do it right, your speech performance won't be very good. After this very detailed, systematic, right, characterization and evaluation, right? Not only do we know from scientific point of view, temporal envelope cues can provide sufficient information, but also we have to develop appropriate strategies, electric stimulation, these single pulses as a function of time and across electrical array. After you do all of this right, and now in this case, they were able to present or produce speech performance from 50% to about 90% in this group of subjects. All right. Now, that was the successful story. And when we transferred the basic research into a commercial successful device. But why cochlear implants? We're talking about modern cochlear multi-channel implants. I saw why they can do better. Well, one of the first things we learned is electrode array. Electrode array does not equal tonotopic organization. This is a familiar figure, right? You open up the cochlea and you insert, in this case, as an earlier device, the ring electrode, right? 22 of them. And we thought there's a place from base to the apex. If we figure out the frequency map, and we should be okay. But I'll tell you, in practice, in realistic situations, it's never the case. And I'll show you some examples. Right? Sometimes when the surgeon insert the electrode array, maybe initially everything went smooth. And then you feel a little resistance, you push a little bit more, guess what? Instead of this keep going, you bend the apical part. Now you tell me an electrode position is the same as your frequency? Of course not. Effectively, these 2 electrodes are identical, right? Or worse yet, sometimes when you push it, right, and you feel the resistance, you keep pushing, you got a basal fold. It's all these electrodes near the basal part of the array, they just tangled, and there's no electrode to frequency or tonotopic organization whatsoever. And electric stimulation by itself is generated, think about the point, it generated electric field. It's a big circle. By extending that circle, right, you stimulated the nerve. So one little electrode here, right, that's a physical electrode. How you stimulate the nerve, is that not a physical platinum plate? It's the electric field it produces. It's much, much, much bigger than the platinum electrode array by itself. Even worse, cochlear implant users, especially in earlier days, they're deaf, and some of them have been deaf for a long time. And on the left side of this spiral, right, this is a healthy, you have inner hair cells, and each inner hair cell, you have 10 to 20 nerve fibers connected to it. But if you are deaf for 30 years, maybe you only have 10% of neurons survive. Maybe there's nothing near the base. So imagine if you have a perfectly inserted electrode array, and you may not have any neurons to stimulate. And that's why cochlear implants cannot really deliver this, tonotopically matched information. And that's why modern cochlear implants, and they do well in speech, in quiet, but not very well in some other things. The other thing we thought electric stimulation can do very well is the temporal firing rate. And what shows here, this is a synchronization as a function of a stimulus frequency. And there are two sets of data. Just look at it. This is acoustic data, pure tones. So what the physiologist did, poke electrode, attach them to auditory nerve fiber. And you change the pure tone and increase the frequency from 100 hertz all the way to 10,000 hertz, and see whether they can synchronize, right, to your input frequency. For acoustic hearing, you can do reasonably well below 1,000 hertz, and the maximum you can do maybe 5,000 hertz. Electric stimulation, on the other hand, they are super synchronized to electric stimulation. You can push the temporal synchrony all the way to 10,000 hertz. If our brain can use that temporal synchrony in response to electric stimulation, then we would predict, cochlear implants using high rate stimulation will be able to give us beautiful speech recognition. But that's not the case at all. And what's surprising was, and this is a simple representative data from an early study I did, right? We can give them electric stimulation as a function of rate from very low to very high. And in this case, one delivered to apical electrode called A, and another delivered to basal electrode. Doesn't matter. The pitch will going up, but it will saturate at 3,000 hertz. Even your stimulation can be 2,000. We tried 3,000 or 5,000. The pitch doesn't increase. It's saturated about 300 hertz. So there's a huge mismatch between what we see physiologically at the auditory nerve level and what the brain is able to perceive. There's a huge match between the two. And because of this mismatch, and I concluded in 2004, and I basically said, we have not been able to reproduce a simple pure tone sensation in cochlear implant users. You can forget about harmonic and the music perception. And I said that almost 20 years ago. I stand by my statement today. To give you a lot of flavor, right? What a normal hearing listener can do, and what a current cochlear implant user is able to do. Speech in noise. There's at least 100 times difference. We're talking about 40 dB difference. right, between what a normal hearing listener and a cochlear implant. And the music perception gap, we're not talking about very sophisticated orchestra level, just simple melody recognition, right? There's at least 10 times, if not more. And I'll present a lot of simulation for you. So you can appreciate where we are, what an average cochlear implant listener can understand or can appreciate music. We're far away from there. This is data we actually collected from real cochlear implant users, and we're able to generate acoustic simulation, right, for you to listen. And you can try to see what the music did I play, instrument, melody. If it were live audience, I ask you, raise your hand and tell me what you hear, right? Most people will say, oh, like a drum, right? You only hear rhythms, right? I'll play the original so you can appreciate how far we have to go if we want to restore normal hearing. So implants have been able to restore partial functional hearing, right, for over 1 million people. We have a long way to go, right, to bridge the gap between normal hearing and cochlear implant hearing. So what are the challenges and opportunities? So in the next 10 minutes or so, I'll present at least 3 challenges. And one of them, I love history, and this is one of the things I started doing. Let's look at the publications in cochlear implant field as a function of time. And what you saw here, earlier days, we have a single digit. Dr. House published the first one, 72 or so, right? And we have talking about 10 to 20 papers. But that exponential growth started in 1990s. And that's the time when CIS, not only the multi-channel came on board, but also the speech processing was standardized, and people see the real benefits. And a lot of people got into the field. And I remember when I graduated from Syracuse in 1990, and I just got bored doing this pure science, and I asked my advisor, and Chris Turner and Joe Zwislocki, and I said, I want to go do cochlear implant and to go to House Ear Institute. And they look at me, are you crazy? That's a really black hole. You may get in and you will never get out. And because at that time, no serious scientist wanted to put their name, for something that unproven. But the history is interesting. Once implant becomes successful, and all of these researchers, including my own advisor, came to join me in this cochlear implant research. So the point I'm trying to make is, we have seen that exponential growth in number of researchers getting into the cochlear implant field, and the number of publications published as a result. And last year, we almost published over 1,500 papers. And that's how much we paid for that number of papers, $200 million at least. And the Cochlear spent, by the way, $100 million annually for their R&D. And then you ask the next question, what did we get out of that investment? Well, look at the right axis, the speech recognition inquiry. And in the figure I showed you, speech recognition from early 90s, almost 0% to about 70, 80% in early 90s, despite all these publications. And that number, the level of performance in speech or sentence recognition inquiry has not changed, Even today, right now, average performance about 70, 80%. I blame the electrode design. I think that's the main hurdle we have to overcome. If you look at the first multi-channel cochlear implant in 1986. This is a straight electrode with a 22 range. You know, this is what we have today, right? Instead of ring, we replace with them plate. Instead of straight, it's curved, a little bit thicker. This is a little bit smaller, but the fundamental design of this electrode array has not changed at all, at all. I don't care what you want to do, as long as this electrode interface stays the same and we're going to stuck there. Right? Here's the reason why. This is a section of a cadaver, a cochlear implant, and somebody passed away, and we were able to get a section. This is scala tympani here. This is an electrode carrier right there. Okay, this is about a 0.5 millimeter by 1 millimeter in dimension, and this is the wires, multi-channel wires. Where are the auditory nerve fibers we're trying to stimulate? All right, look very closely. This is the real dimension. Basilar membrane right here. This is your inner hair cell, 3 rows of out hair cells. This is your dendrites. This is your ganglion cell bodies, and of course axons going out, to the brain. I have to really amplify that for you so you can see that mismatch between the electrode to neuron interface. Do the numbers. We have a normal hearing listener have 3,000 inner hair cells, and most we have 24 electrodes in the cochlea. If you look at the diameter of the electrode, it's about 1 millimeter. And if you look at the diameter of the dendrites of the auditory nerve fibers, 1,000 times less. Okay. How can you use that big, humongous electrode to selectively stimulate that small neurons far, far away? There's 0 chance for the current cochlear implants to do, as long as we keep using the same design. The second challenge is the power, right? Again, I don't have time to talk, it's 10 watts. The best cochlear implants these days, the power consumption is about 10 milliwatts. If you look at our inner ear, the normal cochlea, how much power does it consume? About 10 microwatts. What does that mean? A 10 microwatts, give me a AA battery, it will last for 14 years, 14 years. On the other hand, the same battery, if you use it for a current cochlear implant, which consumes 10 milliwatts, will last for a couple of days. The third challenge we face now is accessibility. Average cochlear implant cost about $50,000 device by itself. And that, compare that with annual income, right, in a low income country in Africa. The annual income is $500 a year. You're asking a family, don't eat for 100 years, put all their annual income. It will take 100 years for them to get a cochlear implant. And that cochlear implant is 2 C-class Mercedes-Benz. That's impossible, right? So, when I started a company called Neurotron about 15 years ago, I said, why don't we make an implant? We can lower the price, but not performance. And took us a while, but we figured out, we used the Apple model, Apple Watch, Apple cell phone model. We did R&D in the United States. We manufactured in China. And this is a device. And we did a very systematic clinical trial. And we compared across, not our device, but against the 3 major manufacturers. Just look at the numbers, sentence recognition, about 70, 80%. It's no different. But what I'm very proud of, because of this new cochlear implant, we're able to drive the government contract program. The unit price, when the Chinese government first started their tender program to help their deaf children, right, get a cochlear implant, the unit price in 2011 was $40,000. 40,000 US dollars. Neurotron got into the market in 2012. Took 3 years, get the first 500 implant users. The Chinese government said, okay, you guys can enter the tender program. You can bid for it. And look at where the price now today. We're talking about 4,000 US dollars. It's 1/10 of the cost what it was 10 years ago. And what it means is, if government spends the same amount of money 10 years ago, you can give one deaf child a cochlear implant. Today, you can give 10. But that only happened in China, not elsewhere. So where are the opportunities or challenges? Well, I think when I look at these, I said, cochlear implants, you look at, we haven't changed our electrode design for the last 30, 40 years. And we're so conservative as enterprise ourselves. We never even ventured to our neighbors. If we can cure deafness, what about the people balance with the dizziness? What about tinnitus? Not to mention the same device can be used for many other neurological disorders. So we need to develop new technologies to improve performance. I believe we have to develop high density electrodes with maybe not 3,000. Can we do maybe 100 or 200 electrodes? And would they qualitatively change the performance? We call it a quantum leap. I think without that high density electrodes, no way will we be able to achieve that high performance or bridging the gap between normal and prosthetic hearing. Battery size. People have developed very, very reliable, safe, high density batteries. You put it in as a pacemaker or other things, it will last for 5 or 10 years. We've been talking about a totally implantable cochlear implant, been talking for a long time. Where is it? Can we have always on? Maybe atraumatic insertion. Technology is always there. And finally, I said, this is what Dr. Bill House, he actually founded a company called All Hear. He will say, we all hear, but I will say, not only we all hear, we have to hear well. And what does that mean? And I will conclude my presentation today by showing you a beautiful Beethoven's Ninth Symphony, where you have 100 people singing and 100 pieces of music. If you pay attention, if you have a normal hearing, you can hear each individual singer and perhaps each individual instrument. And to achieve that level of performance for us, cochlear implant developers, right? This is what restoring normal hearing means. And this is a short video clip. And I'll play it for you. thank you very much for your attention. And if I have any questions, I'll be happy to address them.
If there are no questions, may I say thank you very much, Dr. Zhang. We really had an excellent presentation. And that presentation has added so much to our information. We know cochlear implant development is a tough task. We don't want to go backwards by going into the analog type. We want to increase our activities towards research and development for far better hearing than what it is today. And I do hope that with the joint efforts by all concerned, we will make what we want and our dream will come true. Thank you very much.
Well said, sir. I agree.
Thank you.
Thank you very much, Dr. Fan Gang Zheng, for your excellent address. And I would also like to thank Dr. Professor Hoza for chairing this scientific session. So we'll move on to the next topic today, that is the panel discussion on bilateral cochlear implantation. Can I have the slide of Dr. Neelam Ved? So Dr. Neelam Ved will be the moderator for this panel discussion on bilateral cochlear implantation. It is an integrated panel where there are surgeons, audiologists, and habilitationists as the panelists. So Dr. Neelam Ved doesn't need much introduction. Everybody knows her very well. She is an internationally recognized speaker, and she is involved in both international teaching related to cochlear implantation. So without taking much time, I would like to give over the platform to Dr. Neelam Ved to conduct the further proceedings of the panel discussion. Over to you, Neelam.
Thank you so much, Shankar, for the introduction. And at the outset, thank you to the organizing committee of this meeting for giving us an opportunity to share our clinical expertise and knowledge with you all. Following that talk by Dr. Zheng, believe me, I'm a little skeptical about what we are going to be able to say, but let's go ahead from here. I would at the outset like to introduce my team to you for today. Can I move my slides forward?
Yes, doctor, you can.
I'm screen sharing. Is my screen visible?
Yes, ma'am, it is.
Yeah,
the screen is visible.
Yeah, okay. So my team, as Shankar rightfully said, we consist of audiologists and speech and language pathologists today. Predominantly, they are outnumbering the surgeons. We have two surgeons. We have Dr. Jagini from Sikandrabad, and we have Dr. Sharma from Gangaram Hospital, Delhi. The audiologists and speech language pathologists who are going to share their experience with us today, Fatima, Neelu Somani, Rashmi Deshpande, and Sanjay Munjal. From different parts of the country. We have Fatima from Mumbai, Neelu from Nagpur, Rashmi from Bangalore, and Sanjay from PGI Chandigarh. So let's start right from the word go. I think we all know this. Evidence tells us this, that 2 years are better than 1. And what we've seen among the various presentations that we've heard, and even what evidence has showed us, is that the places where these children really do well is better improvement in sound localization, understanding in noise, music perception. And these are the advantages that the literature tells us is there. And there's this famous publication that came out as far back as 2007 by John Murphy that kind of collaborated what I'm saying now. So literature says that binaural performance is definitely better than monaural, as we said, in localization and speech perception. And that window of opportunity for a person or an individual to be able to integrate sound from both sides apparently closes at 12 years with auditory system reaching maturity by then. So most of the consensus, and especially the one that's recently come out from Europe, says that bilateral implantation should be the standard of care for bilateral symmetrical hearing loss. I'd like to know the views, and let's start off by Rashmi on this, that what is your opinion about this last statement that bilateral implantation should be the standard of care? And is it something that we should also stress and focus upon in India? Rashmi?
Thank you, ma'am, for the question. Ma'am, I think we should be focusing more on binaural hearing. We look at benefits of binaural hearing. There are a lot of benefits of binaural hearing. So yes, that should be the standard of care. But bilateral implantation, that is something that we need to look at what are the factors involved and then decide whether that is something that we have to offer to the patient and what are the issues that might come along with it.
Sanjay, do you have anything to add to this?
The bilateral implantation should be the standard, but keeping in mind the Indian conditions, I think bimodal would be more feasible. And there is sufficient literature to show that this bimodal hearing does provide additional benefit. There have been many studies. The study conducted by Moreira et al. And then by Ching et al. In 2007, I think in NAL, showed that there are certain benefits. And in fact, Schaeffer et al. Conducted a meta-analysis also to show the benefits of bimodal versus the single cochlear implant. And they found that there was improvement in hearing in noise as well as localization when there was a bimodal hearing. So I think keeping in mind, I think whenever the conditions for the bilateral are not fulfilled because of economic reasons or the other conditions which we know there are, so the bimodal should be the choice if the bilateral is not feasible in that particular case.
Yeah, so a good take-home message here that, let's not just focus on implantation, but the aim should be that the person or the individual should be integrating sounds from both the ears. So let's look at binaural hearing, and the modality can be different. You can use either hearing aids, you can use cochlear implants. That modality can vary according to a candidacy and patient, but I think the aim and the standard of care should be binaural hearing. So let's start off with, we know evidence says, yes, you should do this. You should give all our hearing impaired individuals a chance for binaural hearing. But since today's focus of discussion is bilateral cochlear implantation, when would we as clinicians say no to a patient that even though you have the motivation, you have the economics, but I don't think we are going to go ahead with bilateral implantation? Could I have the comments of Dr. Sharma on this first, please?
I think, hi, good morning, everyone. Saying no to a patient for bilateral is not something that we as clinicians really want to do, but there are certain situations that do come up. I think primarily I would look at two from the Indian context. We have one is the financial context. If you have a patient who is going to essentially end up breaking their bank, trying to bankroll the payments for two implants, and they're also looking for funds, then I would usually ask them to not consider a bilateral, get a unilateral and then see. So that's not something I want to do. And the other thing would be in the case of cochlear abnormalities, where especially in the thin nerve cases, where I would be very hesitant I would choose the better ear, tell them to get the better ear done, and then take a call which ear. I mean, that we should just do one ear. And also if the responses, if you have a patient who has some abnormality, responses are recorded from one side, no responses from the other side, I would suggest them also that they should go for unilateral first. And then if we are seeing if we are seeing results, hearing, solution, then we should consider the second.
Okay. Neelu, would you like to say something on this?
Yes, sure. In my clinical experience, I would say not a no, but rather encourage or discourage is the word that I would use, because finally the decision lies on the parents when they say, okay, I don't want it. There have been incidences where in spite of
counseling them that, look, this is not going to be really that great, and the outcomes or whatever, discouraging them in a way directly, they have taken the decision to get a second cochlear implant for their child. So certain things, yes, if there is clinically speaking, if there is a good amount of residual hearing in the other ear, and which we are monitoring over a period of time, and we have good aided responses in a typical bimodal fitting, yes, we would really not say yes, even if they have the information that two cochlear implants work best for my child. That would be one of the scenario. Another scenario, of course, would be like I would evaluate, as Dr. Shalabh Sharma said, many of them, they come with this information like, I've heard about it, I want it. And now with the companies, who are constantly reaching out to the end users, like, look, you got to have get another implant or whatever, doing a marketing, they come up with this requirement that, okay, please evaluate my child. But if we find that the sustenance and the maintenance of the current device itself is compromised, how would they go ahead with the other one? So that would be one of the reasons to consider the financial constraints in actually, counseling them or steering them towards a second cochlear implant. So these are the 2 points. Yeah, thank you.
Fatima, do you have anything else?
Yes, I would say that when in my practice that if the child has complex needs, so we would be very careful. I mean, even if the parent wants to go in for a bilateral simultaneous right away, we would ask them that at least get one done, let the other therapies also roll in, and then we can talk about the second year getting implanted. So that's very, very important. And as what Neelu said, that since they are now a lot of, internet literate, they've read a lot and they know 2 is better than 1, and even the companies reaching out to them because they log on to their websites and all that. So it's our duty to educate them, and finally, yes, the decision lies with them.
Dr. Jagani, what about infections? Do you really say that do we think about it? Is that an absolute no for you? How would you counsel a patient about if he has an infection in the other ear?
I would not directly say no to any infection, but I would definitely consider controlling the infections before we go in for bilateral implants. More so because in children, the eustachian tube dysfunctions are so common. We have to try to take care of the infection before we think of bilateral implants. As we might have to do sometimes even meringotomy, grome, wait for everything to settle down till the grome comes out, patch up, and then do many instances we have done like that. So I would take care of the infections before we advise bilateral implants.
Yeah,
Just
so
I wanted to add on these anomalies. I would not directly say no, because sequential can be done in many of the cochlear and neural, probably simultaneous no for many patients, but sequential bilateral, many of them need and should be done after taking proper precautions and telling the parents about the guarded prognosis.
Great. So let me just quickly summarize on this. So let's say if a patient has cochlear and neural anomalies, a patient has developmental issues, complex needs, infection in the second year, we are looking at a sequential. We're not maybe looking at a simultaneous. We're looking at the fact that we are going to, talk to these families, see how they're going to progress with the first, and then consider a sequential. But with maybe an aidable residual hearing in the second year, with economic issues, and high expectations, we are like taking a step back, as Neelu and Fatima said, and saying, we need to rethink this and maybe not go in for a bilateral. So in 3 of these, yes, we are going to say bilateral, but we're not going to say now, we are going to stagger it out. In the others, we are going to say, maybe no, let's just keep you waiting for that. Am I okay with that? How many of you pay a lot of focus on high expectations? How many of you would, take a step back? Sanjay?
Yes, of course. See, once the second implant is done, so the expectation level is quite higher. They feel that the child would be normal in all aspects of audition as well as speech and language abilities. Okay, so plus because they have put in so much of money, the expectation level go very high. So that is I think would be the one of the prime factor which has to be kept in mind when advising them for the bilateral or the sequential bilateral. So that I think in our clinic also we keep that as one of the top criteria or the factor which has to be, which is quite
a
important.
cost benefit ratio is something that you're going to really compare. Rashmi, you wanted to say something?
Yes, ma'am. Ma'am, I'd like to say, especially when it's coming to children, so we see maybe the child has got the first implant young, and then after a certain amount of gap, when they have gone to school, they might not be performing that well at school. The issue, what is happening is that the message that is right now going across is that if you get the second implant, this child might be having some issues at school, which is going to be magically solved with the second implant, which is not really the case, because yes, a second implant will help, and binaural hearing helps a lot in central processing and is going to give good benefit to this child. Whether that translates into, let's say, mainstreaming or benefit in school, or that kind of effects, that's something that needs to be really evaluated, and we need to see what the issues the child is facing. If we have to have a balance between the issues, what we can provide, and the expectations of the parents. In our clinic, we get a lot of parents who come in saying that I want a second implant because somebody has told me that if I do get a second implant, my child is going to do well at school. Well, like I said, that is not really what should be motivating them. And we are not going to provide this to the particular child and individual. So we need to be really have a balance of what the child is lacking in, what we can provide, the expectations of the parents. So there are a whole lot of
So a
factors will have to be
realistic,
taken.
yeah. So a realistic approach.
Yes.
Nilu?
Yes.
Yes. So I would say again, as I said earlier, it's not a no, but it's about realistically evaluating the expectations. I wouldn't really call expectations as high or low, but they have to be realistic. Expectations are bound to be there, not only from the clinician's end, but even from the parents' end. So I feel it is, again, we're looking at simultaneous versus sequential. When we are doing a simultaneous bilateral cochlear implantation, we would have gone through the entire process and the procedure and the questionnaires which are there, and setting up a realistic expectation. Even I, as a clinician, I will definitely have some expectations from myself and from this child that I'm going to be now going to facilitate. So coming to so what I mean to say is that expectations are bound to be there, but we really need to go the objective way assessments with questionnaires, and we can use the COSI, we can use the SSQ, and we can really come to a point where we are not really saying a no, but then yes, going ahead either with a simultaneous or with a sequential bilateral.
Great. So basically, again, the same thing, realistic, get them down, to ground and start out right from there. When, Fatima, we'll just go ahead. When would you recommend a second cochlear implant in children with residual acoustic hearing? We had the first point where we said, acoustic hearing, which is good, residually, you won't go ahead. So Fatima, would you like to take this on first? That when would you say, okay, even though you have so much residual, we are going ahead?
Yeah, so when we have fitted the child, as I said for the previous one also, when we start counseling a child for a CI, we need to ensure as clinicians that we are going to counsel them for a bimodal, keeping all the economics in mind. Now, when we fit them with the bimodal, the hearing aid on the other
Fatima,
side.
let me just interrupt. This is a child who's had a cochlear implant in 1 year. He had some residual hearing in the other year. So you were giving him bimodal hearing. But now you're saying, no, let's think about a sequential CI.
Yeah, coming to that. So we are monitoring this child over a period of time as to what is his performance with our audiological test battery. Moment we see that the child is plateauing first, so we try to see why the child is plateauing. Secondly, we try and evaluate the other year, okay, how is the performance of this child in high frequencies, because mainly the performance in low frequencies is pretty good, and we are happy with that. The mother also says he's using the hearing aid well. But when we see a dip in the performance in the high frequencies, that is the time we start counseling them that you need to start considering an implant in the other year.
So you're basically looking at, more of responses behaviorally in the high frequencies, maybe using, I'm assuming the Ling or by doing audiometry. Sanjay.
Speech audiometry.
Speech audiometry. Sanjay.
See, the thing is, when there is like now the cortical potentials can be used, like yesterday Dr. Anu Sharma talked about the wave P1, when there is the normalization of the latencies is not taking place with the bimodal. I think that would be the time we could go ahead with the cochlear implantation in the ear with the residual hearing. That is one point. Other is that yes, when there is no measurable difference in the speech perception scores with the hearing aid in the other ear, so that could be another factor when it can be thought of that the child should be implanted in the other ear. Plus, of course, if the parent, there's a perception in the parents that yes, they find that as such hearing aid is not providing the additional benefit to the child in terms of hearing. So I think that could also be taken into consideration for going in for the implant in that ear.
Yeah, so what I understand here is that there are two things. There's one which is a subjective information that the parents tell us that the child is not really performing well with the hearing aid. But objectively, when you looked at it, like Fatima said, she's going to look at speech scores, and she's going to look at the fact that the child is not responding well to high frequencies. What would be your response to this publication, which has just come out in 2020, which says that if children have a better ear pure tone average, which is less than 73 decibels, they do well with bimodal? Rashmi, can I have your take on that?
Yes, ma'am. So there's a lot of research, and now they in fact got it down to almost 70 dB, where they're saying that only if we see that it's under 70 dB, then there'll be a benefit. There's another way to evaluate it in the sense that when we are looking at the performance with, let's say, called C1, the first CI, and then we are doing it with the hearing aid on the other side. So we are trying to look at it separately, but we have to look at the binaural advantage that it's providing, but the bimodal advantage that is providing for the CI plus the hearing aid. If we feel that at a particular point of time, it does happen when they're plateauing, where we see that the benefit that we're seeing with binaural tends to drop, and the hearing aid actually kind of the benefit with the hearing aid sort of interferes with the benefit with CI. So when we see that the CI plus hearing aid, we are not seeing that benefit, or the benefit is reducing, is when we would practically start discussing along with the other points that everybody has put up, that we are monitoring regular progress because we'll be seeing these child in therapy. So everything combined is what we would tend to look at. But yes, under 70 is when I think we actually see a benefit. Otherwise, there's no binaural summation, there's no binaural squelch effect, there's no central summation of actually. So there are no true binaural benefits if it is more than 70 dB. So we really have to be careful. I mean, it's just not putting about the hearing aid, but getting a benefit together.
Yeah, so great. So we are coming to some sort of a consensus here that, okay, even though, let's say objectively it's showing that it's less than, or the audible hearing is less than 70 decibel, but subjectively you are not happy, the parents are not happy, you're not seeing that much of speech performance, then you will think of counseling this patient for sequential. How do we as clinicians tip the scales? How do you really manage to convince families that, okay, go ahead, you should go ahead for a bilateral implantation? Dr. Jagini.
You mean the surgery part of it, or?
No, this is a family that's walked into your clinic, bilateral, severe to profound hearing loss. It's a child about 2 years of age. How do you convince this family and say, let's think about a bilateral?
Yeah, I would try to counsel them saying that if the aim of the parents, like all the parents have, is the child to be as normal as possible, compete with everyone and be everything normal. So the nearest to the normal you can get is only if you have binaural hearing. So I would try to convince them, if everything else is favorable, they should go for bilateral implant, if possible, even simultaneous, because of the critical period of hearing, which is important, that between 1 and 3 years the child gets acoustic stimulation. So explain them that the only way the child can be almost normal is if they have good bilateral hearing.
So you will, sort of counsel them saying that your chances of becoming near normal are best if you go in for bilateral.
Yeah, correct. At the same time, tell them unilateral hearing is also very beneficial, but wherever possible, we should give them bilateral hearing.
So Neelu, what is it that you would try and motivate them with? What is it that you will tell them are the advantages?
Can you please repeat the question for me? Sorry.
How would you motivate your families to go ahead for bilateral implantation?
Yes, so I look at it, there are two kinds of families, one who are self-motivated and the others like where you really have to get to them point to understand that, look, your child needs a bilateral and that's the process. The ones that they are self-motivated though, but coming to a point or a decision that, you know, you need a bilateral, we really need to have our periodic assessments in place. And here I would like to mention that the 70 decibel residual hearing, what shows in an audiogram, may not really be converting into a functional benefit in a particular child. And we could also see that there is what you call progressive hearing losses coming in. So each case has to be evaluated case wise since the time the first implant has been done. And definitely the motivating factors would be falling out on the performance. So that is what, like, we could see some soft failures happening even with the current cochlear implant that the child is already having. It could be either with a unilateral, it could be either with a bimodal kind of a fitting. And as the child is growing up, his hearing needs are changing. He's getting into more challenging environments. And the parents are really coming up and telling us, like, I have this experience where they tell me, okay, ma'am, please do the mapping. You know, he's not listening this way. I think there is something to do with the processor. Please check the processor. But actually, these are issues with, you know, hearing with 2 ears and not with just like hearing with 1 ear. So when the child is ready for a school readiness and when he needs a better signal to noise ratio, that is where the challenges are coming in. So I would really look at these changing environments of a child and accordingly like motivate them for a bilateral implantation. And even music perception is what many parents they look at because they want their young babies, young children to enjoy it. And for me, these are the points. Yes, thanks.
Fatima?
Yes, so most important is to you need to explain to the parents the benefits of what a normal binaural hearing is and what your child would be missing if it is just unilateral.
So Fatima, to cut you short, what is the point you'll tell them they are missing with a unilateral? Let's
yeah, so it would be improved quality of life, localization of sound, you know, even helping them to get into mainstream school because that way incidental language learning would be more. So their language, as a normal child develops so much of words in the vocabulary per year. So if the child is aided in both the years with an implant, so even that scope the child gets of, you know, coming at par with the age appropriate level.
Okay, Sanjay, anything else you'd like to add to this?
I think most of the points already have been covered by all the panelists. So the thing which we usually, like, apart from whatever the others have told, so when we have to counsel them, or usually what we do in our clinic is that we have one group called as Gossip, the group of cochlear implantee parents. So we this group meets at so this meets at regular intervals. During that we have interactions with the parents and their families, so they interact with themselves, and I think that is the place where they get, I think, more motivation than we telling them, because when it comes from the parents' mouth, it gives them much more confidence.
So you rely a lot on what we call waiting room counseling.
Yes.
Excellent. That's, I think, one of the best. Rashmi, quickly, anything you'd like to add?
Yes, ma'am. I think with all the other benefits that everybody's mentioned, the main thing is also the listening effort, cognitive load that actually comes on the child. If you're just talking about unilateral versus a bilateral implant, in our practice, we've seen that a lot of children, when they've had a unilateral implant and then they've gone for a bilateral implant, we've seen a huge difference in the amount of listening effort, the cognitive load that kind of reduces quite a lot, and the ease of listening gets better, which actually then improves their performance in all other areas. So that is something, the subjective perceived benefits of top-down versus bottom-up processing needs to be really considered and explained to them. We tend to sometimes focus only on the bottom-up processing and only talk about those particular features, but the top-down processing is something that is really important for a child. So I think that's what also is something that we do talk about.
Great. Shalabh, anything to add?
Yeah, you know, the last point that you've got on the slide is actually a very important point, and I make sure I tell all my patients, because I say this because we never know when a child with a unilateral hearing implant at the age of, say, 20 or 30 or 40 has a problem which prevents him from getting a second implant in the same year for any reason. Implant is not possible, an accident, trauma, meningitis, something happens that causes that ear to be non-usable. And then we have a very serious issue of a hearing person now becoming a non-hearing person, and the possibility of doing an implant now on the contralateral ear and expecting a decent result, probably the chances are very, very minimal. So a bilateral implant is definitely, it's very important from a fail-safe point of view that they have a backup for, when the child develops into an adult and if there is any problem in 1 year, at least the other year will still keep working.
Great. So I'm going to keep you still commenting because, one of the reasons why a lot of parents and a lot of us as clinicians kind of pause and ponder about, let's say, doing a simultaneous is the risk during surgery and the operative time. So in your experience, has there ever been this as a crucial decision maker that you've, said, no, I'm not going to be able to do a bilateral simultaneous for different reasons, which involve surgery?
I think it would have to do more with the anesthetist. In case the anesthetist, and we have excellent pediatric, anesthetists doing babies, prematures and everything. But if they are unhappy or not happy with the child for any reason, which is medical, in the sense that either the child is low birth weight, has other cardiovascular, respiratory issues, that would ask me how long would the surgery be. So if I do it myself, then top to bottom, from stitch to stitch, it will still take a couple of hours, 3.5, 4 hours. But if I have
anesthesia is a major issue in your decision making, which means the anesthetist is going to be a part of your decision making team. Am I right?
Yeah, that's right. For any child where there is a doubt, definitely the anesthetist would play a big role. And if these are very small children, they are undergoing a surgery which would be about 3 to 4 hours. Whether they would, require, I wouldn't want to take up a child where there's a chance that there may be a respiratory issue or ICU admission later.
Just for the reference of a lot of us in the audience who are young and wanting to start off, what would be your cutoff time? What would you say, with your anesthetist, that if my surgery is going to take more than an X amount of hours, this is a no-no? Is there any cutoff time in your mind?
Truthfully, there would not be a cutoff time because our anesthetist really at Gangaram, there should not be an issue. But if you're working in a center where the anesthetists aren't specialist pediatric, where they don't have that much of experience with very long surgeries in very young children, then it's better to keep a 3-hour, 4-hour period. As if you have difficulty in the surgery, you've taken 4 hours, for some reason you're still having difficulty, then it would be better to cut it short.
Yeah, so about 3 to 4 hours is what you're saying. Fatima, when we look at the economics, and we've already spoken about the cost of getting two devices, what is your opinion about the maintenance and family commitments? Do you look into that? Do you look into what sort of a family it is, socioeconomically and other issues?
Yes, definitely, because when they go in for a bilateral, they are self-funded, and so they have some amount of backing in their own capacity. So yes, they are committed when we talk about bilateral, and especially when they come from other schemes. Yes, that is no choice that they go in for one. But yes, when they come in for a sequential, when they have had one scheme implant and one they would go in and fund for themselves, then that is the time we do tell them to retrospect and see what is the cost, what was the cost involved in maintaining one device, and then that will be double when they get another one. On the flip side, if they're using the same devices, they can interchange cables, batteries, etc., and they are fairly able to manage. And by that time, the parents are quite educated that what they need to do for the second implant. So that's how, they also make a very informed decision that, yes, I'm ready to go in for a second implant. So yes, we do.
Neelu?
Yes, so regarding the cost of the devices, so as Fatima rightly said, those who are going for bilateral simultaneous, they are pretty well prepared for it. And two devices definitely of the same company, they share the accessories. In my clinical experience at our clinic, we have seen that there's not a substantial increase in the cost of the maintenance of the devices, because the cables are shared, and even in the bilateral kit you have a lot of accessories which are coming in doubles, and by then the parents would have known how to really take care of their processor, so they are well aware of the exorbitant cost of repairs and buying new accessories. So that's been drilled into them right from the day one, and even before they are going in for their first implant as well. So this is all like is taken into consideration. Rest, I would just like kind of pause and ponder, looking a little bit into the family dynamics. Like at times the mother is very motivated, but the father is a little reluctant, and there are other people like, kind of interfere. So rest everything, I think if all assessments and all are in place, we would be just happy to go ahead.
I just have a different perspective on this, and maybe I'd love your comments on this. Is it only about hearing? When we look at the fact that the family is going to put in an X amount of money into the device, into maintaining the device, into the habilitation, we do realize today that bringing up a child by itself is a very expensive proposition. You have schooling, you have joint families, you may have an elder kid. How many of us think of all those aspects, that if the family was to put in everything into this, what is happening about the other expenses which are the day-to-day running in a family? Neelu, you put up your hand.
Yes. So many a times, you feel that, or you rather observe that it's a very emotional decision which is coming out of guilt. So that is where, we have to be really practical and show them the picture that is like, the future, like what is the expenditure that are going to come. I think that's the main thing. And as and how we are interacting with the families, we kind of get to know a little bit more about the other sibling, if it is being neglected, and that way. So a lot of counseling is done even by our social worker who looks into these aspects.
So great. So I think that's another take-home message. Let's look at beyond just hearing. There is Shalabh, you wanted to say something?
Yeah, like you, I've also been involved with some NGOs, and we are helping out a lot of patients, have helped out since many years with a lot of the kids with money for getting the implants done. Now, some of them come back after some time, and then they want the second year to be done, and they want, say, another, say, X 4 or 5 lakhs for that surgery also. And I tell them that you considering getting a second implant, you want my help for a second year. And now when things go, when you need change your accessories, get repairs done, which are very expensive with some of the companies, I said, you won't be able to afford it. So you have to really figure out, because I can't fund a second implant and then fund for the other accessories and repairs later, because I'd rather save that money for another child who needs an implant. And now, as the program has grown over so many years, I've realized that the point is going to come when I'm going to probably need at least about 50% of all the funds that are coming in to basically maintain the upkeep of the previous implants that we have already done. So this is very important. I think no program to help out kids can be successful unless you're also going to look after the kids as they grow up.
So sustainability, we've had a discussion on that even yesterday, and even Sue's topic this morning was about that. So it's not just putting in the 2 devices, but sustaining those 2 devices. That's very important. Sanjay, quickly.
I just wanted to highlight one case we had where they wanted to go for bilateral implantation by selling off their land. They had some property and they wanted to sell off, and then because they thought that the child is not doing that well, which he should have done, or they saw some other children with bilateral who were doing much better than him, and they wanted to sell off their land which they had. So in that case, we discouraged them for going for the bilateral implantation, but because we explained them that what all would be required once the child grows, it is not only about once you sell off the only land which you have. Okay, so such things I think that needs to be taken into consideration when we are counseling for bilateral.
Holistic, attitude is what we all need more than just looking at hearing per se. So surgical challenges are one of the biggest things that parents are always a little doubtful about. They're always worried about, will my child be able to withstand the surgery? So the youngest age, Dr. Jagini and Dr. Sharma, which is the youngest simultaneous bilateral that both of you have done? Dr. Jagini?
I have done on an 11-month-old child. Definitely this important consideration for the family and even for us, the surgical challenges in this bilateral simultaneous especially.
Shalabh?
8 months, 9 months, 10 months, all of them. But it's if they are there, it depends on also their how fit they are, and not sickly.
It's more an anesthetist.
I always get the anesthetist, pre-anesthetic consult done first, and if they are okay with it, then I'm absolutely okay with it.
Great. So we'll just quickly, for the last couple of slides, focus a bit on the surgical challenges for our surgical colleagues in the audience. Dr. Jagini thankfully shared these slides with me. Would you like to tell us a bit about this? I think anesthetics risks have been covered by Shalabh. Could you take on the slide, Dr. Jagini?
Yeah, if you do some, take some precautions and do some technical modifications, most of the time, even this bilateral simultaneous is very safe and without much increase in morbidity compared to unilateral. So one thing is blood volume, because most of these are kids with say 10 kg kid will have only about 800 to 1000 cc blood volume. So if they lose about 50 to 100 cc, they may have the side effects of hypovolemia. So we should try to maintain as bloodless field as possible, reduce the chances of bleeding by taking precautions like using diamond drill, because the mastocytes are many times not developed fully, and cauterizing the emissary veins and meticulously, and the soft tissue work to be done meticulously. So bleeding is one of the concerns, but if proper precautions are taken, most of the time that should be okay. The other concern is pressure on the second side, first side when you are doing the second side. So the proper positioning and using a soft pillow, and taking some precautions to the how we do this is we do the first side completely till you expose the round window, but not put the implant. Then we put some stay sutures and go to the other side, and then completely do the implant on the other side. Then come back to the first side and then finish off the implantation. This way you would be putting the pressure on the implanted side to the minimum, and would be able to use the monopolar even on the second side for the large part of the surgery. So taking precautions while doing surgery, and we use the screws most of the time because it saves a lot of time. It's a self drilling. It takes 1 minute for putting the screws, less than a minute many times. So but some technical modifications and precautions should make this bilateral simultaneous surgery most of the time as safe and effective as a unilateral surgery.
Great. So Shalabh, in addition to the modifications that Dr. Jagini has done, do you have any tips and tricks for young surgeons just wanting to start out on a bilateral cochlear implant?
I would say for a young surgeon who's starting off, just keep a watch on the clock. And but the problem is that if you keep a watch on the clock, then you tend to do things which go wrong sometimes. But just to concentrate on the job at hand and follow the usual technique, I would normally do one side first, complete it, just go to the other side. Normally from skin to skin and closure, it takes about 1.5 to 2 hours for each side. So
do you use monopolar at all, or do you just
I use monopolar on the first side a bit, only for the periosteal flap, but when I go to the second side, I usually slip my the bipolar under the periosteal flap, and I make the smallest, small cuts at a time till I've got the anterior incision made, and then the side incisions anyway don't bleed much.
Great. Of course, the point that Dr. Jagini's put in there about placing the implant more vertically, that's definitely something to be kept in mind. Do you use titanium screws for fixation, Shalabh?
No, I'm not. Actually, I'm not fixing my implants. I haven't fixed them for many years now. So I just make a periosteal pocket and a bed for those patients. In fact, for the earlier implants. Now with the new series of implants, no bed either.
When we counsel these patients, Shalabh, about simultaneous surgery, do we mention anything about vestibular issues post-operatively?
No, I don't usually mention, because once you mention, then they'll start looking for it, and any instability in the child will then be attributed to the implant. I don't do that, no.
Rashmi, have you post-operatively seen any patient who has had vestibular issues with bilateral implantation?
Ma'am, so especially in children, it's difficult to probably evaluate vestibular issues, and because the children themselves aren't really complaining or they behaviorally, but we might see, because many of the times we've seen that many of these children tend to have a lot of sensory integration issues. Now, I don't know, maybe we are missing this out, and maybe these sensory integration issues also could be because of the vestibular issues that are coming in. There could be a small percentage of that. And many of the, because we do closely, I do work with the OT, and many of the times we have seen that when these children are rocked or when these children have some sort of stimulation, they tend to do better. So there is probably a relation between the sensory integration issues that we see and the vestibular issues. There is a lot of research definitely that is happening now, and it is saying that there is a certain percentage, sometimes 20% also, where we see children with vestibular issues. I think we need to be now looking in the clinics, analytically seeing all these children, look at all the issues that we are seeing. Especially, I really feel that in the last few years, maybe because we've been so observant, I see at least 50% of them having some form of sensory integration issues. They could be really minimal, right up to the fact that we have actually diagnosed them with a sensory processing disorder. So it's a whole range, but I think really we need to be focusing on the minor details now and looking at the child as a whole and not just look at the listening and the speech and language development and cognition.
I just, one thing I think as a surgeon, which is very important, and that is marking the site of the implant. Because in a bilateral, if you shave the head, then it's very easy anyway to go wrong where you have sighted the second implant. And then you've got kids who have an implant here and the other one is up here. And that looks, not only does it look bad, but I think with these the off-the-ear devices, I think there is something to do with very small heads. And if the two devices are placed too close together up here, then they interfere with each other also. I think we've had some issues with some patients with that also. So marking the site and making sure it's symmetrical and looks symmetrical is also very important.
Great. So we had this discussion when we asked about Dr. Jagini and Dr. Sharma also about, which is the earliest implantation that they've done. So this one goes out to the audiologist and the speech language pathologist. We say that the critical age for doing a bilateral is about 3.5 years. Are you managing to convince patients that young that, go in for a bilateral? Sanjay?
Of course, in an ideal condition, that is the time which should be discussed with the parent.
Sanjay, ideally, yes, but what's happening in clinical
practice? That's what I'm coming to. We in our center, we do get patients who come to us after 5 years of age also. Okay, so there also we have provided them with these options of bilateral, but at the same time we discuss with them that yes, the ideal period is somewhere below 4, but yes, it is still means they can go for it. Yes, but there have been instances where we have for simultaneous, they have done simultaneous after 6 years of age also. And there also we have found that yes, those children also do better than this thing, but they are not doing that bad as the literature sometimes shows us. Okay, so that we have not, though we discuss all these things with the parents also regarding the prognosis, but still I think the time it is critical. But if the parents are willing to go for it, I think we should. Should be discussing with them the prognosis and going ahead. I think as such critical time is there, but once that critical time is gone, it's not that we cannot go with the simultaneous.
So as Fatima, I think, said right in the beginning that at the end of the day, you're going to leave it to the parent. Your job as a clinician is going to be to tell them yes, no, what are the limitations. But at the end of the day, if they still insist, you're going to go ahead and do a bilateral given all other issues even later. Fatima, am I right?
Yes, yes. We have also got, in my experience, children who are implanted even 10 years later in a sequential implant. So very guarded outcome is being told to the parent, and then it's finally the parent's decision, and they take it and they move forward. And we found good results. It's not that we don't, but yes, the preferential year will always be the earlier year which was implanted.
Yeah, so the reason we generally push in for a bilateral CI, if I'm not mistaken, one of the major things that we tell parents is binaural hearing. And we have enough evidence both clinically in our practice and even in literature that beyond a certain age, this is not happening. The second implant is not going to give this patient binaural hearing. So I guess at that time, your counseling changes is what I'm understanding. So, instead of stressing more on points like this child will do better in noise or in mainstream education, the focus would be more on localization And maybe the focus may be more on, what Shalab rightfully said, the safety of having a second device. Anyone chooses to agree, disagree? Neelu?
Yeah, so it's about binaural versus a bilateral. So it's very complex to really understand when that binaural is really happening, because we know hearing as such as a binaural sense begins 4 months, gestation, right? So we are really missing out on that point, like when does true binaural really start? So whenever it is, even if it is a simultaneous bilateral, the age does matter. But in my clinical experience, I've had like a 10-month-old up to a 4-year-old who are going for a simultaneous bilateral. And no doubt the results are better as compared to a unilateral. And as far as the critical age is concerned, definitely, we have even older children, as Fatima said. I have one particular young adult who had his second sequential when he was 21. So the need for a sequential bilateral has to be evaluated, and when children come to that point, at certain points they themselves take decisions, or they express that, look, I want to hear from this side. So there's a lot of I think introspection we really need to do in there.
So is there a critical age in your mind where you would tell the patient, if you do it before this, it will give the kid a chance at binaural hearing?
No, no doubt we are stressing on that the gap between the first and the second should not be more than 6 months. That is what we tell them, because it eases out a lot of things about what you can say, optimizing the map, getting that bilateral balance, and again the habilitation process, and even with the parents, to adjust to both sides, the child. So all those things.
6 months. Neelu, you are saying 6 months, right? Fatima, quickly. How many
I would say about
the best?
2 years. 2 years, because 6 months is too small a period for them to. Yes, maximum 2 years.
Rashmi.
Ma'am, research also says that under 2 years, you will be able to see a benefit with binaural. But I think beyond that, what happens is that the ITD, ILD cues, which are the internal time difference, internal level difference, these don't tend to match that well post that. So that after that, we will have issues in terms of really matching the two sounds and they getting complete binaural summation. But I would like to stress on this point that when we talk about benefit from a bilateral CI, we always look at it as CI1 is equal to CI2. But that is not what is going to happen all the time. So I think then the counseling sort of changes, and we need to explain to the parent that when we are doing it much more younger, we look at CI1 is more or less equal to CI2, given that other factors are fine. But when we do it much more later, what really happens is that then we are looking at CI1 plus CI2. We also as professionals tend to look at so much, aided audiogram with 1, speech perception scores with C1 is not equal to speech perception scores with C2. But that would not be a point when there is a gap. We look at C1 plus C2 and then see whether the benefit is there. But again, it will have to match with the expectations. And then at that point of time, I would probably focus more on ease of listening and reduce cognitive load. So
let's say that if you do it,
changes.
Yeah, so let's say if you do it early, if you do it, let's say this paper said 1.5 years, but let's put it as 2 years. If you do it within 2 years, you're saying to the family, there's a chance of binaural hearing. If you're doing it more than that, then it's bilateral hearing. Okay, so I think, maybe we can counsel it like that. So would you, and I think Neelu just mentioned that she did do it for, one of her adolescents, even after at the age of 21. So how many of you really would be counseling the adolescents or the teenagers to come back and get a second sequential done? Okay, we are getting a call from the organizers, so we've got to go a little earlier. Yes, Rushita, going, summarizing. Yeah. Shalab?
Yep. I wouldn't recommend to teenagers to get the second year done, but if a teenager came to me and wanted to get the second year done, then that's something we would sit down and discuss with him as a team and what he could expect.
So additional benefit maybe would be, like you said, the safety, the localization, but not much more than that. Am I right?
Yeah, but there are star performers even in these sequentials. So you just can't say no or yes. It's a bit of a maybe there.
Case to case. Implant choices to both the surgeons. Do you have any specific implant choices when you do simultaneous?
Yeah, because most of the kids are very young, so I would definitely prefer as thinner implant as we can do in the around 1 year of age when you are doing. Even if you do a bed, you can't go very deep because well, I do the bed always, but
So you
still
would
thinner
prefer
implant
thinner
would help.
implants. Yeah. And
Yeah.
I think Shalab, same?
Yeah, the thinner implants, because since I don't make a bed, the surgery is so much quicker.
Yeah. Sequential, how many of us have the experience of, I know this, that we all will try and promote for the same company. Does anyone here have an experience of a sequential with a different company? Yes, Fatima?
Yes, I do have two cases with me. They were both implanted first with a Digisonic, and then later on they went in for a cochlear device. The reason they opted out for from the Digisonic was, they were not very happy with the performance. But, when we started systematically mapping both the devices, one of the recipients uses it even till today, and the other one stopped using it. Now today, I just 15 days ago, the cochlear device stopped working. So we started the Digisonic implant again, and she is now comfortably using that. So it's again the change in mindset. Now the mother says we will try and use both the implants, simultaneously, and when the child is very happy.
So it's not an absolute no that we tell most parents. Yes, there is an option, and if the parent chooses to have a different company, you can. It's just that they have to deal with different, companies.
Yes.
Mapping challenges. Can I have Rashmi on this? Intraoperative monitoring. Do you feel there's any challenge?
No, ma'am, not really. In terms of bilateral, I don't see any issues in terms of intraoperative monitoring. Not that we have had any
switch on or the troubleshooting as audiologists.
Switch on, yes, I think time definitely, because you have to then plan. Then you may want to either do the counseling beforehand, do the kid counseling later, stage it out. But definitely the switch on of the two devices will have to happen in the same. I would prefer to do it in the same session, but maybe the kid counseling, I might kind of do it over a period of time. Troubleshooting, yes, it gets sometimes there are two ways to look at it, because if they already have one device on the other and they call up, we tell them just change the cable, etc. So troubleshooting also would not be an issue unless until there's a scarcity of spares, etc., that they are facing at the end. But maintenance is a huge cost. In this, I would definitely say in troubleshooting, the bigger concern is when these children have, let's say, been using these devices for 6 to 7 years, and then there is an issue in the processor per se, and then we have to now start talking about upgrades. It's really complex for a family to now at this point of time start thinking of an upgrade in both the sides, and
So
that becomes
economic.
really complex for me as a clinician to actually explain to the parent.
You
So I
know?
think that is becoming a huge issue now.
Intraoperative monitoring, absolutely no issues there, whether it is a simultaneous or it's a sequential. Switch on for a simultaneous, yes, it's much more, as Rashmi said, staged, and it's so we do what do you call, with the WPP, that's the wireless programming pod we use, and we make it kind of a fun for the child where he doesn't even know that it's happening. So it is very subtle. And now we have with our newer softwares, especially with the Cochlear NFS Custom Pro, that is what we would encourage. Troubleshooting, yes, since the devices are the same, it should not be much of an issue. But if there are two different devices, then it's like, looking into this and looking into the other kit as well. So long term, it's the only thing about that is the cost incurred now in the upgrades. Yeah, that's about it.
So quickly, when we measure outcomes, I'm assuming that when you look at outcomes of these children, we look at all these domains. Am I right? Just correct me if I'm wrong. So you're looking at, of course, speech and listening skills. You're looking at localization abilities, quality of life, language acquisition, and cognition and memory. Rashmi, anything to say about this in the outcome measures? Couple of seconds.
Yes, ma'am. Just about the speech perception and intelligibility, or even in the localization, we'll also look at spatially separated speech and noise. It's not that you're only going to have speech and noise in a particular direction, which it has to be through all direction. So it has to be spatially separated. I would definitely like to, we have heard Dr. Karen Gordon's lecture yesterday, and I do firmly believe that I see a lot of difference in cognitive load and listening effort. So I think these are the things that we have to start working upon, and it should be evaluated. There are a lot of laboratory kind of things that are going on, but that might not be possible in our infrastructure. but maybe along with the psychologist, because I've had a word with the psychologist we work with, and we're trying to now figure out if there's a way that we'll be able to, check the listening effort or cognition, maybe doing a parallel task at the same time and making the child listen and see whether, it makes a difference in that task, and probably evaluate that as per that. And then, of course, the outcome, the other language acquisition, etc.
So Rashmi, what I quickly want from you is all this is fine. These are all domains. Which is the one that you can use today? I mean, cognition, memory, you said child psychologist, localization abilities, we need a lab. So the ones that we're using
No,
now.
I'm not saying that we need a lab for, I'm saying that if you're looking at, if you look at the research where it says that, it's a 33-degree angle of localization that's happening, that's not really possible.
So let's not talk clinical.
If we have two speakers, we will be able to still check whether the child is able to localize. Is the child saying that it's central? We move this, the noise to the same side as the speech, that where it's coming from, and do it from the opposite side, front, back. So these kind of things is still possible. But I'm not saying we can replicate probably, let's say, the research study, which talks about a 33% of angle that we'll see with better localization.
Great. So, I'm going to just quickly just summarize. Yes, we talk about, is there really an age for doing the second CI? I think we have to really understand that, yes, older children do benefit. But as we discussed before, it would be more bilateral vis-a-vis a binaural hearing. Literature has shown us that if you do this bilateral under 8 years of age, the speech perception for the first and the second years does get closed within the first 12 months, but they never really do catch up if you're doing the bilateral implantation more than 8 years of age. That gap will always persist. I think at the end of the day, when we are counseling these parents for a bilateral, it's implantation, what we are basically trying to give them is that we're trying to give that child a clearer picture, a clearer sound over life. And 2 is better than 1. We know that for a fact. But at the end of the day, given all the circumstances that we have in our country, I think we have to take a case-to-case based decision. I'd like to take this opportunity to thank all of you for sharing your clinical expertise with us. And thank you once again for the organizers for this opportunity. Thank you very much.
Thank you, everyone.
Thank you.
Thank you.
Any questions that Nishita?
Neelam, Sunil here. So that was an awesome, extremely comprehensive discussion on bilateral cochlear implantation, very well moderated by Dr. Neelam Ved. And each of you contributed your insights and inputs were absolutely fabulous. And we had the right mix of surgeons, audiologists, and ASLPs here. Thank you so much for this. And we're just pressed for time. You did very well. You were well within time. Thank you so much for this. We will come back to you in just 1 minute. We'll be live in 1 minute with the inaugural ceremony. Thank you once again.
Thank you.
Thank you.
Thank you.
Thanks.
Integration audio check. Integration audio check.
Yeah, Prashant, it's coming.
Integration audio check.
Can you please switch on your video? Prashant?
Integration audio check.
Yeah.
Yes.
Check with Anil if the audio is coming.
It's coming, Prashant.
Integration audio check.
Yeah.
Coming? Okay.
Come, Rashmi, come. All good? Good job done. Rashmi this side. Rashmi this side. ಎಲ್ಲ ಬರ್ತಿದೀವಾ ಈ ಲಂಬು ಇಲ್ಲಿ ಬಂದ್ರ ಡಿಸ್ಟರ್ಬ್ ಮಾಡ್ತೇವೆ इस लंबू यहाँ डिस्टर्ब कर रहा है बीच में the mic will be there. The mic will be there. They will work with it. We like
check with Temporal, if you like.
Ellargu namaskara. A warm welcome to everyone. It's time to formally inaugurate the 18th National Conference of Cochlear Implant Group of India, CIGICON 2021. It is also the 6th World Congress of Cochlear Implants in Emerging Nations. We'll begin the inaugural proceedings now. Firstly, I would like to call upon Mr. Apurva Kumar, Organizing Secretary, CIGICON 2021, to deliver the welcome address, please.
Dear ladies and gentlemen, greetings and welcome to CIGICON 2021, the 18th National Conference of the Cochlear Implant Group of India, under the aegis of Cochlear Implant Group of India, CIGI, and the 6th World Congress of Cochlear Implants in Emerging Nations under the aegis of Global Cochlear Implant Access Network, GCIN. I heartily welcome the President of CIGI, the President of GCIN, and the Organizing Chairman, Dr. Sunil Narayan Dutt. It's my pleasure to welcome the Secretary of CIGI, Ms. Nishita Mohandas. I extend my warm welcome and recognize the presence of Scientific Committee headed by the Chairman, Dr. Shankar Medikeri, Co-Chairman and the Joint Secretary of CIGI, Dr. Mohnish Grover, Chairperson of Surgery, Dr. Himanshu Swami, Chairperson of Audiology, Dr. Madhuri Gore, Chairperson of Rehabilitation, Ms. Rashmi Deshpande. I welcome my dear friend and the Treasurer of CIGICON, Dr. Sumit Kumar Gaur. With immense pleasure, I welcome all the EC members of CIGI, all the life members of CIGI, and the steering committee of GCIN, and the members of the organizing team. Warm greeting to the 54 international and the 85 national faculty members who readily agreed to be part of this virtual conference. Now I'd like to invite our educational partners. A very hearty welcome to our sole strategic partner, Medal Corporation, Mr. Tejinder Singh, Head of Medal India, and the entire Medal team. I welcome our Platinum Educational Partner, Bangalore ENT Trust. I welcome our Diamond Educational Partners, Abbott and Sanofi, and a warm welcome to all our Gold Educational Partners. Now I'd like to welcome and recognize our event organizers, Avaya Medical. And lastly, I welcome all the 600 plus delegates registered to be part of this conference. I hope you will enjoy the scientific feast and have a great virtual experience.
Thank you, Mr. Apurva Kumar. I request the members of the organizing committee to light the lamp and seek the blessings of the Almighty.
Let's shift the lamp here.
Thanks, everyone. I now call Dr. Sunil Narayan Dutt, President CIGI and GCN, Organizing Chairman CIGICON 2021, for the President's address.
Ladies and gentlemen, a very good morning, a good afternoon, and good evening from all parts of the globe. The Cochlear Implant Group of India is an adult today. In its 19th year of inception, ever since 21 of us across 3 streams got together in 2003 here in Bangalore and put this together with a singular objective of deafness alleviation in the country. Look where we are today. I reckon we have come a long way in these 2 decades and have most impactfully made an inspiring difference to the hearing impaired community in India. We are nearly 700 members strong today, and our voice is definitely heard. This first time ever virtual CIGICON has brought together 140 luminaries, as Apurva said, from across the globe, an unprecedented number of faculty in a single CIGICON, albeit thanks to COVID. With similar objectives in the developing world, emerging nations as we are called, we put together the Global Cochlear Implant Access Network, GCIN, some years ago. Several meetings were conducted in Cape Town, Dubai, Cairo, successfully in the past, addressing issues and challenges unique to these regions. This is the 6th World Congress of Cochlear Implants in Emerging Nations. It gives me great pleasure to hand over the medallion of the president of Global Cochlear Implant Access Network to Levent Senaroglu, who will conduct the next conference in Turkey. Ladies and gentlemen, COVID has shown us devastation and despair. Humbling is too small a word to describe what our lives have been through in the past 18 months. But this has been a wake-up call for all of humankind as well. We have begun to value, refine, and redefine our friendships, our relationships, and appreciate the little things in life that were all hitherto taken for granted. Here's wishing each and every one of you a fruitful conference. Thank you very much.
Thank you, sir. I now call upon Mrs. Nishita Mohandas, Secretary, CIGI, to address the virtual gathering, please.
Beloved founder members, dear colleagues, professionals and friends. Good morning and a warm welcome to the 18th CIGICON and the 6th World Congress of Cochlear Implants and Emerging Nations. It is for the first time since the last 18 years that the National Conference of the Cochlear Implant Group of India is being hosted completely online through Bangalore. The theme, Implantable Hearing, Refined and Redefined, envisaged by the OC, focuses on bringing together as many professionals to discuss and deliberate not only on newer developments in the field of cochlear implants and other implantable technologies, but on also how to keep them up and going. Last year, for the first time, the CIGI hosted a special GBM with a single point agenda to postpone the 18th CIGICON and all other activities associated with it until further notice. Next, the CIGI hosted the first ever virtual seminar series along with the organizing committee of CIGICON Bengaluru, attended by a large number of professionals, and was very well received and a highly successful event. This opened the doors for hosting the current CIGICON online as year after year, and more so because of the pandemic. Organizing this conference was difficult as sponsorships were sparse, too many conferences held online, and the logistics needed to hold such a meeting was tough. But as they say, when the going gets tough, the tough get going. Later, the EC hosted the first ever GBM online. Over the next few months, the EC of the CIGI held discussions and made representations to the government for removal of the GST and for initiation of the Universal Newborn Hearing Screening Program. Currently, the EC has worked very hard on the CI registry, and a framework is now ready for installation and to be used shortly. The website is also upgraded and will be launched shortly. The membership process has also been updated and upgraded with online submission forms and necessary documents, and online payment has also been initiated. I'm extremely proud to announce that very soon, after ratification of the GBM today, we will be touching almost 700 members. Currently, the topic for unrest amongst members regarding the new implant manufactured in India is also being addressed with representation sent via emails to the respective company, surgeon, CDSCO, the PMO's office, articles in newspapers and on social media. I am confident that in spite of all odds, our sheer hard work, grit and determination will help us see a light at the end of the tunnel. The organizing committee of CIGICON 2021, along with the executive committee of the CIGI, received an overwhelming response from national and international faculties to hold the conference online. The organizing committee has been toiling day and night and working very hard in tandem with the back-end team, the Avyaya Medicon personnel, who are responsible for hosting such a great meeting. I'm confident and absolutely sure that the OC will be able to reap rich benefits and bring accolades and glory they rightly deserve. Kudos, a heartfelt appreciation and gratitude to the organizing committee. My best wishes are always with them. Thank you one and all for your attention and patient listening. And I wish you a weekend wonderfully ahead of you, filled with a stimulating and intellectual learning extravaganza. Thank you very much.
Thank you, Mrs. Nishita Mohandas. I now request Dr. Shankar Medikeri and Dr. Monish Grover to release the conference proceedings. I would also like to mention here that the conference proceedings will be available on a virtual platform for a period of 90 days after the conference.
Switch to that. Mic mute. Are you there?
We have great pleasure in releasing the conference proceedings of CIGICON 2021 and the 6th World Congress of Cochlear Implants in Emerging Nations. Dr. Monish, you just...
Yeah, these proceedings, as we can all see here, contain various educational partners and their details. We also have messages from various dignitaries that includes the organizing chairperson, Dr. Sunil Dutt. We have the message from Secretary CG, Ms. Nishita Mohandas, Scientific Chairperson, Dr. Shankar Medikeri, Organizing Secretary, Mr. Apurv Kumar, and the Treasurer, Dr. Sumit Kumar Gaur. There are various photographs of organizing committee members, Scientific Committee, the Cochlear Implant Group of India, EC members, and the GCN Steering Committee. We have abstracts from various keynote speakers, that's Dr. Thomas Lenas, Dr. Karen Gordon, Dr. Sue Archbold, Dr. Fan Dan Singh. The various international faculty and the national faculties have also been put up in the same proceedings. The scientific program in detail, which we all have a copy, is also part of this. We also conceptualize the world cafes which have been used in the previous CIGICON, and we had 9 world cafes. We have abstracts for surgeries, e-posters, oral presentation from surgery, habilitation, and audiology. So all these abstracts are a part of these proceedings. And before the end, obviously the things could not have been possible without our educational partners, and they have been given adequate space in these things as well. We also have these proceedings which have been put up on the website of CIGI and CIGICON, and we'll also be mailing it to all the CIGI members and delegates. Thank you all.
Thank you.
Thank you, Dr. Shankar Medikeri and Dr. Monish Grover. The chairman of this scientific committee, Dr. Shankar Medikeri, will address the gathering now.
Thank you, Shweta. Mr. President of CIGI and GCN, Dr. Sunil Narayan Dutt, Honorary Secretary of CIGI, Ms. Nishita Mohandas, Scientific Committee Co-Chairman and the Joint Secretary of CIGI, Dr. Monish Grover, the members of the Scientific Committee, Dr. Madhuri Gore, Rashmi Deshpande, and Group Captain Himanshu Swami, all the members of the Executive Committee of CIGI, Organizing Committee of 18 GCN, the CIGICON 2021, and the 6th World Congress on Cochlear Implant in Emerging Nations, all the steering committee members of GCN, and all my dear delegates. It gives me immense pleasure to be talking to you all as the chairman of the Scientific Committee of 18th CIGICON 2021 and 6th World Congress on Cochlear Implantation in Emerging Nations. The Scientific Committee members have strived for the last year and a half in judiciously selecting the various interesting topics and the faculty of repute, both national and international. The theme of this year's conference being the implantable hearing, refine and redefine, the Scientific Committee has taken care to include all aspects of hearing solutions from basics to the most advanced. We have given equal importance to all the three streams, namely surgery, audiology, and rehabilitation, which form the three cornerstones or the strong pillars for a successful implantable hearing solutions program. We have been lucky to get very well reputed international faculty as the 4 keynote speakers. Many national and international faculty of repute have agreed and they are conducted the master classes, the panel discussions, symposia, and have given some invited talks on various aspects of cochlear implantation and other implantable hearing solutions. I'm happy to share that this year we have almost 85 national faculty and 54 international faculty sharing their experiences with us and enrich our knowledge in the field of cochlear implantation. I would say with a bit of sadness that this year, the response from the CIGI members to present their work, both in oral presentations as well as e-posters, has been lukewarm. We would like more and more CIGI members to present their good quality papers in the annual conferences in the coming years. The additional feature of this year's conference being World Cafe, there are 7 World Cafes discussing on controversial issues in different aspects of hearing solutions. In these pre-conference World Cafes, various experts in the field from around the globe have discussed threadbare each individual topic and have created a consensus document or the guidelines for the benefit of all the members of the fraternity. These documents will be presented by moderators of the World Cafe on the 3rd day, that is tomorrow morning in the conference, and the organizing committee is working on their publication in the peer-reviewed reputed journals. So on behalf of the scientific committee and the organizing committee, I would like to thank all the national and international faculty for having kindly agreed to accept our invitation to be a part of this prestigious event. I would also like to thank all the past presidents of CIGI who have come forward wholeheartedly to contribute to the success of this conference. On behalf of the scientific committee, I would like to thank the president, Dr. Sunil Narayan Dutt, for reposing confidence and assigning us this job of creating a wonderful scientific program. I would like to thank all the members of the EC and the organizing committee, especially Apuru Kumar and Sumit, and also the Aveya Medicon for their continuous support and suggestions in making such a wonderful scientific program. Dear all the delegates, as you know, the proof of the pudding is in eating it. So I would like to request each one of you to attend all the sessions from beginning to end and enjoy the academic feast. Your feedback, be it accolades or criticism, really matter to us. So please do share your feelings. So lastly, I would like to congratulate wholeheartedly my colleague, Dr. Mrs. Madhuri Gore, for being honored with the prestigious CT Oration Award for this year. Thank you, one and all. Thank you.
Thank you, sir. We have come to the end of the inaugural function now. It is time for Dr. Sumit Kumar Gaur, Treasurer CIGICON, to deliver the vote of thanks.
Thank you very much. Good morning, ladies and gentlemen. As Treasurer of CIGICON 2021, it's my proud privilege and honor to propose this vote of thanks. At the outset, I would like to thank the Cochlear Implant Group of India, its Executive Council, and all the members of the general body of the Cochlear Implant Group of India. I would also like to thank the organizing committee and the scientific committee of CIGICON 2021 for their untiring efforts in the last 18 months to put this program together, the first ever virtual CIGICON. I would also like to place on record the gratitude to the steering committee of the Global Cochlear Implant Access Network, this being the 6th World Congress of Cochlear Implants in Emerging Nations. I would now like to thank our educational partners. First of all would be Medal Corporation and its India head, Mr. Tejinder Singh, for their generous support, and hence they become our strategic partners. Next, I would like to show our gratitude to our platinum partner, the Bangalore ENT Trust and Dr. Shankar Madikeri sir, for the very first endowment he made to us as soon as CIGICON bank account was open. Thank you very much, sir, for that. I would also like to thank Sanofi Aventis and Abbott for their educational partnership in the diamond category. In gold category, I would like to express my gratitude to Jane Resound, Zydus Respicare, Zydus Fortiza, Sun Pharma, Lupin Respira Specialty Care, Alchem Burgeon Nova, Lupin Respira, Ceramed, Ascigen Hospital Care, Lincoln Pharmaceuticals, Alchem Burgeon Asta, Dr. Reddy's, and Iris. My heartfelt thanks goes to our event organizers, Avaya Medicon, who have been with us for over 2 years and played a significant role to shape up CIGICON 2021. Thank you very much to the whole team of Avaya Medicon. I would also like to thank our distinguished faculty members, both national and international, who brought science to the conference. And last but not the least, I would like to thank all our delegates without whom this conference was not possible at all. Thank you very much to all.
Thank you, Dr. Sumit. On behalf of the organizing committee of CIGICON 2021, I take this opportunity to thank all the participants and invitees who are present virtually for being a part of this inaugural function. Thank you so much.
I would also like to recognize our MC today. That was Mrs. Shweta Pradhan. She's part of the Avaya team. So give us a minute, ladies and gentlemen, while we set up for the oration and the felicitation. Thank you.
So the SIGI oration for the year 2020-2021 goes to Dr. Madhuri Gore.
Give that. You can get the mic a little closer.
Dr. Madhuri Gore, recipient of the SIGI Oration 2020-2021. Dr. Madhuri Gore, you are a pioneer in the field of audiology with a focus on cochlear implants, and you have been a part of the SIGI from its inception. You were one of the organization's founding members and also served as vice president from 2017 to 2019. Your passion in serving the hearing impaired is reflected in every aspect of your work, from having been Bengaluru's first pediatric CI recipients audiologist. You have since then assisted hundreds of patients in receiving cochlear implants and also ensured that they get proper service post-CI. Over the years, your enduring care and loving nature makes these patients fondly remember you for life. Dr. Madhuri, you've been a role model, source of inspiration, and mentor for many students in your glorious teaching career of over 30 years. In addition to being on the teaching faculty, including professor, you have held esteemed positions such as Deputy Director, Technical and Principal of SRC Institute of Speech and Hearing, Bengaluru, which is one of the premier schools of audiology in the country. Madam, your academic areas encompass a wide range of topics in audiology, speech perception, psychoacoustics, noise and hearing conservation. Diagnostic audiology and implantable devices are just a few of your specialties. You have guided over 75 master's dissertations and served as a resource person at numerous conferences and webinars. You have also guided many postgraduate students for their independent projects, been proactively involved in additional projects as a member of various research teams, and successfully conceptualized and run the fellowship on cochlear implant technology and rehabilitation. You have a long list of national and international publications in prestigious journals to your credit, as well as numerous honors for paper presentations. Many students of your remember with immense gratitude the extra time you stayed back in college to help them understanding audiology better, write with finesse, and broaden their horizons. With kindness, you have framed them to be better human beings and audiologists. You've never looked at the clock while extending your helping hand to any student who approached you at any time, even at the 11th hour. Your enthusiasm and commitment to the field of audiology and its advancement speaks for itself. Dr. Madhuri, your vision towards reaching the remote areas is tremendous. You have organized several camps in the rural areas as you realize that those populations are getting neglected and lack access to services. You also made an extra effort to reach out to many government and private schools. You initiated several free camps on noise and its effects and cochlear implant awareness programs. Of note is your service as a member of the Karnataka State CI Committee. In addition to building up the CI unit, you've always been involved in various clinical areas such as developing speech test materials, AEPs, OAEs, and tracking rehabilitation progress. For your contributions, you have also been awarded the Women's Day Award in 2009 by the PRCI, IIBMR, International Business School, BP Chambers, and the Rotary International Award of Excellence in 2009. You were also the recipient of the Professor Kameshwaran Oration in the year 2014 from the Indian Speech and Hearing Association and the Empowering Differently Abled Award in 2018 from Surana College as part of the first annual Transformational Leadership Summit and Innovative Excellence Awards. Your partner for life, Dr. Chanakya, describes you when Madhuri and I have independently reached the peak of our career, achieving a status of professional nirvana, the enshrined dharma behoves us to share the knowledge, skill, empathy, and happiness we gain in the ardor with our aspiring generation. What could be more rewarding than the frequent passing message that your guidance illuminated a path not only for us to follow, but also to investigate, learn, and perpetuate. As a couple, what more could we ask of ourselves and our commitment to learning and sharing when all the four in our family, the two of us, our son Dhruva and our daughter-in-law Kyungjin, have each acquired a PhD and have committed to the cause of elevation of mankind. I guess we are blessed beyond our dreams to remain useful to our society and to stand by our well-wishers. You are one of the most approachable persons in the speech and hearing fraternity, as well as a guiding hand in the area of audiology, particularly cochlear implantation. Your signature smile brightens everyone's day, especially those who come to you for advice. We are privileged to be part of your journey. You are truly deserving of this acknowledgement, recognition, and award of oration at CIGI. Citation presented at the CIGICON 2021, Bengaluru on 13th November 2021.
Thank you so much. I'm overwhelmed. Thank you very much.
Will you please give us a minute for Dr. Madhuri Gore to sit in the hall and get onto the computer to start the oration address? Thank you.
Anil, do you want to check?
It's coming.
Presentation.
Shall I put the presentation now?
Yeah. You want to check? No, that's fine.
Ma'am, we could hear you.
Okay. Is it right? Good morning, good afternoon, good evening. That was a very humbling and very emotional to listen to listen to Nishita. Respected members, the president of the CIGI, president of the organizing committee, scientific committee, members of the EC, senior members of CIGI, and other members of CIGI. I humbly accept the CIGI oration today, and I'd like to thank everyone for their support. Before I begin, I would like to dedicate my presentation to my husband, who has stood by me and given his loving support and more to all my endeavors in almost 40 years. Cochlear implants as a field have changed the course of audiology, and because of the unusual aspects that it's so different from the regular acoustic hearing, it has increased a lot of interest and is a very exciting field to be in. Before I continue with my presentation, I'd just like to give a brief background about myself. 40 years ago, the main aim in audiology was to get a perfect hearing thresholds and they had every audiologist had to know masking, speech audiometry, and emittance. We did not have ABR or any voc potentials then, and that was our main skill besides therapy. So when I joined the Dr. Chandrasekhar Institute of Speech and Hearing, Dr. Vijayalakshmi Basavaraj initiated me into the correspondence therapy program, which dealt with making lessons for children with hearing loss and writing out the lessons and demonstrating how everyday material could be used to make learning exciting. So I was a part of that, and later was in charge of the preschool program. In the preschool program, we initiated the teaching pragmatics of communication. Now, in the pragmatics of communication, we learn turn taking and expansion, which is what is done in regular speech and language therapy. But what was done was we gave the parents a script in which they wrote what they would talk about everyday matters, and write a script and describe how they would expand, how they would turn take, and how they would stop for the child to respond. So that improved their speech and language skills a lot, and that was kind of unexpected for me as well. But that was how it was. It was a very good experience. In 93, Mrs. Meher Vakil brought Dr. Daniel Ling to our institute. Now,
At the time he came, I learned from him that if the child is not speaking some words or some sounds or not there, then that is what the child is hearing. So now suppose you have a ski slope loss, they might hear the vowels, they hear the voice, but they don't hear the consonants. And this can be applied anywhere. So Dr. Ling showed us how we have to evaluate the hearing and how to evaluate hearing. But and Mrs. Vakil showed us, how important her program was. Later around in the late a few years later, Mrs. Vakil came again, bringing Jaspal, Ms. Neelam Lala, and Mrs. Geeta Prasanna to the institute. And I saw Jaspal give therapy for the first time. This child was one we had sat with earlier for therapy. But what Jaspal did was she sat quietly and she brought out all the responses in the child. That was amazing. And it was disturbing as well, because suddenly I realized we set the expectations low, we were directive, and that gave me a huge insight. In 97, I went to the my journey into the cochlear implant field began. And Dr. Mahadevaya, a very eminent surgeon, and I went to the Bionics Institute in Melbourne and the Sydney Cochlear Implant Center. And we attended the workshop, and which was a very exciting experience. We learned, we got a lot of theory input from the senior most people in the field that time, Dr. Graham Clark, you can see there, Dr. Pyman, and many others. And we learned also to troubleshoot, to do some mapping, and we interacted with the patients. And what decided that, even though I heard adults speaking that they hear people talking like chipmunks, and that was not as impressive as when we saw a little child who was coming for a mapping session and who was protesting in so many tones, no, no, no. And I really understood, I decided that this was the very good thing that we have for the children with hearing loss. The cochlear implant program gave us a lot of new ideas and or a lot of new problems. So how I'm going to present is that we're going to talk about a few of the problems that were important, that I thought were important, what we did. So now, even after implant, they hear the sounds, but certain sounds were missed. And now, unlike children with hearing aid, then you look at the audiogram and do that and you get some idea. But even then, the audiogram is not perfect. So some children with the same audiogram do better than the others. In cochlear implant, there were some unusual findings. That is, children could, there was a disconnect between the words and the speaker. So now children, when we did a small study, that my student recorded the parents' voices, the therapist's voice, and the teacher's voice. We run a small preschool program, so the teacher's voice there, and the children were all familiar with these voices. And these people said everyday sentences that, what children talk about, short sentences like, is the milk hot, or put on your shoes, or, something, this is nice. And the children were asked to say who said that and what is being said. So now what was found was, even with 1 year of experience, the children recognized what was being said, or 1 or 2 years, recognize what was being said. But suppose they were asked who is speaking, they couldn't say that. If they said who is speaking, they did not understand the words. So that was unusual finding, and that gave what was happening there. Only the experienced children could do both together. So when we discuss this, you think if they can identify on the environment sound perception, by 8 months of after using the implant, most of the children, or almost all the children, could identify in a closed set the bus, scooter, motorcycle. But the same, when it was a closed set of voices, they couldn't do it. So what was happening? My friend Dr. Asha Ethiraj said that one is a right hemisphere activity and one is a left hemisphere activity. So there appeared to be kind of a disconnect, and which connected later. So now our question was, is it like an auditory processing disorder, or is it from the peripheral processes? So we did do peripheral assessment. You can see a TT-ABR, but I won't talk about it now, but they could think of peripheral and central. So now to identify the speaker, sometimes we use indexical properties, and sometimes we also use the speaking style. And in speech, rhythm is one aspect. So typically, the temporal is the best preserved in children with implant. But best preserved meaning how best? Was it similar to normal children? So one of the studies done by Hira was that she used a loop in which they had a beat. So they had to clap along with the beat, which they heard. The children had to clap. And then after that, the beat would stop and they had to continue clapping. So children with implant who we thought were doing well, they did not keep up to the beat. They lost the beat, whereas typically hearing children continued to have the beat. Most of the children with implant did not discriminate small changes in the pitch. Timbre, they could identify vehicles, they could identify some musical instruments, but to identify people by voice took time. And melody, it was, like students said, if you give a close set songs, like Happy Birthday or Row, Row, Row a Boat, or something which are there, or which they know, and the national anthem and these, they identified this melody, but if it was sung, when it was played with a musical instrument, they did not do it. So actually they were identifying words, not maybe the melody. So now this was different from the traditional dealing with persons with hearing impairment. And then obviously you have to work on it. So there was a focus on rhythm in the therapy. Now in traditional auditory verbal therapy, which approach we used, the use of music is there. Like this, every activity has a small song or this, but there were delays in learning. And everyone would have thought that, the cochlear implant is going to make it better, but obviously it is not. And there were changes that happened in the providing the fine structure. So actually it appears that the children were doing like a Hilbert's transform in their head, and they were hearing the envelope or they were hearing the fine structure, not both until a certain time. So these gaps had to be identified and the basis for these gaps. So were they central, peripheral, could it be done by tweaking the maps a little bit, or in more intensive therapy? That was the question, and that is what was done. And so this aspect is there, that what is to blame for the perception deficits. Is it the peripheral or the central? And this, it is kind of difficult to quantify. So if you have to locate and tag, it's not so straight because there is communication between the peripheral auditory nervous system and the central auditory nervous system. So it's not we can't do it. Now, we noticed some, now if all people should know that the children with implant don't undergo the same kind of habilitation. Some opt for an oral method and some opt for an auditory only method. Sometimes it depends on the age of when the implant is done, but sometimes it's a parent's preference and that happens. So now we used a small study to find out what happens in the McGurk. Now, if you're familiar with the McGurk effect, if the sound k is said, but the when the person is looking at the video and the lips are closing, and if you see only the video, you think they've said per, and if you hear alone, you hear the sound k. Now, what happens when both are presented together? Typically, people hear the sound t. So just to restate that if the sound produced as k is given by the recording, but the video recording says pa, then the typically people who hear the sound t, which is nowhere in the picture, but that's what happens. That means the brain is already doing auditory and visual integration. So even though people are using hearing, they are doing both together. And we are using two senses always in certain, levels of, at different levels. So what happens when children with hearing a cochlear implant are asked to identify the sound? So suppose they hear only. The children who had an auditory oral approach or children who had an auditory alone approach, they heard the sound k. When they saw only the video but did not hear the sound, they both identified it as p. But when they got the information together, then there was a difference. Those who were auditory oriented responded like typically hearing persons, they heard ta, whereas those who learned in the auditory oral method, they heard pa. So this was another technique because you have used a different method to teach. The brain has got reoriented or reorganized. Even though they're speaking, there are differences in the brain, which you can see on the behavioral measure. So maybe the McGurk effect can be identify who is more or less oriented. Now, we all know about the magic hours of practice, the 10,000 hours of practice. 10,000 hours is more than 1 year. 1 year has some 8,000 and odd 700 hours, but 10,000 is more than 1 year. So now that much practice, can that be provided, and does it work? And doesn't it mean that, it has to be in a different way to learn easily? Is the way it is done that children plateau off, or do they begin to catch up later? So these were, and in adults, there is prolonged deafness the only answer for poor progress? These are questions which arise. So now when we select the person for an implant, we do a lot of pre-implant perception. And one of those is psychophysical tests, which are like, are these two sounds same and different? Are they, which is louder, which is higher? And even because they are non-verbal, they can be trained to respond And if it works, do you hear one beat or two? You can start with that. So here is, you can see in the figure, the promontory stimulator, which is in blue, and on the right, you can see how it is placed. So that's a needle electrode, which is inserted through a speculum and placed on the promontory. So now through this promontory stimulator, you're giving electrical pulses, which are a lot similar to what is given in the cochlear implant. So you have pulses ranging from 50 hertz to 400 hertz. And you have this adult lying on one side with the needle in the ear being held by, very patiently by the surgeon. And we are presenting the sound. We find the threshold. We find what is the dynamic range. It's a lot like mapping. Increase the intensity till they feel it is, a maximum levels of comfort. And we find out, can they detect gaps between two sounds, two buzzes? And can they hear the frequency differences? And of the 10 which I have done, none of them could hear the frequencies beyond 300 hertz or 400. It sounded the same. They did not have frequency discrimination. Today, Dr. Zheng also talked about that. The other thing is that this gave us a very good idea. And the final test was, were there enough surviving spiral ganglion cells? So it did an adaptation test. Now, this test has some issues or not used, but it gave a great understanding to me. And in the beginning, I did it on myself, actually, put it at the back of my hand to understand what was happening. And so the stimulation, the responses that people who were recently lost hearing were similar, in the sense they heard a buzz or they could hear one or two sounds, and some of them made it sound like a, chirp or an insect. And those people appeared to even have a memory. That means this evoked a memory in their auditory cortex. So was that important? So now we have two aspects. One is the peripheral nerve okay, or is it the memory which is there? So now we have tests, EABRs and CAPs, which have links to behavior. Now, suppose we get a P1 potential in the CAEP, then this is what is in the figure is the implant, one done at 4 months of implant age and one done at 7 months of implant age. And you can see that the speech perception improved from 20 to 60% in a closed set. And the P1 latency also decreased from 217 to 193 milliseconds. So using that, you could estimate progress, and that was one way. The other part, we saw that those who had strong memories did well, and I think this has been also published. So also as we went on, we saw that the adults slowly emerged from plateaued situations. That means perhaps they were moving along, but it was so slow, it appeared to be a plateau. And I've seen them after 5 years, they took to kind of respond confidently in regular conversation. So we can't be sure in prolonged what happens when there's prolonged deafness, and there can be PA, it's not peripheral auditory nervous, peripheral nervous system and the central auditory nervous system, both can dominate. So in addition, we found multiple deficiencies. So just to illustrate this, I'd like to tell a small story. We had a young IBM engineer who had lost her hearing at the age of 4 and who wanted an implant. So her promontory test was very good. There's no adaptation and she had good perception, but of course she didn't get, they didn't evoke a sound memory of any specific sound, but she heard a buzz. She had good frequency discrimination. and surgery was uneventful. But when the switch on came, she said she felt a vibration. So I panicked, but the Australian audiologist, Mr. Brendan Murray, was calm. We started the auditory training, and she moved from wearing the hearing aid, preferring the hearing aid, to removing it. But then what we realized is that she was never going to go beyond closed set perception for a long time. Now she's little better because she did not have a memory for her sounds, despite her excellent language and consistent use of hearing aids. She was a lip reader or speech reader mostly, and the importance of family support. So now all her brothers were engineers. They were all busy. There were no one to talk to her, and everyone spoke, and only her mother had time, and she spoke in Hindi mostly, and only to this person in English. And finally, after a long time, though she had given that what she expected from the implant, see, there are other things that we don't ask. I used a questionnaire from Australia. Why do you want an implant? In India, the one important thing is when women or men of this age ask an implant and are unmarried, they often want to marry a normal hearing partner. So this I did not realize, and this I got support from my senior colleague, Mrs. Kumudavalli, who convinced her to marry whom she wanted. So now we realized that there were more things that are required for therapy. We had to ask the right questions, and then we evolved therapy for memory. And this therapy improved speech perception within 10 days. So in the sense that the study was designed such that the child got training in memory for visual, for auditory, for all aspects, spatial memory, and regular therapy. And then the speech perception scores improved. And also we used a token test, and there the performance improved a lot. The other aspect we realized was that we had to get multidimensional understanding of the whole picture, even in speech language, where we used to do typically expressive and receptive. We had to check for pragmatic. We had to check separately for play as well. And what happened after the implant? The first thing improved was play. Doesn't that show that there is a lot more that's happening after an implant? Play became like more age appropriate. And then the receptive language improved, followed by pragmatic aspects, receptive aspects, expressive came later, and phonology was the last. So what we realize another way is, since progress tend to move up and down, always the plateaus need not, they could change. And we had to try multi-pronged, and a lot of people had to be involved in that. Family support had to be enlisted because we needed the bigger picture. There's so many more issues that we had not looked up. The bigger picture was required. We were like, the blind men examining the elephant. So now looking at the bigger picture was important. What was the bigger picture? Now, parents sometimes reported balance problems, vision, feeding and all has come more recently, but we knew we had a child who had a feeding deficit, and we didn't know when she came for therapy and she was being tickled, her stomach, the contents came out of the small tube which was inserted. And then we knew she had a tube. We didn't know about feeding those days. So we had to, and she was in a tube because she was getting frequent pneumonia. So we had to look at her long-term aspects, feeding, paresis, and they had heart problems and so many other problems. So a child with hearing loss was not only a child with only hearing loss. They had many other issues. And what had to be done? So we had to find out, we had to interact more with the doctor, see the bigger picture, meet the non-professionals, the speech language pathologists, audiologists, psychologists, occupational therapists, physiotherapists, educators. You have to see so many things. You should understand a little bit about radiology, how they responded in therapy. How was the child? Was the child progressing or not progressing? Were there more turns? Were there more verbal turns? Were there less missed turns? Everything added. Sensory integration is a huge issue, and that had to be checked. So our tests, audiological tests also had to be better. We couldn't find everything first shot. See, now you see the speech perception test in English, and everyone is familiar with this. And first thing children know is first they know the pattern. They get confused with dog, shoe, car, but not dog and apple or dog and umbrella. So those who are not getting that, they need temporal mode training with that. You have to discuss, integrate the findings. So if they are young children, I'd just like to present this child who had preauricular tags, stenosed EAC, mild paresis. He was beginning to vocalize and imitate CV and CVC combinations. And he had aided responses on the edge of the speech spectrum, the lower edge, not the green beam. And but we could get a pure tone audiogram. So 2 years, we can get a pure tone audiogram. They have to come every day, and you have to, they can learn if they're smart, but it takes a long time. Then we did a TT-ABR was done. That was Dr. Medicari referred it to Dr. Sunil, and I think he and Apurva, they did the TT-ABR. And you can see this is like somewhere close to a type C. So now integrating they went in for the implant, and as predicted by the TT-ABR, the child needs to speech read along with that. So this is one part. He did not have dysphagia, but he did have a slight facial paresis. So as Dr. Holcomb said yesterday, we need a whole village to test. And these are my colleagues. We have the along with the audiologists, the SLP, psychologists, occupational therapists, and the educators. So you can see Dr. S.R. Chandrasekhar, who founded the institute and eminent ENT surgeon himself, he understood the importance of a test. In addition to the thing, a lot of my students became my teachers. Okay, Saji, Apurva, Ajim Shah, they were my students, but now they are my teachers because I need help from them many times. And that is something, it's nice to learn from your students. They're very kind and understanding, and they're firm, they endure. No one can help me, Apurva told the students, don't help her, let her learn, which is good. Okay. So now we are looking into the neural aspects, but we are also listening more to the parents, and we are going beyond, therapy. Their child is talking, looking into schooling, reading. Are they doing well? When we gave a questionnaire to the teachers, one of the parents told me, ma'am, you're asking them only how they're doing in school. Shouldn't you ask how many friends my child has? Does she have friends? So we need to look at more aspects and support parents. So let me just talk. See, even though you're looking at so many aspects, all the information doesn't come at the same time. So here was a child with congenital hearing loss and had aplasia of the right vestibular cochlear nerve, and there was some small tweaks seen in the right internal auditory canal. Left, there's a tweak seen, and it was suggested of a grossly hypoplastic cochlear nerve. Now the mother felt left ear was better. Again, we took a long time. I've put it, we typically take 2-3 months to get an audiogram, and then you find that he had some kind of a pattern perception. Left ear was better. So every time he came, we had to, rewrite. So that's why there's so many aspects. And because he had this pattern perception and there was thing, we did get ECAPs in the surgery for 3 of the electrodes, which was good. We didn't expect even that, but it was unusually on the basal, not apical. That was also unexpected. You can see the sound field thresholds are well within the spectrum. And this we had to, his mapping took time because we had to keep changing the pulse width and find out which was comfortable, which was the best rate for him. And a few months later, because he had visual problems, he had to wear specs. Then he underwent a genetic testing and found CHD23. So for the parents, it is like one thing happening after another, and they need a lot of support. So we have to look at the bigger picture. We don't see the picture at one shot. We see things in part, and we need to increase the community support. But any lessons, you can see that within the children have so many problems. We always need a team approach, and the basic team is always the same. Discoveries happen through teamwork and by listening to each other and seeing the bigger picture. Let me just present to you the team I have worked with for a long time. I have, as initially I was working, I have worked with late Dr. Mahadevaya. For a short time with Dr. Sunil Dutt before he went to the Gulf, and there was one pediatric and one adult case from which we had done work together. But I have been working with Dr. Medicari. I've been associated with my institute for almost 20 years now. And I have been lucky in my interactions with all the surgeons in that they all always respected the audiological decisions. And Dr. Medicari is very warm, and a good friend, Ms. Rashmi Deshpande, is a great support to me always. And now more a friend rather than a colleague. We've had great interactions, and we are lucky to have I was lucky to be part of a great team. It makes a big difference to outcomes, I feel. So this is something. So now, initially, during the surgery, we used to do a ESR. That is what Saji had recommended. Sometimes ECAPs did not come, at least when we used to use the earlier version before the auto NRT came into picture. We didn't always get the ECAPs because you had to set the right delays and gains. So we used to do an ESR always. So now I could not appreciate the ESR at all. So Dr. Medicari set it to the maximum to enable me to see it. And then we discovered something which I'm just going to present now. I hope you can see. So we are doing the ECAP. I don't know, you can see the ECAP, and you can see, I can't hear the beep. I hope you are hearing.
We can hear it, ma'am.
You can see when conditioning is going on, you can see the stapedius muscle contractions or tendon. You can see the movement. Also at high intensity during the ECAP process itself. So this discovery, I don't know, is the video playing?
There's a ball that we can see.
That's what, I don't know what happened. I think it's a short video. So we discovered that ESRs happen during the recording of the ECAP. Now, this is a nice discovery and everyone can use it because there are so many young surgeons there, and ECAP, I mean, even if you don't get ECAP, once you get an ESR, you know that, you know, it is in the right place. And this was a very momentous discovery. It has been presented before. And so I could not get a good picture of the founder members of the Cochlear Implant Group of India, which was formed in Bangalore in 2003. But I have a picture of all our first 25 cases and all the Bangalore team. You can see here Dr. Sunil Dutt, Apurva, Mr. Avinash, Tushar, Dr. Medicari, and a whole bunch of kids who are now grown up now. The slide Dr. Medicari kindly shared with me. Thank you.
Thank you, Madhuri Madam, for the wonderful SIGI oration lecture. It took us through your journey right from its inception. And like I say, once a teacher, always a teacher. There are so many learnings to take from your oration speech.
Thank you very much.
So now I would like to call and announce that the SIGI Award paper in Audiology and Rehabilitation goes to Ms. Muthuselvi T on her paper, Effect of Modified Programming Parameter on Sound Field Thresholds, Speech Perception, and CAEP among children using CP802 processor. I would also like to take this opportunity to announce the SIGI Fellowship. It goes to Neha Shakrawal from Jodhpur, and she would like to pursue her fellowship at All India Institute of Medical Sciences, New Delhi. Muthuselvi, I invite you now to give your lecture.
Thank you, ma'am. Thank you so much. So, shall I share my screen?
Yeah, sure. Yeah.
Yeah. Okay, fine.
Yeah, share your screen.
Okay, just would like to know whether I can. Are you able to see my screen, ma'am?
Yes. Can you slideshow, please, ma'am?
Yeah, please.
Just click on the slideshow so that then we'll know that.
No, this is, yeah, I had this problem yesterday too. I don't know. Are you able to see?
Yeah,
is in the
able to
first
see, ma'am, but not on the slideshow mode.
The same problem happened yesterday. 1 second.
Selvi ma'am, Satish here. Like
yes.
Shall I share your screen and you'll be able to...
No, I need to say next. That would be a problem.
Yeah, that doesn't matter. You can say next, he will help you.
Okay, are you able to see that? Yeah. See my screen is now.
Can you just maximize that, ma'am, below? Can you come down there and maximize the screen?
No,
No, it is a little down.
Yeah, 1 second.
Little more. Plus. Yeah.
Okay, just check.
Yeah, this is
okay. Thank you. Just 1 second. I'll just go to next slide. Are you able to see the next slide?
No, ma'am. We are there in the first screen.
Yeah, I don't know. I'm changing. I don't know. You're
no,
not
I
able
think
to.
You make the Avyaya people the host.
So yeah, please. Yeah. Then I stop share. Yes, fine.
To stop sharing.
Yes.
And then you just go on to saying next, they'll advance your slides. Yeah.
Yes, fine.
Thank you.
Yeah. Oh, yeah. But it is say stop share. Your yeah. You can share the screen. Yeah.
1 minute.
Yeah. The first slide. So I just take this opportunity to thank CIGI Group for selecting our paper for CIGI Award. And also congratulations, Modri ma'am. And it's so nice to hear your research work in various fields, and it is really pushing us to do further, do more for the kids for cochlear implant. Yes. Yeah. Shall I start?
Yes, ma'am. Good.
Yeah. The topic that I'm going to present today is effect of modified programming parameter and sound field threshold, speech perception, and CAP among children using CP802 processor. Presenter myself, T. Muthuselvi. Next. Next. Yeah. I think you skip one slide. So this is actually part of my PhD study. So where I would like to thank my guide, Professor A. Ravikumar, and Professor co-guide, Professor Madhuri Gore, my research advisory member, Professor Ajit Kumar. Yes, next. So starting up with introduction, the CAP is being very widely used to fit hearing impaired who are using hearing aids. And if you're able to do that for a hearing aid user, you should be able to do it for cochlear implantees too. Before that, as an audiologist, you should be knowing when you change a programming parameter, how does it going to change your sound field threshold and speech perception? And similarly, the CAP measure, does it change? And if both of it are changing, whether you can correlate this two. With that background, the present study was to investigate the effect of modifying programming parameter and behavioral measures, as well as acoustically elicited CAP measures. The objective of the study is to see the effect of this changing parameter. Here, what we are looking at only the T's and C's, and sound field threshold separately, speech perception separately, and objective measurement being acoustically elicited CAP responses. And next, to correlate this changes in CAP measures with behavioral changes. Yes, next. There was 20 participants participated in the study. All of them had a normal anatomy and uneventful surgery. And they have used the implant minimum of 1 year. And children with multiple disability, ANST, and deformed cochlea, now they were excluded from the studies. And also the children who did not have a CAP also were excluded from the studies. Next. And next. So this is a study participant. The details of the study participant, you could see the 20 participants details. The chronological age is 8 years, and they had the age of implantation is almost 2 years, and they had a sound field threshold with their everyday map starting from 27 dB to 31 dB HL. Yes, next. So we created the experimental map based on the everyday map. Here, the everyday map, what I'm trying to say is the map the child is using minimum 3 to 6 months, the stable map. And before looking at the experimental map, just going to say quickly about how did we create the everyday map. Is actually we followed the pretty much the regular protocol what we do in the clinics, where the T levels are set by where the child is perceived the electrical pulses 100% of the time. To set the C level, generally we used 3-point loudness rating scale, which you could see in the left side. As we are testing a child who are very young, and we just used a 3-point rating scale. And we set the C level when the highest level the child set is okay and medium, and this also rechecked with our the live mode. Yes, next. So just let's see how did we select this experimental map. Basically, along with everyday map, we had 6 map. There is 5 different altered map. The first is we kept the M or C level constant. We reduced the T level globally by 10% to say by the with reference to electrical dynamic range. The reference was used by electrical dynamic range because it was almost constant for all the participants. So if you expect in cochlear, the electrical dynamic range is somewhere around 40 current levels, then the 10% of it is 4 current levels. So we reduced by 4% with that reference to that particular electrode. And the other program, we increased by 10% and 20%. The next, we kept the T level constant, and we reduced only the C level by 10% and by 20%. So finally, we did a electrical behavioral measurement of sound field threshold and speech perception and your CEP measurement. We could see the changes only with respect to the 20%. So that's the reason we have taken this T increased by 20 and C reduced by 20 were taken as experimental data and used for experimental program. T was set at 10%. That was also taken because for the other part of the study, we need to compare it with metal and cochlear. So we did not have counterpart for 20%. So we had to selected T set at 10% below than that. Yes, next. And this just gives you the mean data of all the program. We carried out the behavioral assessment of sound field threshold and speech perception test were done using picture identification test by Tamilmani and Gore 2002. This actually test assessed the monosyllabic, bisyllabic and trisyllabic perception at 50 dB. And next. This actually gives you the parameter used to run your acoustically elicited CAPs. It's pretty much this regular parameter we used. The stimulus, what we used is BADAGA to get a responses across the frequencies. Yes. This is a placement or setup. When you look at the electrode placement, we also measured eye blink responses to just to remove your eye blink artifact from your CAP responses. And this is the setup followed where you're keeping the speaker at ear level at 1 meter distance. This is generally what we do in speaker at 0 degree angle. Next. And this is the gives you the parameter used to record your CAP, the stimulus parameter that BADAGA were used. Yes. And see, we measured acoustically elicited CAP starting from 80 dB to 40 dB. We reduced by 20 dB. If you get a responses, if you don't get a responses, we increased by 10. And in the end, we got 3 variables here. One is P1 latency and amplitude at 80 dB and CAP threshold. That is a minimum level where you are able to get the P1 peaks. That is considered as CAP threshold. Yes. And the blinding followed for the studies, actually minimum 2 clinicians were involved for the study, where the clinician 1 always did a acoustical CAP measurement. The clinician 2 did a behavioral measurement, where the clinician 2 were really did not know what was the program being loaded in the processor, as well as the response of the CAP measurement. Overall, 10% of the participants we retested again within 2 to 3 weeks duration. So their reliability scores were ranging from 0.8 to 0.9 to say that the response what we got was reliable. And the data followed a normal distribution curve. So we ran a one-way repeated measure ANOVA to find main and interaction effect of sound field threshold across the frequencies, starting to 250 Hertz to 8 kHz in 4 different programs. Similarly, the stimulus used, that is mono, bisyllable and trisyllables for speech perception across the everyday program and the experimental program. Also CAP measures like a threshold, P1 latency and amplitude in all 4 programs. And further, we did a Pearson correlation to correlate the changes behaviorally with CAP measurement. Yes. Coming to the results, and the results were given over here as per your objective of the studies. The first objective being to see the changes in the programming parameter and sound field separately, speech perception separately, and CAP measures separately. So let's see one by one. So if you look at the color coding, so throughout the presentation, I would have used black for everyday, blue for T reduced, and green for T increased, and red for C reduced. So you can just follow the same in your mind. So actually, when you look at your threshold, when you look at it, the black one and blue one and green one is almost overlapping. That means to say the changes in T's actually did not have any effect on sound field threshold. Further, the C level led to poorer sound field threshold. So this was something that was like kind of interesting. So what we expected was when we increase the T's, the sound field threshold should improve. That's what we generally used to do in our regularly in our clinic. All of us do it. But again, I think is the 20% increase is equivalent to 8 current Can you hear me now?
Yes, ma'am. Go ahead.
Yes. So next slide. I think did you hear this?
A bit of it, ma'am. I think at the end.
Okay. Okay. So what you can know is when you reduce the C's, the threshold is actually becoming poorer. So even though you keep your T's constant and reduce the C, the threshold is becoming poorer. I think it's mainly because of the reduction in the dynamic range. Yes. Next slide. So next is speech perception. So when we compare the speech perception between your everyday map and T, when the changes in T's, the speech perception was poorer, but there was no significant difference. But you could see only when you reduce the T's, there is a significant differences with respect to speech perception, which was almost similar to a sound field threshold. Yes, next. And this is also similar to your sound field threshold and speech perception, where we did not find the differences with changes in T's. Whether you increase it and decrease it, there is no changes happening in CAP threshold. But when you reduce the C's, the CAP thresholds are becoming poorer, as you can see it from the red one. Yes, next. So P1 latency and amplitude, we got some interesting findings actually. So when we here you compare your black one versus to your blue one, even though the P1 latency is poorer when we reduce the T's, but actually it was not statistically significant. But on the other hand, when we increase the T's from the actual T's, the P1 latencies are becoming better. So it has been shorter. That is to say that the conduction is faster, the audibility is better, though there was no significant difference we could see in sound field threshold, either CAP threshold. And expected when we reduce the C's and latency became poorer. Yes. And the similar things with amplitude, there was no changes with T reduced, and but we increased the T's, the amplitude became better. That is also indication showing that the audibility is better, though there was no differences in the sound field threshold. As expected, when we reduce the C's and the amplitude is actually poorer and it is reduced. Yes. So this is an important slide to answer to your first objectives. When we reduce the T's, what is happening to the behavioral measure? Actually, there is no significant difference. Similarly, with the CAP changes, there is no significant difference. Similarly, when we increase the T's also, there was no changes with the behavioral measures. And with respect to electrophysiological measure, there was a changes seen with P1 latency and amplitude. But when we reduce the C's, all the three measures, whether it is a behavioral, whether it is physiological, it is becoming poorer. So that is to say, to answer to the first question, when we change the programming parameter, does it change behaviorally? Yes, the answer to it. Does it change behavior electrophysiologically? Yes, there is a differences in the CAP measurement, but it is only the changes with respect to C level, not so with T level. Yes, next. Yeah. So this is actually put in all the individual waveform, follows almost similar trend, and the black one shows the grand average. Yes, next slide. Yeah. So this is a final one where you have a grand average of all the intensities for each program. So when you look at your P1 and P1 latency and amplitude for 80 dB, actually we are not able to appreciate so much differences in P1 latency and amplitude. Except the red one, you could see there is a reduce in amplitude. And when you come further to 60 and 50, also not much changes. But only if you look at 40, that is the softest level, you could see the P1 latency with the baseline program, that is your everyday program, and T increased. So the 40 dB, the P1 was absent for C reduced as well as T reduced. So what is that clinician has to look for here is, in programming, if you want to have to validate the programming changes using CAP, please look for the softest intensity, don't look for the high intensity. So softest intensity at 40 dB actually shows the difference, not so at the high intensity. Yes. So this is a correlation graph we could see between your behavioral measures and CAP measures. For this correlation measures, we have taken the everyday program and the program where you found C level being dropped down, because only that program there is a changes behaviorally as well as CAP also, electrophysiologically. So here, if you see the first, you could see the stimulus used in CAP and CAP measures and sound field threshold and speech perception. As expected, the CAP threshold were correlating with the sound field threshold. But we expected the stimulus used, that is bar, being low frequency transition, should F2 transition should correlate with low frequency sound field threshold. Actually, that didn't happen. It was correlating very randomly across the frequencies. That is, we suppose that the presence of I in bar aga, that is making the stimulus not so frequency specific. So that's the reason we are seeing correlation across the frequencies. And P1 latency were correlated with the sound field threshold, and P1 amplitude, as expected, is being correlated with your speech perception scores. Yes. So this scatter plot shows the correlation between your sound field threshold and CAP threshold, and sound field threshold and P1 latency, and speech perception with P1 amplitude. And we could get the correlations ranging from 0.4 to 0.8, being moderate to strong correlation in some. Yes. So coming to the conclusion, to answer to the first question, can you use CAP, that is acoustically elicited CAP, to validate the programming parameter? Yes, the changes in Cs can be used to be validated by your CAP measures. At least with respect to I don't want to give your generalized statement saying that the T level cannot, the changes in T levels cannot be validated by CAP. The percentage of changes what we had is the T is reduced by 10 and T increased by 20. That changes did not have any effect in sound field threshold as well as CAP threshold. And as a clinician also, we can ensure that at least within this one, if suppose if at all if the child was not giving reliable responses, and if you make these changes within this particular level that did not affect your behavioral measures and as well as UAP measures, that is measurable significant difference were not seen between this. Yes, thank you. Next slide. So I would like to thank CG Group for selecting our paper for the award, and I would like to thank our cochlear implant team of Sri Ramchandra Institute of Higher Education and Research for helping me in recruiting these patients. And I also would like to thank our universities and HODs and in the Department of Speech, Language and Hearing Sciences. Thank you. I'm happy to take any questions if there is.
Thank you, Muthu Selvi, for lack of time. We will not be asking questions. Thank you very much. Your prize and your award will be sent to you.
Okay, thank you, ma'am.
Shortly. Yeah.
I think I didn't exceed much time. Yeah.
Yeah. So now I would like to invite Dr. Kapil Sikka, who's the principal investigator of the SIGI Research Grant Project, which was a pilot project, clinical and social outcomes of cochlear implantation and older pre-believers. Kapil, are you there?
Yeah, I'm there.
Yeah.
Thank you so much.
So you want to share your screen right now? Yeah.
Just give me 1 minute. My Zoom is not allowing me to share it. Just give me a moment, please.
No issues.
अतुल एक बार देखो. I request organizers to let me in from my other device.
Can you help Kapil to come into from the waiting room? Kapil is not able to log in from his other device. He's trying from the other device. Can you help him, please? Backend team, Abhaya.
Yes, ma'am, I am in.
Doctor, please log out from one device, doctor. Doctor, please share your screen.
So is it visible?
Yes, doctor. Can you make slideshow?
So it's visible and audible?
Yes, doctor. Please go ahead.
Yeah. Thank you, Nishita ji, for a nice introduction. And my talk for today will be on clinical and social outcomes of cochlear implantation in older prelinguals. I have a long list who I cannot fall short of acknowledging, and I have listed them here. Particularly thankful to Cochlear Implant Group of India Executive Committee for funding this research for last 3 years, and thankful to research section at All India Institute of Medical Sciences for letting us do this research project. So project, as I have put, is on clinical and social outcomes of cochlear implantation in older prelinguals. If we look at older prelinguals, then this gap of 5 years, it has caused a lot of fear and trepidation amongst cochlear implant community, fraternity. Many funding agencies, they are wary of funding these patients once they cross the age of 5 years. They are right in doing so because there is ample amount of literature worldwide which says that children who are young, they do better as compared to those who have grown older. But I will present before you some harsh truths about Indian CI programs at most institutes. Many kids, they come to us when they have crossed that age of 5 years. Late presentation is a reality. A couple of years back, we analyzed our own data on more than 100 cochlear implant recipients and found that our average age of implantation was unfortunately almost 4.8 years. And there is certainly, I looked at literature very recently, there are a few studies from Indian subcontinent also, but by and large, I would say there is dearth of data to determine the efficacy of CI in older children, how exactly they are doing. This is an editorial from few of the most respected members of our fraternity, and they had put it, and I quote, although associated performance in older late childhood kids may not parallel normal hearing age matched individuals, but the benefit in terms of communication that cochlear implant gives, it cannot and should not be negated. So aim of my study or our study was to determine the effectiveness of CI in bilateral hard of hearing late implanted prelingual patients on various outcome measures. We had taken various outcome measures: speech understanding, language abilities, auditory performance, and subjectively perceived benefits. So for auditory benefits, we used CAP and speech discrimination and speech awareness thresholds. For speech, we evaluated using SIR scores. For language assessment, we used RILS, and later on the CG expert group also recommended SECS scores, which I'll be coming on shortly. We had some objective and newly developed questionnaires for pre and post educational profile and social behavior. And we also evaluated how the parents were satisfied pre and post implantation in these group of individuals. So the study was an ambidextrous study for a period of 3 years. We started in 2018, practically in 2019, and outcome measures were to be examined in children who were implanted after they have crossed age of 5 years. That is the critical age of CI. We initially planned to include all the kids, but CG expert group recommended that outliers should be eliminated. So we considered upper age limit as 15 years. The proposed sample size in our study was 60, but we crossed that and we have included 113 subjects in our study. The obvious poor prognostic parameters like spectrum, auditory neuropathy, spectrum disorders, intellectual deficits, they were excluded. And we had a designed performa for filling up the parameters and the follow-ups. We applied for ethical clearance and got a due ethical clearance for Institute Ethics Committee. And this is the picture of performa which we used for entering pre and post-operative questionnaires and parameters. The materials I have already elaborated included auditory abilities, CAP and aided thresholds, speech audiometries, the subjectively perceived benefit scales, the language performance scales, and speech performance scales. For those who are new to the subject, the categories of auditory performance is one of the most commonly used auditory perception benefit scale. With 0 indicates no awareness of environmental sounds. With 7, the patient can use a telephone with a known listener. SIR scores are most widely used speech outcome parameter, which includes pre-recognizable words in spoken language. If this is the outcome, then it is SIR score of 1, and 5 is that the speech of the child is intelligible to all listeners, irrespective whether they know the child or not. So we did follow up at regular intervals, 3 months, 6 months, 9 months, till 24 months, and all details and scores, they were tabulated in Excel sheet for analysis. There was pandemic which hit us badly. So all kids could not come at all follow-up intervals. So if a patient did not come at 6 months follow-up, we averaged his scores at 3 months and 9 months and so on. Statistical analysis was done by my colleagues from Department of Biostatistics, and there were standard statistical tests involved. Most frequently, to put it, are paired t-test for normal distribution, and without normal distribution, Wilcoxon's sign rank test. We recruited 113 subjects, 64 were male and 49 females with age range of 5 to 15 years. 67 were enrolled before the initiation of study. So they were following up with us, implanted before the initiation of study, and 46, they were implanted after we initiated the study. So total of 113. Median follow-up was 33 months with shortest of 3 and longest of 96 months. As expected, the most frequent etiology was idiopathic. Almost 80% of patients did not have any specific etiology for their hearing loss. 14 patients reported some radiological abnormalities. We are not very fond of implanting. We are very skeptical in implanting very severe malformations. So most of them, they were minor radiological abnormalities. Age of hearing loss, mean was 35 months. That is the diagnosis of hearing loss. Hearing aid dispensing was 40 months and cochlear implantation was 74 months. We also evaluated the socioeconomic scale of these patients. As you can see, most of them belong to lower middle and upper middle socioeconomic status. 78 out of 113 had single language exposure and 29 had bilingual exposure. Only 3 had reported intraoperative complications. All of them were fortunately minor. 1 had a CSF leak and 2 had a bit traumatic CSF, electrode insertion. 104 subjects had good ECAP responses, and in 9 of them, the ECAPs could not be obtained in all electrodes. First parameter was how they were using hearing aids and what time they were using cochlear implants after implantation. So it showed significant improvement. If we looked at time for which they used hearing aid before they came to us, only 35% used hearing aid for 10 to 15 hours, which increased to 84% who used cochlear implant for 10 to 15 hours post-implantation. I was very concerned that we will have many non-users. So patients who reported that they use cochlear implant occasionally, that is less than 3 hours, they were considered as non-users. So in our series, out of 113, there are 7 non-users. Out of them, 3 has never used cochlear implant and 4 were occasional users. Pre-implant regularity, the commitment was taken into consideration before and after implantation, and most of them, they followed in a good regularity in attending therapy sessions. You can see that most of them attended at least 50% of recommended therapy sessions to them. Categories of auditory performance was the first parameter that we looked at, auditory parameter that we looked at. So we have already seen that it ranges from 1 to 7. Pre-implantation, the average or median range was 1, and post-implantation, it increased from 1 to 7. It was a range with a median of 5. So more than 60% of patients, they have reported CAP scores at this median follow-up equal to or better than 5. So we also put a map that is showing a cross-sectional view of average CAP scores at follow-up intervals, and we have represented in a graph. You can see that CAP scores, they start improving 3 months after implantation. They keep on rising and sort of plateau at 24 months. I have also put this graph because we might be asked how they compare if we correlate them with the early prelinguals. So I did not evaluate our own early prelinguals, but we have put in what literature says in a study by Fang et al. And you can see that they clearly lag behind. And this is the approximate lagging curve that you can see. SAT and SDS, they were also evaluated. Mean awareness thresholds were 73 decibels pre-implantation with hearing aids and 45 decibels with cochlear implantation post-operative. 78% of patients had SATs of better than 50 decibels. That is a good thing to know. Pre-implant, unfortunately, we do not routinely got the close set word recognition or discrimination scores in all the patients. We had only in 7 subjects, either because of minimal benefit with hearing aid, it could not be done, or it was not done. It ranged from 4 to 20% with a mean of 15%. And post-implant, we could do it in 90 subjects, and scores range from 8 to 100% with a mean of 79%. To put it simply, 70 out of these 90 subjects where we could get these SDS scores, they had a closed set word recognition of better than 60%. Speech intelligibility rating, I must confess that our patients are poor speech performers. Their speech abilities, they do not reach even close to normal, and median speech scores which were reached were in range of 1 to 3 with a median of 3 post-implantation. They got better, but not to even close to normal speaking children. 73 out of 113 had SIR score 3 or better, and 3 SIR score, I personally don't grade it too good. So I have again plotted it on this map. It starts improving after 3 months and plateaus by the time of 24 months post-implantation. Again, put it on Fang's study, and you can see the SIR scores also lag behind the early prelinguals by this much margin. RILS and SECS, I am frankly not an expert, but my audiologist and habilitationist friend, they helped us a lot in doing receptive, expressive, emergent language tests and scales of early communication skills. They are not universally applicable because I was told that you cannot really rely on that after the child crosses 8 or 9 years of age. But we did measure them to the best of our abilities, and you can see that there is a progressive increase in both receptive and language abilities of the individuals as the time progresses post-implantation, applicable to RILS as well as SECS scores as seen in this map. Mode of communication was one of the parameters that was close to my heart personally before I started this study. So you can see that 81% of patients had manual communication before they were implanted, and it reduced to 9%. So they were more of hint and sign language users before implantation, which reduced to 9%, and oral communication, it increased from 4 to 35%, although long way to go. Mode of communication in kids, you can see that 44, this is how parents communicated with kids. 44% of parents use spoken communication after implantation, contrast from 10% pre-operatively. Educational profile, we wanted to evaluate how many we have been able to mainstream if we consider schooling as a important mainstreaming parameter. I'm sorry, I'll take just 2-3 minutes more. Pre and post-implant educational status was compared. This is the pre-implant educational status. This has a bit of bias because of COVID pandemic, most of the parents who wanted the kids to go to school, they could not actually mainstream them. 43% of kids went to normal schools pre-operatively, which rose to 62% post-operatively. So we had developed our own questionnaires. This is our questionnaire, how the child gets along with other children. They are effortlessly coping with schoolwork, doesn't stay home and does not show any reluctance to go to school. Pre-operatively, the average questionnaire was 2, and post-operatively it rose to 4, which was statistically significant. One of the most important parameters, according to my own perception, was parental satisfaction, which rose from score 1 in most of the cases to score 8 in most of the cases in post-operative. So more than 70% of our parents, they scored implant better than 7 on a 10-point rating scale. Conclusions, results reveal observable and statistically significant improvement post-cochlear implantation on auditory abilities, communicative abilities, educational profile, and social aspects among studied population. It may not parallel implantation at young age, definitely, but it can still be useful in establishing good communication in children, and agencies, they should rethink strategies for late implant funding. Better studies should be designed, and possibly a matched pair analysis, which we at our institute are doing it with one-to-one comparison on between older and younger prelinguals. And we also need a uniform template for outcome reporting across all age groups. Thank you so much.
Thank you, Dr. Kapil, on presenting the CG Research Grant project. That concludes our pre-lunch session here for on the 13th of November. Our next session is scheduled at 2 o'clock. We will resume proceedings from 2 o'clock onwards. So which would mean that there would be a very short break for lunch. So I would request you to have your lunch with you along with when we start the proceedings at 2 o'clock. So let's have a quick lunch break now. And I also the post-lunch session, all the presenters to stick to time because we have a general body meeting which would be starting sharp at 6 o'clock. So I request all the speakers and the presenters and the panelists to adhere to the time. And let's meet up at 2 o'clock after a quick short break. Thank you.
Okay. Good afternoon, ladies and gentlemen. Good afternoon, good morning, good evening. We begin the second half of the proceedings for day 2 of the scientific program of CIGICON 2021. We now have an hour of MEDEL symposium, a company symposium by MEDEL. MEDEL have been very graciously supporting CIGICON. CG in the past and all the CIGICONs that we have conducted. And this time they're the sole strategic partners, educational partners. And we're very grateful to Dr. Ingeborg Hockmer, Alexei, Sebastian, and very importantly, Mr. Tejinder Singh, who's the India head of MEDEL. And we have about 40-45 minutes of scientific content within this symposium. Thank you very much for this support, and we really appreciate it. Let's go ahead and start the symposium. Over to you, MEDEL India.
Good afternoon, friends. At the very outset, I would like to welcome you all to this MEDEL Online Symposium at CIGICON 2021. This is the 18th edition of the Cochlear Implant Group of India Conference and the 6th edition of the World Congress on Cochlear Implant in Emerging Nations of the Global Cochlear Implant Access Network. I would also like to take this opportunity to thank Dr. Sunil Dutt, the organizing committee and the organizing team for putting this conference together and enabling us to participate and inviting us to participate at this symposium. The past 18 months have been very trying times for all humanity with COVID-19 pandemic situation. We've all been in the same storm, but maybe in different boats. And it's nice to see that we can once again all gather together, though virtually, discuss science of hearing and hearing solutions, especially the implantable ones. We look forward to meeting you all in person at the next conference in 2022 and hoping for a safe future for all of us. Coming to our symposium, it's an honor for me to introduce the program and the 2 speakers and to welcome them on our symposium. The first topic of the day will be sharing best benefits, which will be presented by Ilona Anderson, our Corporate Director of Clinical Research at MEDEL Worldwide Headquarters. She is well known to all of you as she has been participating at several conferences around the globe, and she will be talking about the best benefits. The second speaker of the day at this symposium is Pooja Behra, who is Rehabilitation Manager, User Engagement with MEDEL India. She's going to be talking about Rehab on the Go, which is basically about the MEDEL rehabilitation materials and their applications. We hope you enjoy this topic too. So welcome once again, and we hope you enjoy the symposium, and I will now hand over to the speakers for their presentations. Enjoy the conference and wishing you all the best in the future. Thank you, and do visit us at our exhibition booth also. Thank you.
Hi everyone, and greetings from across the ocean. My name is Ilona Anderson. I'm the Corporate Director of Clinical Research. Today I really want to show you how well MEDEL does to show best benefit, all based by evidence. MEDEL really has a unique design quality. We have a user benefit of over 200,000 people, and all our devices are approved based on scientific evidence, and the same thing for all of our indications. MEDEL has really a number of unique design features. Firstly, fine hearing sound coding technology, which assists with place coding. It has variable rate of temporal coding, and it allows us to reach closest to natural hearing. We also have free-fitting electrodes, which are really good for atraumatic insertion and superior flexibility. And this really helps keeping our cochlea survival in an atraumatic way. And this is also based on the array, which covers 2 full turns of the cochlea. It reaches the apical area, which by stimulating allows close to natural tonotopic pitch perception. Now we're going to look at hearing preservation. And as I said earlier, everything is backed by evidence. So in the corner of all the evidence slides, you will see the number of publications this data was taken from. So first we look at superior structure preservation, and way to look at that is scalar dislocation rates, and here we have them across manufacturers. Medel has a 4.1% rate of scalar dislocation, compared to another company with 28% and another company with 24%. And what you can see here in both of them is it's a higher rate of scalar dislocation with a perimodiolar electrode. And if we look at studies of mixed manufacturers, you can again see that lateral electrodes are really much better to prevent scalar dislocation across manufacturers. So in essence, if we look at everything, there is about 275 ears that have scalar dislocation. So overall, it's about 19.7%, which is really a high number. So that's why we should be focusing on using lateral or electrodes. Here, we can look at other evidence of structure preservation. And again, it looks at the number of studies. You can see that on the left side. And again, what the evidence out of all of those are. So for Medel, we could say there's 10 standard deviations out of 242 cochlear implants, which results in 4.1%. And we can see the numbers for the other 2 companies with a greater result, say, of 23%, 27% as an example. Right. We also look at superior hearing preservation. And here there were 5 publications which compared the manufacturers directly. And we show superior hearing preservation rate because we have a higher rate of full and partial preservation. So here you can see that over a longer term hearing loss, we have 11% of our population who lose hearing loss, compared to another company which has 36%. If we look at it the other way around, we have complete and partial hearing preservation in 78% of candidates or users in the study, compared to, say, 54%. And again, a lower number for hearing preservation loss. And between the two, you can see that there's significant difference between us and another company. Independently, just looking at our electrodes, we have done a post-market study for EAS, and we looked at the preservation rates determined by the Skarzinski scale, and we show stable long-term hearing preservation over 5 years. So our results in the end say we have 74% chance of hearing preservation at 5 years. And here we see at 5 years, we've got 12% of users who have complete preservation and 62% of users who have partial consideration, and that's how we get to 74%. Now, let's take it another step further. Not only do we have good electrodes with no scalar deviation and good hearing preservation, we also have complete cochlear coverage. And this is because we have longer meta arrays, which means we also have smaller deviation from the spiral ganglion. And our monosyllables are better for scalar tympani insertion provided by the Medel electrode rays. So that's really key. Here you can see that there are a number of different arrays from us and other companies. We can also see the electrode length. So we are going furthest into the cochlea with up to 31.5 millimeters, whereas the other companies, their lengths kind of match our medium electrode array, which means we have a really larger angle insertion depth so that we can really reach into the apical region of the cochlea, which can be stimulable. And if we look at this, we can see our hearing performance. With our Flex Staff, results show 92%, and with our Flex 28, 81% on those CNC scores, where they are much lower on the shorter electrode arrays from other companies. So what are our key features with complete cochlear coverage? A lot of publications show better vowel and consonant recognition. We show improvement in speech, perception in quiet, and in noise, which is really important because that's a really difficult listening situation for anyone. We have the lowest pitch perception, which is influenced by the depth of insertion because we really go to those low frequencies. Results also show that we're better music rating, and our place pitch match is much better in our studies with complete cochlear coverage. By looking at our longer electrodes and the fact that we have complete cochlear coverage, one of the key elements that now comes out is fine hearing. So with fine hearing, we say MED-EL is unique because no one has this kind of coding strategy. It means we can use a longer electrode array and also more closer to natural place and rate stimulation. And this, according to one surgeon, says we have an unparalleled restoration of tonotopic pitch perception. Unparalleled. And I think that's something we need to consider in how we create best benefit for our users. So with fine hearing, our fine structure coding strategies allow highest hearing quality because we have tonotopic coding, which gives us place, and temporal coding, which gives us rate, and no one else has that mix. All other strategies only use the fixed rate coding, so they don't really get that base that we need. In fine hearing, we know that natural hearing means the second term. This is absolutely key to have fine hearing. With our temporal or rate coding, like I said, that covers the mid to low frequencies, and each cycle of sound wave opens and closes a hair cell response, and it really is a one-to-one rate, which gives us precise natural frequency tuning. However, we also have tonotopic or place coding, and this really stimulates the high frequencies. And these hair cells are at frequency turn place trigger action potentials. So we can mix here place and rate, so we cover both the mid to low frequencies as well as the high frequencies. So this allows precise natural frequency tuning. So we have fine hearing, we have superior structure, we have hearing preservation, we have complete cochlear coverage. So this allows us to have closer to natural hearing, superior sound quality, as well as superior speech performance and sound source localizations. So let's look at that superior speech performance. Okay, with this we have a number of studies comparing MED-EL and another manufacturer. Of these 8 studies, with 853 subjects, 6 studies showed that MED-EL was better, and the other said they were the same. If we look at ourselves, so MED-EL pre to post-operative, we have 8 studies showing 311 subjects, showing significant improvement in speech in quiet, speech in noise, and sound localization. And again, that is because we have our hearing preservation, our structure preservation, and our complete cochlear coverage. So, with this complete cochlear coverage and fine hearing, we provide better speech in quiet and noise, and sound quality, and music perception over a large number of studies. We also have great audio processors, and I think this is very key as well, because yes, we have great technology, but we also have to have processors that really help provide that great technology. So we have off-the-ear and behind-the-ear processors, and they give similar benefits for our users. So we have microphone directionality and ambient noise reduction, and studies have shown they give us better speech perception in quiet and noise. We also have wind noise reduction, which provides better perception in wind, because that's always a difficult thing. It is like another kind of noise. Our microphone directionality and ambient or transient noise reduction reduces our listening effort. So it makes it much easier to listen to when we can get rid of that background noise. And of course, this is done because we have an adaptive intelligence which adjusts the processor according to its signal type. So that is according to if there's noise in the background or not. This also brings an important thing, which is sound quality, because it's not just what we measure in a soundproof booth, it's what the person perceives out there. There are 4 elements to this: sound quality, music, quality of life, and speech in quiet and noise. So sound quality, we've seen, for example, that bilateral cochlear implants provide greater benefit to our users. We also know that telephone use is satisfactory, not only on handhelds, but also on, the old-fashioned telephones versus our smartphones of now. And we've also seen in publications that fine structure improves scores for tonal language speakers. So we do cover the range of linguistics here. And we also know when reaching the apical regions, that sound quality is closer to natural hearing. And we've also shown studies on exceptional sound quality for quality of life. This is really important. How does that person feel? By providing our fine structure processing, it significantly improves quality of life on a number of questionnaires. And we also show a significant improvement compared to another manufacturer on daily device use, child's acceptance, and what the parents believe is the right choice when they looked at quality of life for their children. We also see music, really, really important. We get a richer music experience because of fine coding strategy. And we can see that we can have different sound quality ratings based on whether we have full bass or a stimulus version or no bass at all. And you can see here when we have that fullness of sound, we get a better sound quality rating on music. Increased music perception has important because we know that a lot of people with hearing aids did better than with CIs on music, but with fine structure, it's more natural, less tinny, and more reverberant, and a lot of appreciation. So we see here that closer to natural hearing gives us reference to natural pitch, long electrodes, and fine structure processing. I like this quote. One patient indicated the signal constructed for the normal hearing ear was a complete match to the sound of CI in her other ear, and that is from a single-sided deafness user. Finally, we create all of this, and all of this is really important, but in the end, your users need to know about reliability. And for us, we have really exceptional reliability, and that's the ability of an apparatus to consistently perform its intended function without failure. And you can see here our hard and soft device related issues, medically related issues, no tip folder, and you can always look at updated rates on our medal.com website. And that, I want to thank you and enjoy your conference. Regards.
Mum and Dad, almost 20 years ago, I came into your life. You said that having me was the greatest gift you could imagine. But there was something wrong. Your child couldn't hear. People said that we simply had to live with it, to accept the circumstances. But you didn't. You wanted the best for your child and made a courageous decision for a revolutionary treatment. A tiny miracle implanted in both of my ears. I was only 2 years old, but I still remember the day when sound came into my life. Back then, you set the stage for me to not only hear, but to speak, to learn, to express myself, and to be able to do what I love. Thank you, Mum and Dad, for giving me the greatest gift I could imagine.
Hey, Mom.
You feeling better already?
Not sure. I'm still feeling it.
That little injury won't stop you.
Yeah, I really hope so.
Hello everyone. I'm really excited to talk to you all about what's new in rehabilitation in middle. I'm here today to talk on rehabilitation on the go, apps for professionals and parents. I'm sure this scenario looks pretty familiar to the most of you, wherein we are pressed under tons and tons of score sheets, files, reminder post-its of our caseloads. Wouldn't it be nice if all or some of the bulky files, folders, and notes were available at one place, a place which you can access from anywhere? I'm glad to say that it's possible now. We at Medill, in our initiative Rehab on the Go, have launched more apps for professionals and parents. And from those apps, today we are going to discuss about the Child Journey app and the Little Ears Auditory Questionnaire app. But why should we be using apps first of all? What is the importance of apps? Well, when we use apps, it becomes as one place to store all our reports. So no more looking into several files, several thick folders, several books, several notebooks to see how the kid is doing. But all you have to do is just open the app, go to the child's name, and then see all the test results that you have conducted on the child. It's easy to show and discuss progress on iPad or tablet screen, either to the parent or with other professionals, or if it is an adult recipient, then to them. Sharing reports is no longer difficult. You don't have to think, oh, how do I take a photocopy or how do I give this to the family? All you have to do is just click on the send button, and then the report gets immediately emailed to the family or to the recipient or to any of your co-professionals that you want to share the report with. If the test that you're using has bars or has graphs or has visual representations, then that becomes easier to show the progress when you are seeing it on a tablet or an iPad screen. If you have entered more than one patient and if you have tested more than one patient, and then you can compare how each of those are doing, and then you will be able to visually see the representation of the trends of outcomes at your clinics. And of course, easier interdisciplinary discussions are possible because of the usage of apps. So the first app that we are going to discuss today is a Child's Journey app. If you all know about the Child's Journey material that we have already, it is available with us in a booklet format, and it is used to assess on all of these 8 domains. Along with the booklet format, what we have come up now is an app format. So with the Child's Journey app, rehab professionals can keep every child's goals and progress at their fingertips. The app tracks 8 different developmental domains so that clinicians can identify a child's current skill level, find out areas of concern, and select goals to focus on in therapy. A Child's Journey is suitable for assessment and monitoring of children from birth to 6 years of age, and this is available for download on the App Store or on Google Play Store, and currently we have it available only for iPads or tablets. This is how a page of the booklet format look like, wherein you can see that the skill receptive language and the age range of 30 to 36 months. So what we had to do earlier was, if a particular skill was present, then we would have to think whether it was emerging or whether it was mastered or whether we want to take it as a goal. And then you had to mention the date. But now this is how the app format looks like, and this is the home page of it. So on the home page, there is an introduction to the material, and then a small write-up on all the domains describing what the domains are. There is a possibility to enter background information about the child, like the name of the child, the date of birth, hearing loss related history, hearing device related history, language usage history, communication approach related information. All that you can mention in this child background information. And then once that's done, you could select the skill that you want to test in the middle, top middle here, like that. Say for example, this is what expressive language between the age of 0 to 12 months looks like, and all you have to do is read the questions and then compare with your child and then mark whether it's a goal, whether it's emerging, or whether it is mastered. This is how audition looks like, for example, in the 4 to 6 years age range. A very nice thing about this is you also have an option to see only the goal or only the emerging skills or only the mastered skills, or you can see all of them together. So that thing is also possible here. So how do we mark? How do we mark? So the guideline is that the goal indicator is noted when a skill is expected for a child's age or stage of development, but has not yet been demonstrated by the child, meaning you will be working on it. So the goal portion is ticked. When do we mark it as emerging skill? When a skill is expected for the child's age or stage of development and has been demonstrated by the child, but then it is inconsistent. Like, some occasions it's there, but some occasions it's not there. Like about, 50% of the times a child is doing and 50% of the child is not doing it. Then it is advisable to mark it under emerging. And then the mastered indicator is marked when the particular skill is observed with more than 90% consistency. So then you have to tick on the mastery level. So this is an example of play skill, and you can see that starts collections, that's mastered, plays games with rules, that's emerging, organizes other children and props for role play, probably that's not applicable, so that's not marked. So sometimes what happens, a particular thing is there, a particular skill is there, but you might want to make some notes, right? Plays games with rules, that's emerging, but then this child plays rules with games only based on the games that are interesting for the child. Then you might want to make this note somewhere, right? So there is a possibility to add on those notes also in the app. And then finally, this is how the results look like to the tester. And once the testing is done, the tester can email the results to the parent or to whosoever they want to do that. And then this is how it looks like. On the receiver's end, this is how the report they will get like. So there is a description of what is a goal, what is emerging skill, what is mastery, and then again a summary of the results. So this was the Child's Journey app. Moving on to the next app that we have of our very popular material, the Little Ears Auditory Questionnaire. So earlier it was there in booklet format. The booklet format is still available with us, but we thought, hey, why not have it in app format as well? So we have the app format now. And then the Little Ears Auditory Questionnaire app helps families and professionals assess the auditory skills of children up to 2 years of age. This quick and easy tool can help alert caregivers or therapists to delays in listening development, as well as it can be used to monitor progress. And with these apps, families and professionals can share and send reports even when they are not able to meet. Again, like the Child Journey app, this is also available on the App Store, on the Google Play Store, and currently available only for iPad and tablets. So this is how the booklet format of it looks like, wherein you had the questions, the answers, and then example. This is how the homepage of the app version looks like. So there is a description of what the tool is, and then a guideline on how you are expected to complete this particular questionnaire. Again, like the Child Journey app, even with the Little Ears Auditory Questionnaire app, there is a place wherein you can make an entry of the child's background information. Some fields in this are mandatory and some are optional, but it is advisable that all fields are filled for better documentation purposes. So this is how the test format looks like. So there is auditory response, which is the question. Then there is an example so that you can explain it to the parent, like what you exactly mean when you're asking that question. And all you have to do is if the child is exhibiting that behavior with more than 80% consistency, then put a tick in the checkbox, like put a tick. And if you know it's dicey, sometimes the child is doing, sometimes the child is not doing, it is not consistent, then maybe the cross checkbox you might want to choose. So on completion of the test, this is how the results look like. So you can see all the green check boxes are those skills that the child has achieved, and then the all red crosses are the skills that the child hasn't achieved. So the second page of the result sheet looks somewhere like this, wherein a graph is formulated, and then on this graph you can compute the total score against the hearing age of the child. So if you look at this black line, black arc here, that is where the child's responses should be based on the normatives. But if it's between this black arc and this lower black arc, then you know auditory development is happening, but still more development is possible. But if the responses of the child are in the blue shaded area, like in this particular case, then of course there is some matter of concern, and this needs to be delved, dig deeper, right? So this is a wonderful tool to discuss with the parent. Like we at clinic, sometimes we might not know what is going on in their house, that auditory development is not happening, or what are the red flags that we might not have noticed. So using this tool, you can talk to the parent, share their reports, and then talk about the overall progress of the child. That's not it. We have more digital resources, like we have the Common Object Token Test app, we have the Here Today app, and we have the Auditory Skills Checklist app, which is again available at App Store and Play Store. And these three apps are available on iPads, tablets, as well as smartphones. You can scan this QR code and visit our webpage to have a look at these apps and then download if you like. I'm going to display it for some more time so that you all get some chance to scan the QR code. Okay, so thank you for listening to me. And for more information about rehabilitation or about these apps, please feel free to write to rehabilitation.india@medal.com. Thank you so much.
A very good afternoon to everyone attending our medal symposium at the 18th CIGICON and 6th World Congress of Cochlear Implants in Emerging Nations. I'm delighted to present this vote of thanks to our organizers, speakers, and all the attendees. On behalf of Medal India, I would like to express my gratitude to the speakers of the symposium for their presence and contribution to make this a great success. I extend my gratitude to our director, Mr. Tejinder Singh, for opening the symposium and for inspiring and encouraging us with his words. A special thanks to Dr. Ilona Anderson, Corporate Director of Clinical Research, Medal Austria, for brilliantly putting forth the USPs of Medal that enables the user to achieve best benefit. I extend my gratitude to my colleague, Ms. Pooja Behra, Rehabilitation Manager, User Engagement, Medal India, for sharing what's new in Medal Rehab and for specifically shedding light on the rehab apps for professionals and parents. At this hour, I must thank the organizing team SIGI for working relentlessly to showcase our online symposium. I also would like to congratulate SIGI and GCIAN for the excellent techno-scientific feast during this conference. Lastly, I would like to thank our entire medal team for working so hard to put this online symposium together. Thank you, everyone, once again. Enjoy the conference.
Okay. Go ahead. Thank you, India, and Mr. Tejinder Singh for an excellent symposium. Now we are go ahead with the next program. So we have now a panel discussion. It is an integrated panel. The topic of the panel is new normal in CI practices post-COVID. So the moderator for this is Dr. Amitav Roy Chaudhary, who is a moderator, and there are 3 surgeons, 2 audiologists, and also a rehabilitationist in this panel. So now I am going to Dr. Amitav Roy Chaudhary. Dr. Amitav Roy Chaudhary is a professor and head of the department of Vivekananda Institute of Medical Sciences, Kolkata. Also a visiting otorhinolaryngologist of AMRI Hospital, Kolkata. He is the president of the Association of Phonosurgeons of India and also a co-editor of the textbook of laryngology published by JP Brothers in 2017. He has been an invited faculty at the European Otolaryngology Congress, Brussels in 2019. He has delivered orations and keynote address at many state and regional conferences, and he has conducted more than 100 workshops on various branches of ENT nationally and also at Dhaka, Bangladesh. Over to you, Dr. Amitav, to conduct the further proceedings of this panel discussions. I think you can go ahead and introduce your panelists and conduct the panel discussion. Thank you very much.
Thank you very much, sir. Dr. Medikari, organizing secretary for this great conference, which has we have already seen huge success in the last few days, and taking forward, we are after having a lot of evidence-based learning, we are going to talk about or discuss about a multidisciplinary approach to management of this crisis, which we have been able to do. I would like to invite my panelists to. The first is Dr. Naushad from Kochi, India. He is a consultant ear, nose, throat specialist, over 20 years clinical experience. His special interests are cochlear implant and also endoscopic skull-based surgery. He is the managing director and chief ENT consultant of cochlear implant surgeon and membership of CIGI, Indian Medical Association, and Association of Otolaryngologists of India. With his vast experience in cochlear implantation, both at government and non-government sector, I'm sure we are going to get a lot of input from him. Welcome, Dr. Naushad. We then have Dr. Kranti Bhavna. She is the young and dynamic ENT surgeon heading the Department of ENT at AIIMS, Patna. I know she's been trained partly in US and also in the East India. And she has international visiting fellowship by the American Academy of Otolaryngology in 2016, awarded San Diego, USA at annual meet Auto Expo 2016, and followed by she did some observership University College of San Diego, and surgical video. She got a prize for a surgical video presentation, and she also did a BACO fellowship, and she is a very keen cochlear implant surgeon. Welcome, Dr. Kranti Bhavna. May I now invite Dr. Neeraj Suri. Is Dr. Suri here? She again is a very leading cochlear implant surgeon of the country. She is the associate professor of ENT at GMERS Medical College, and she has pioneered a lot of things in Gujarat and very active in the government program in Gujarat cochlear implant program. She's also been the nodal officer of cochlear implant program and deafness program in the state of Gujarat. She's been mentoring cochlear implant certified fellowship course in Gujarat, and she is also the author of the book called Speakaboo, a glimpse into toddler's brain. I have personally gone through this book, and it's worth reading. Very fantastic book. Welcome, Dr. Suri, if you're already here. Now I'm happy to invite Ms. Meenakshi Adra. She is also, her list of her biodata is very long, but I'll briefly. So she's a very senior and reputed audiologist and speech language pathologist, and she has been founder and CEO of Meenakshi Speech and Hearing Clinics, which is very well known in the north of India and rest of India. And she's got 20 years of CI experience and is one of the founder members of CIGI. She has supported more than 1,500 cochlear implant recipients, and she's passionate about her profession. Obviously, we know her work, and she has keen research aptitude and authored and presented many papers in international workshops in the field of pediatric audiology, electrophysiology, rehab, hearing aids, and cochlear implants. Welcome, Meenakshi. We are delighted to have you here. We also have Mr. Shrikant, who is an audiologist from Visakhapatnam, India, who graduated from All India Institute of Speech and Hearing, Mysore, the EPIC institute in the country. He worked in Andhra Pradesh Government Medical and Health Services. He's practicing in the city of Vizag for 39 years, and he's been helping cochlear implantees well since 2008. Welcome, Mr. Shrikant. We are very happy. We also have, I'm delighted to invite Ms. Vaishtai Dabu, who is a certified AVT specialist, and she is a specialist on habilitationist, and she is the principal consultant of integrated services for listening and speech. And she has got a lot of work in this field, and she does a lot of courses. I'm just, obviously, you can see her biodata in the screen. She's been managing trustee of V-Connect Foundation and Parent Support Groups. She serves on the board of the Alexander Graham Bell Academy, USA, on the Language Certification Committee, and she's co-founder and trainer at online AVT conducting and AVT courses. So she has done extensive work on habilitation and AVT in our country. Welcome. Thank you very much for joining us. We then have Ms. Anuradha Sharma from Chandigarh. She works at the government sector, and she is a faculty at the Department of Otolaryngology and Speech and Hearing. She has got a lot of publications, 22, 16 international and 6 national, and a lot of presentation. She has won DHR and ICMR funded extramural project on cochlear implantation, many awards to the feather of her cap. And areas of interest are cochlear implants, tinnitus, adult neurocommunication, pediatric communication disorders. And she is also an editor and reviewer, guest reviewer of Annals of Neuroscience. And we have also been lucky to have her today for our panel. Welcome, Anuradha. Dr. I think we have been able to meet everyone. So without any waste of time, we are just going, if you allow me, I'll just share my screen. So COVID-19 pandemic has a tremendous impact on medicine, and it is one condition which has probably made all of us in the world to life. Our life has kind of come to a standstill at one stage suddenly, but we have all learned to live with it. We have all sailed through it with ups and downs. We have lost many lives, many colleagues, many friends, but even then life has to go on. So we have also accepted it as a challenge. So how does the cochlear implant pandemic involve us in a CI program? First of all, lockdown norms, closure of clinics, these are all cascade of events that followed after the pandemic was declared by WHO in 2019 and subsequently in our country in 2020 early part. And that again led to suspension of elective surgery in the hospital. So at the one end, people and parents were eager to resume their services, get their services resumed in terms of surgery and other things. At the same time, people were very much afraid of contracting the disease going out of home. So it was a big challenge to strike a balance between these two things. And last but not the least, as we know, the world economy has had a tremendous impact on this, and our cochlear implant program also no exception to that. So restriction of movements, lack of public transport and clinical management has been the major challenge. So on one fine morning when the entire country went to a complete lockdown, we just landed up with a huge waiting list, both in terms of surgical practice, in terms of habilitation, in terms of audiology and diagnostics. So I would first start my question with Mr. Shrikant regarding how, when everything came to a standstill all of a sudden, how did you manage to handle this situation? And what were the new norms or new modifications that you do in terms of getting your tests done in your clinic?
Yeah, we had many challenges. I am attached to one government setup where this government scheme, state government scheme and ADIP scheme surgeries are done, and another is a private setup. So in the government, unfortunately, our hospital was declared as a COVID hospital. So we are not supposed to handle any of our other patients. So for nearly 6 months, we had a block. There was a backlog of 6 months for our patients. We had to maintain a waiting list and then call them afterwards and do it. During the second wave, we had about a 3 to 4 months window where we had to maintain a waiting list and do it. But we had given them a choice that if they want, they can go to other hospitals and or private setups and get their tests done and bring the report, so that we were accepting that report. But still the parents were hesitant because the geriatric and the pediatric population were the ones who didn't want to go to any hospital setups or clinic setups during this for fear of catching the pandemic. Even otherwise, in other hospitals also, most of the hospitals in our state was notified as COVID hospitals. Many private hospitals also were taken over by the government and was declared as a COVID hospitals. So we had to suffer a backlog, but now we are clearing all the outstandings.
So now that you had a lot of backlog, what method did you use to prioritize? Like it's difficult to handle this situation because people are losing time. At the same time, we are not able to give them the service.
Yeah. Now we have increased our output. That is one thing we have done. And the government has hired temporarily some audiologists, and we have worked we have done over work and overtime and other things, and we tried to clear the backlog. Now it's almost cleared.
So that's a very reassuring thing that the government sector is also working hand in hand with the private sector because the government sector has the bulk, and if we can increase the manpower, which has been done, as I can understand from him, it might have done a lot of help. Coming to the next point, which I want to discuss here is obviously again in March 2020, suddenly everything, one fine morning, the Prime Minister announced a complete lockdown in the country. And all these people who would have had surgery in the beginning of March or middle of March, they were just waiting to be switched on. How did we, I'll now go to Meenakshi. How did you handle this? And obviously you must have done some modification in your switch on issues. So if you could highlight those points. I think you need to unmute yourself, Meenakshi.
Sorry.
Thank you. Thank you so much.
Yeah, thank you so much, sir. Before I answer that, I would just like to also go back to the question that you put to Mr. Srikanth.
Yeah.
So in our private practice, we prioritized by when we reopened, we also had a backlog of some waiting lists. And so we prioritized by testing first. The children were our priority. So we mobilized all our resources toward testing younger kids so that if they need to go in for further implants or so they can be processed faster. And as for the waiting list, we all know that as you said, that all our centers had surgeries before and suddenly lockdown. So we had 3 cases. And the biggest challenge was, actually, we were doing telemapping even before COVID. We have different clinics and we were connecting with different clinicians, but patient had to visit one of the centers. So, but during the lockdown, as you said, there was restriction of movement, children couldn't reach. So we had a biggest challenge. So what we tried, we connected with the patients who were implanted. So one of the patients, of course, it wasn't immediate, but after a month, when there was little relaxation, we connected with one of the patients when actually the courier services was provided. So what we did was we couriered actually the biggest challenge was actually sending the kits, programming system, softwares to the patient. So how we managed that was we sent the programming system and the software and our kit across through the courier to the patient's home. But the challenge there was actually the ability of the family members to carry out the process, like installing software, connecting the recipient to the hardware. But
so
we did before that.
Training. Yeah,
it was really challenging. So what we did was we had, before the whole process, we had 2-3 sessions where we trained the parent how to do the whole thing. And then, of course, we could carry out the process. It was not, of course, as smooth. There were some hitches, but still we could do the switch on. But for the other 2 cases, we could not actually, we had to wait till there was the restriction movement was lifted. And there was one patient from the railways. He got special permission. The moment it started, they could reach, but it was almost like 3 months. We had to wait for the switch on. So that was the biggest challenge that we faced. And so now we are actually.
If I may just add one to your experience, in our program also we had 3 patients, and out of those 2 patients, what we could do is we could get a special permission from for our clinic to be open for a particular number of hours and get special permission for the family to come. Right. And we went and could just do the switch on and then could train them. So actually, that is, I mean, everyone has their own way to handle this crisis. So
unfortunately, these patients were outstation. We also got the permission, but these patients were outstation patients. We tried first connecting to the nearest mapping centers facilities, but we could not be, it wasn't possible. So that was one thing. Of course, troubleshooting was another aspect, because the moment there was a lockdown, we got so many calls regarding, first there was a fear, initial calls were not regarding any problem, but it was more like, if my battery goes off, if something goes bad, what will happen? How will I get things? So that was what we reassured them. So we got special permission, as you did, that we opened our centers. We relocated our accessories and parts to various of our clinicians, their homes. So from our homes, if we could manage to deliver them, but the major part was batteries, battery chargers, and cables. That was the major problems that we faced during the pandemic. So post-pandemic, what we learned out of the whole experience was that we started counseling our patients to actually store and stock more spare parts. So it's initially they were more dependent because they are within the reach of the clinic. They would immediately come to the clinic to get a spare part. But now we have counseled them to that they should maintain more spare parts. Of course,
like it's like people have learned to store their food for a reasonably few days now, because any day there can be a crisis. So COVID has taught us many things, and I think it applies to our CI programs as well. So I will now go to Dr. Naushad, because then again, same situation, beginning third week of March, suddenly shut down. People were, especially children, waiting for primary surgery. As I said, parents were very concerned. At the same time, they were very scared to move out, even if you arrange something for them. So how did you handle those surgical candidates? You need to unmute, sir. Yeah.
Yeah. Can you hear me? Yeah.
Yeah, sure.
In the government sector, almost all patient surgeries were postponed. The centers where the implant surgeries were performed were converted into tertiary COVID care centers where only elective emergency surgeries were done. For the first half of the lockdown, all government sector hospitals, no cochlear implant surgeries were done. On the other hand, in the private sector was affected very minimally, because my clinic, my hospital closed only for about 15 to 20 days. The major problem was the accessibility, coming to the clinic, because the lack of public transport as well as the containment zone. In the area where my hospital is situated was declared containment zone for about 30 days. The patient cannot come in. These were all the major drawbacks in the initial phase. Then we started applying with the police people. We gave them the prescription pad in writing. Please send them to for the transportation. So they used to access. They were able to come to hospital. The primary surgeries were not much affected in my hospital. In fact, all listed patient scheduled surgeries were performed, and both the sequential surgeries were also affected. But after the initial half of the lockdown, the Kerala government came out with they made that cochlear implant surgery is a semi-emergency. So all these government patients were shifted to 1 or 2 centers where they are not considered as a COVID care center, and the surgeries were performed during that phase. And the backlog, all these that was done in the hospitals. So not much delay in the primary surgery. We
have not lost much time.
Yeah. Not lost much.
We will come to more details on those factors in a minute. Thank you very much. We'll just move on. Obviously, I think we have discussed that clinic management. What I understand is, and what we felt during those times, it was not the norms only. It was the whole thing. Probably it's like a new exchange transfusion, the entire system of your functioning, entire system of your clinic, everything was changed, which obviously had staffing issues because people were not coming to the clinic. Even if you want to open, even if the lockdown in some particular areas were eased, economic issues because the clinic obviously was having, so is the government had to do a lot of spending on sanitization and personal protective equipments. We had to do smaller groups. So all these things would have changed our philosophy of running the clinic, and especially when you're thinking of a AVT and those kind of services in a clinic where kids are there, and it's difficult to have them masked and then teach, or you are masked and then you teach. So these are the issues that we are going to hear from our habilitation specialist. I will start with first of all, Vaistai, if you can, because you run your own clinic kind of, and you have a lot of issues about training, so you must have trained other people also. So we will hear from you, and then we'll go to Dr. Anuradha, who is a faculty at the Government Institute. So we will know how we have, because this is a very key area, because cochlear, I always tell my patients that cochlear implantation, my role is 50, even 20-25%. And the major role is habilitation. And so this is the main area. If we can sustain the habilitation program through any crisis, the implant program will sustain. That is how I look at it. So your views on that, how you have handled and what modification you do.
Sure. So a little bit about habilitation. We as habilitation, so I will talk in general about habilitationists. So we as habilitationists, by and large, were in a comfortable zone. Most of the habilitationists were working physically through their centers. Now with the pandemic, suddenly they had to shift in their mindset. So the challenges that were there is, firstly, I would say many of them were not trained in teletherapy. So without training, suddenly to move to teletherapy was a huge challenge. Many of the habilitationists, especially the newer ones, because of lack of enough training in actual physical therapy, found it even more difficult to move to teletherapy. So they needed to basically change their mindset of, how do we change working with them? So here now with the pandemic, they needed to start thinking differently. Essentially, their entire mindset needed to change. So what were some of the things that they could do? Firstly, everybody was, kind of worked up about their own mental health. The therapists themselves, the parents themselves. So mental health was a huge challenge for everybody concerned. Secondly, many of the families did not have a smartphone at home. Some of them had one smartphone which the entire family was sharing. The therapists themselves did not have the infrastructure in their own homes to conduct the therapy. So to have a dedicated place, to have a laptop or a computer for themselves. They probably had a computer, but maybe the whole family was using it. So those were some of the challenges that were there. What I would say is the other thing, that the main thing is that they needed to start thinking out of the box. So one of the learnings from this was that they started using different modes of communication. So they started connecting with families just on the phone. Some of them were sending voice notes to the families. Some of them were doing therapy via WhatsApp. Some of them were taking screenshots of some of the drawings and sending it to them. So I think there has been a sea change in the mindset of therapists. They've started thinking differently. And I think that has made a huge impact on therapy. I think one of the main things that I would really say, what we have learned from the lockdown is that many therapists, so basically AVT is a coaching and guiding model. So out of the 10 AVT principles, 6 are to coach and guide parents on different aspects. One of the things that the therapists learned to do was to start using this coaching and guiding model through remote therapy. I think that was something which came out very strongly. Earlier, when you are doing physical therapy, you are there. So as a therapist, it's very easy to jump in and actually, do it for the parent. But here, if you're sitting behind a screen, there's only that much you can do. So what the therapist started doing was actually coaching and guiding the parent, telling them you can do it this way, you can do it that way. So as a result, it helped the parent, it empowered them, gave them strategies to work with their child. In terms of, yes, go ahead, doctor.
No, fine, carry on.
So in terms of resuming physical therapy, I would say in my personal case, I was anyways doing teletherapy before the pandemic. So there were a few cases that I was doing physical therapy. So it was very easy for me to move them to teletherapy. They were initially hesitant about teletherapy, but once the pandemic hit, they didn't have a choice. And in fact, now they're very happy with teletherapy, because it has cut down their cost of travel, so much time, especially in Mumbai. People have to travel long distances. So, in a short time, with them working from home, they are able to save money, save time, and it is very effective. So I would say some of the current practices that we are doing is using different models of therapy. So remote therapy. So I think what has happened now is a complete mindset in the minds of therapists, because their minds have opened up and they can use very many different modes of communication, modes of doing things. I think therapists, I must say, have really worked hard to really think of innovative ways. So I think in current practice, there are different new ways of thinking. There are many different apps which have come about. There are different platforms which have come about. I think it has become like one global world. So
we can probably spend an hour on talking about the newer modalities and newer apps, because there are so many things which has come up.
Absolutely. And I think one thing that I would like to add is from the parents' angle. I think because the world has become like one world, I think accessibility to excellent therapists is now very close to the parents' reach. Earlier, they would have to travel, but today, just at the click of a button, they can access any therapist across the world.
We will discuss this when we discuss the future.
Sure.
We'll go to Dr. Anuradha, who's a faculty in the government setup. In addition to what she has told us, I would also like you to throw some light on the people or the children who are slightly mentally or physically challenged. Those particular category of people may be slightly more challenging to give teletherapy. I'm not sure, I'm not a therapist, but if you can highlight on that, because people would know.
Thank you, Dr. Good afternoon, everyone. I would start from, like you had said, that what were we doing before? So therapy before COVID was a physical contact between client and clinician. Clinician was a sole session planner, from therapy materials to plans, activities, and that's how the targets were achieved. Then suddenly the pandemic came in. And the biggest challenge, the first challenge that we faced was that every cochlear implantee child was not an appropriate candidate for teletherapy. We could not enroll all of them for cochlear implantees for teletherapy. We started with synchronous mode of teletherapy. I'll divide it among 2-3 categories where we face the challenges. The first one, like Vaishtai has also said, we were facing hardware issues. Initially, they didn't have laptops, tablets, or smartphones, and either they did not have a provision of video calling or good resolution from the camera. Even the scarcity was there in the market with these devices. So the parents, even who could afford, couldn't get these devices. And then there were software issues. There was lack of high-speed internet data. I mean, we cater to children throughout northern belt. So from Himachal to Jammu Kashmir, So because of all this, there was a lot of, freezing of audio and video calls. The calls were dropped, and the parents were troubleshooting themselves. In the session, the clinician and parents were, doing this troubleshooting training. Both of them were learning during the sessions. This led to a lot of time wastage and mismanagement. Sometimes the clients wouldn't even show up at the desired time when the therapy session was scheduled. And now, because everybody was home, the siblings were home, the extended family was home, there was a lot of background noise. Some children had a lot of dependency on good quality of sound quality, so it became a big issue for them. Another issue that we faced was lighting. So because all the family members was there, so the space that the mother and child would get for therapy may not be actually apt for the session, because there would not be enough lighting on the face of the child, or the activity could not be visualized accurately. There was a lot of sometimes children needed some speech reading cues. During that time, that was also hindered. Sometimes a little gestural support was needed. That lighting also couldn't cater to. From parents' perspective, when we asked the parents later what were the issues that they were facing, they found it very, very challenging. What was happening was, they said that there is a stage where there is a boredom faced by both children and parents, because they were confined at home for longer durations. So even children started showing some behavioral changes, and they were not cooperative for the sessions for longer time. So the target goals that were given by clinician were not achieved, which led in turn to the anxiety and all that psychosocial issues. Sometimes, like audiologists have also spoken about breakdown of accessories. So this led to long-term gap of even therapy sessions. There is one important area where I would like to say that our older cochlear implantees were also suffering, because they were not so tech savvy. So the technical experience, lack of skills in hardware, that hindered them to come for online training. So they felt very left out. And from a clinician's point of view, we were working in isolation. Suddenly there was isolation where we were always filled with, kids noises and kids around. But yes, there was a lot of positives coming from this modifications that we did. There was unlimited creativity from the clinician's point of view, as well as from the family point of view. We trained them to use digital therapy materials. We trained them to digitize their personal family photographs. You name it and they did it, like online shopping sites, traveling, mapping, tickets, YouTube videos, anything they used, which was available on regular basis, was used by family members. Second, a very positive thing happened was, now the whole family was there. The extended family, the father, whom we had very, scarcely seen during sessions, they were there for the therapy sessions. And we were giving the quality services at the client's comfort, their home. Fourth thing was that client as well as clinician and other family members all were available on online platforms at even odd hours. Because of WhatsApp groups, the clinician was accessible any time of the day. So you just leave a message and we can reply. And some parents had to relocate. That was another very important positive aspect that came from teletherapy. Because of occupational hazards, some of them had to relocate. So they could continue therapy wherever they were with teletherapy. So basically, they had a versatile skill, repertoire build up. Now, coming on to your next, that what was the challenges abruptly that we've learned and physical therapy sessions? I would say we were not very much into teletherapy priorly. We were more into physical sessions. So because of that, what we learned was that, we must go in for confirmed time and date sessions with the patients. We also should have, priorly discussed what is going to be done during the therapy session, the lesson plan, the documentation, the activities should be prepared priorly. So that during the session, the toys, the therapy material, the food materials, or the other materials are readily available and the time is aptly used. Then for the older clients, what we did was we used culturally relevant icons. The font size we increased so that, the visual problems that they have are taken care of. We use some remote assistant things like Go to Assist and screen sharing. Screen sharing helped a lot. Sometimes they would just get stuck in between and say that we can't help. So we used TeamViewer and all these, kind of programs. And then one very important thing I must say that happened due to COVID was multi-client conferencing with Zoom platform. Now we had all of them on one platform, and we even had other team professionals. Once we roped in a clinical psychologist, other time we had a pediatrician, because we are in a tertiary care hospital. We could request them and they could, come in during those Zoom meetings. So everyone got to, meet team professionals under one roof. One client had given, I'm sorry?
So there is a lot of things that you have learned and you have modified, what I can understand. And we will also discuss the future, how it's going to be in the end. So if we just throw light on how you manage the physically and mentally slightly challenged people for therapy in 30 seconds, and then we go to the next one.
So we did not include all the physically and mentally.
Yeah.
Yes, we did not, like I said in the beginning, that all of them were not candidates, but yes, during our client meetings and all this, we did include those parents, and we asked them, we separately send them those session plans through WhatsApp and through home training programs. So that's how we cater to. Baki physical sessions we have started last year.
She has mentioned, yeah, I think all of us have done the same thing. So we'll go to the next question. Next thing, I'll go to Dr. Naushad again. When you have already briefly mentioned that you are in private and government setup, but does the guideline or advisory by the international organization, even CIGI has got its own guideline, does it help, or deciding when to start, like 3 months is the general consensus that beyond 3 months we should not wait for a waiting child. So what was your intake, and what is going to be your future intake as well, if we have to suffer more with this pandemic?
My advice, please, we have strictly doing the surgery in accordance with the health authority. And the government, we have approached the government for the backlog work. They were waiting for the surgeries. The government themselves formulated, they have converted this cochlear implant surgery into semi-emergency surgery.
That's a very important and very strong point to be highlighted, as you said.
Semi-emergency, so that the surgery cannot be postponed. And we have told them the necessity of early intervention as well as therapy. Delaying the child can make the outcome very bad. So the government has taken in the right sense. When they have told that this is semi-emergency. So they converted the theaters allocated the theaters for doing cochlear implant surgery in government setup. Whereas in private, we don't have to wait.
That's not much of a problem. Yes, I understand.
Not much of a problem.
So that I think that every center had to decide their own course of action depending on the geography, location, COVID, non-COVID unit, building which separates a COVID wing and non-COVID wing of the hospital. I think that those are the things which dictated us to, with the surgeons, to restart our surgery. But on principle, I think all of us would agree that this is semi-emergency. People talked about a neurological emergency also for cochlear implant surgery. So it cannot wait for months and months together. That is purely documented in literature, and I think we also agree with that. We'll come to operating theater. I think the concerns, the moment we thought of restarting the surgery, whether it's 15 days or 2 months, depending on where we are doing, again, the patient protection, healthcare worker protection, and anesthetic and other surgical issues, and the things that Dr. Naushad has said. I will go to Dr. Kranti Bhavna for this, because you are in a government premier institution, and how did you handle this, and what are the things that anyone should think of in the future? What I would learn from your mistakes?
So very true, as the problem was universal for all of us. The problem was more in government setups, especially since all our centers were declared completely COVID. We could not admit anybody other than COVID, and it's not only a point of delay for these patients, it was also problematic for us in a sense that we were doing active COVID duties. ENT department was totally involved in not only active COVID but ICU duties. All my residents and all of us were doing ICUs because we were more closer to doing all surgical tracheostomies and all that. So the whole thing was when to start, how to start, and that was dictated. Sorry for that. That was dictated by our hospital SOP and our government of Bihar guidelines. So once we started in 2 phases. Twice we could restart our OT. First after the first phase when I think everybody started, and we were trying to clear our backlog. What we actually did is our hospital got divided into, as you already said, COVID, non-COVID zone. Everybody came for admission, and they were kept into an area where a primary COVID test was sent. So nobody could be admitted without a negative COVID. And once they are admitted, there was a repeat COVID test. So RT-PCR, we were considering 2 negatives RT-PCR, and before the OT, at least it would be maximum 48 hours old. That's it. So that was one thing, active RT-PCR, so twice doing that. Patient protection, so this thing what we did in our ward was we actually we have cubicles in our ward, and we dedicated cubicles for the pediatric patients. We did not allow attendants at all. Only one attendant was allowed with the baby, who was not allowed to mix with other people so this was something which we made it a bit strict, because what was happening, cross infection was happening because people used to meet each other. So that is also important. In government setups, you will see patients, attendants live in and around the hospital premises. When our hospital became completely COVID, all the attendants were left out. They were not allowed to be with COVID patients. But once it came out of COVID and we were supposed to operate, slowly these attendants came back. So we wanted to limit that attendant mixing up, because that's where the infection would come up. So that's one thing which we did. As far as healthcare protection was concerned, we were very lucky that way. We had ample, no dearth of PPE kit, one of the best quality we were getting. And I'm glad to say that at least during management and operating these cases, we did not contract that infection. In second wave, obviously, many of my postgraduate students became positive, but that time we were not operating. So the other thing was anesthetic and surgical issues. As I told, we all had that negative RT-PCR, and other than the main issues were same, which happens with all the kids, the general PSC and everything.
Can I ask you something?
Yes.
How did the training get affected?
Oh,
it's also an important aspect of our CI program.
It's a very, very
It applies to habilitation also, but surgically more.
Yes. Imagine your hospital being closed for literally many months together. So my postgraduate students, my senior residents were, as I told you, doing only COVID, doing more of medical science, more of surgical tracheostomies. We did more than 200 plus surgical tracheostomies, nothing else than that. So definitely it was only thing which we maintained throughout was online modalities of academics, which was happening. We were sharing our videos, whatever we did before. So this is what we were doing, but nothing hands-on training was something which
I would just add one thing to this, being a surgeon, that our anesthetist and the nursing hospital authorities always insisted when we're doing this resume the cochlear implant surgery for kids, that you need to do a quick surgery.
Yes.
So no training there also, which I want to highlight. And those people who would be on a fellowship program or something, they will be really deprived of the surgical training in this last 2 years, which is a great impact on training as well. Carry on, Kranti. Sorry to interrupt.
No, so I'm just going to be very quick. And the important thing which we were discussing was initially when we started, we were using the double draping method. But now slowly when the COVID rates have really come down in our state, we have forgone that double draping method of microscope, but we drape the microscope above, but not the lower part of it. But still we are using the respirator mask. All of us are donned in N95s and all kind of completely disposable halyard gowns and all that. That's the norm. But during that we were obviously using the respirator masks, all of us. Hospitals stay very true. We have initially also, but during COVID we wanted to make it at least possible. So once I operated them, then we were discharging them by second to third day of admission. We do, I know there are many people who do it daycare surgery, but when people travel for long distances and when they come to places like the capital of the city. So we need to keep them for some time and then used to go back. So that is what we have done for our CI patients as of now. And thankfully by now our backlog is a bit over. We are operating 2-3 cases a week and the day to complete our backlog.
So what I understand is that we have survived through this crisis in terms of surgical practice, and what Dr. Naushad and Kranti tells me that we have almost cleared our backlogs by now.
Yes.
And also the habilitation
Can I add one more point, sir?
Yes, please, sir.
Yeah. In our private sector, we used to do the RTPs or the bystander also.
Yes.
That's very important. Yeah.
Same
with us.
Same with us. For our attendance, we have to do the COVID test. So we have COVID test for the baby and the attendant who is supposed to stay with the baby. And as I told, we were not allowing mixing, and we're keeping
no
the baby.
visitors.
No visitors at all. No
visitors.
Yes.
No. A lot of things have changed, and our practice in terms of surgical practice also will adapt to some new normals anyway. We'll discuss those things very shortly as we finish. Another big area of CI programs, a big pillar of any program, is awareness camps, counseling, which happens, which is like an ongoing process in a CI program. And I'm sure all of us have suffered, and all the centers in the world have suffered because of this. I will go to Dr. Shrikant now, because you are in a institution. How did you think that this can be made better? Because obviously I'm sure all of us would agree that it has had tremendous impact. No counseling session, no awareness camps, no even the screening, high risk screening, and even newborn screening also stopped. In my hospital, only newborn screening stopped for a while, quite for some time. We did not have a newborn screening, which is normally in practice. So, Mr. Shrikant.
Yeah, newborn screening is affected for us also. The concerned doctors used to say, wait for some time before you go in for any test. So that was there. That problem was there. Regarding awareness, we used to conduct physical camps, awareness camps before, but that has stopped for the last 2 years. Now we are using social media like Facebook and other social media. So it has been more of a digital awareness camps now. And regarding counseling, we are now doing some things like, in addition to the regular counseling, which we used to do, now we are talking about the, we counsel the patient about the protocols. For COVID protocols will be the additional aspects in the hospital when you go for surgery. Then we are asking them to take less time to take a decision. Like we used to counsel them, and they used to, they have to find their funding, or they will consult a second opinion, or they may consult the family. Now we are telling that we don't know what will happen tomorrow, so you take less time deciding whether you want to go in for a surgery, and go in for it as early as possible. So decision making has been hurried up actually, and then we are now preparing them for non-contact habilitation. So before only we are telling that you may not, this thing depending upon the future, you may not have to go. You have to go in for a non-contact like online teletherapy or this thing. Then one important thing which we used to do in counseling is we used to send our prospective patients to the people who have been operated upon. You go and meet the parents, go and meet the child. 2-3 numbers or 2-3 this thing we used to give. You go meet all your doubts regarding surgery, or how the progress will be, prognosis will be, how the improvement will be. If you meet them personally, you will know. But now we can't do it because both the parents are apprehensive about meeting somebody else. So now we are doing it in WhatsApp groups or group video calls. So the counseling has changed more towards digital media from our side this time.
Can I add, sir?
Yeah, please.
Sir, regarding counseling, like I agree with Shrikant, sir. As he said, now we have made WhatsApp groups which have existing users, and then when we have a new a prospective client, so we add that person into the group and then enable them to interact with the families through video chats, video conferencing, and even for the counseling of new devices, like what they should choose, decision making of the devices, even that has gone online. So for telling them all the technology availability, we use the video callings, video chattings with them, demonstrating them using the presentations or actual devices. That is how our counseling has changed. Very truly said that it has moved towards the more digital aspects.
Yeah, even for consenting surgical, yes. Normally in my practice, what we do is we do the final consenting and counseling session together with habilitationist, audiologist, and myself, all patients. And again, that we are now doing online to save one visit for them to the clinic or the hospital. So I think we have all learned new ways to make things easier for us.
What we have found is that
Sorry.
So what we have found is that probably this is actually helping them better, because connecting, sometimes it wasn't easy for them to actually visit the families, but connecting with the families is becoming easier through digital media.
Absolutely. Thank you. I think Vaishtai wanted to add a little point here, something.
Yeah, sure. So two things. One is in terms of counseling, I think parent support groups have really worked very well. So in my experience, I run a parent support group, and I think a lot of issues that parents were facing were discussed in the group, and there were other parents who could give responses to them. So they felt supported in their issues in the parent support group. The other thing I would like to add is auditory verbal therapy, like I said, is a coaching and guiding model of therapy. So I think one of the things here is that I know that this counseling is different than that, but I think for therapists, one of the learning has been to use that coaching and guiding model to work with families. And that coaching and guiding model can be extremely powerful. So many of the therapists are now using that model. There are still some therapists who have not had that training, who still require to, hone that model for themselves. So just wanted to add that.
Sure. Thank you very much. So I think we'll go to this short slide. I think this is all these while we are talking about the effect of COVID pandemic, but actually does COVID disease itself also has a lot of effect on the otology or the inner ear as such, because we have seen many patients with tinnitus, many patients develop hearing loss, and there are so many unknown things about COVID which are gradually erupting after people have suffered with COVID. One very interesting thing, actually Kranti has pointed this out. If you can elaborate on this regarding this paper and case report.
So when I was going through literature regarding CI and COVID, I definitely got many art. And one of these very interesting article was a report of two patients who came to their rehabilitationist, and they told that they have suddenly lost hearing on the side of the implant. Now, what is that actually what has happened? And these patients were not initially diagnosed as COVID. They were admitted and they were being evaluated, and then they developed those respiratory symptoms. So they were in the early phases of infection of COVID. So there were many theories as to why it can happen after COVID, that whether the implant has stopped working or what happened inside the ear. So many theories which were given, and which were actually seen was because we know that COVID has special affinity to ACE2 inhibitors, ACE2 receptors, sorry, not inhibitors. And when people used to get infected with COVID, the brain cells used to get affected. The temporal region can get affected. So the central auditory system could have got affected by that. And there was one important concept of the role of COVID. And once they are attached to the ACE receptors, they used to release a lot of cytokines, and those cytokines in turn can cause a lot of inflammation, not only of the central auditory pathways, but also of the inner ear, and inflammation around the cochlear fluids. So, and it was also noted that in one of these patients, there were short circuits of the, so only half of the electrodes were working. So why that was happening? So again, the concept of inflammation around the fluid inside, around the fluid draping the cochlea, draping the electrode in the cochlea has come up. So this was
maybe the worst is not over yet. We will come to know
yes.
many things about COVID and impact of COVID disease itself on
Yes,
our implant
because
team.
we also know that it's not only ACE, and we also know how it causes endothelitis, how it causes vascular problems. It's a thrombogenic disease,
Yeah,
and we
I
know
think
how
we are
it
not
affects.
going into the details, but
Yeah,
what
so I'm
we
not
want
going
to
to do
highlight
that.
here is that
Yeah.
we should be careful to look at any things, and it can be attributed to the COVID, which
Yes,
they may be
and
suffering, they may be presenting with, or which they may have suffered in the past. We do not know.
we don't know what long COVID is up to. Long COVID is
And the
actually a problem.
and rest of the points are, I think, have been discussed well, in psychological impact and financial impact. We will now I'll just advise there are lots of literature in the world literature, but this is a Indian paper which gives a very good perspective about the Indian scenario and the challenges. Basically what we are discussing here today has been jotted down in this paper, so you can have a look, all the attendees can have a look at this paper, which is in our Indian Journal of Otolaryngology and Head Neck Surgery. Coming to, I think we have discussed how we have dealt with this pandemic, how we have dealt with the challenge, how we have modified our strategy. So we have discussed everything. Only thing I want to know from all of you now, probably just 1 minute each, so that, instead of sentence, if you could use short sentences and words, how it's going to change our practice for the good or worse, the pandemic. So I'll start with Dr. Anuradha.
Well,
please be short for this, because we have to then sum up as well.
Okay. The first point I would like to say is, being in a tertiary care hospital, the rehabilitation services, the tele-rehabilitation services should be ensured. The legal efforts should be made to make these ensured. Then the privacy and security, especially when we are using public platforms, the online platforms, this should be taken care of. I wouldn't deal into the details of that. Third important point is the consent form, that the patient should be clearly told, appropriate reading level of the client should be told, that why telepractice was recommended, what are the privacy and security measures the practitioner is going to take. Another important point is documentation, that now that teletherapy has come in picture, every session should be well documented, and whoever joins, like any communication partner or e-helper is there, that should be definitely documented. Next, e-helpers, they can be of very good help because they are good at telepractice equipment and troubleshooting. So if they are there at remote sites, they can be help in connecting clinician and client. Then satisfaction surveys, that is feedback forms, should be taken from the client, which will help us to know how well we perform with the teletherapy. Then technology assisted tools like Avatar, like Train to Hear, Angel Sound, Heroes, these can be used and has been used by some of my clients and have been found to be successful. And as SLPs, it's our obligation to improve our knowledge and expertise in this. Also, we should also see that one-on-one sessions that we are taking, are they as good as the teletherapy sessions? Every session should be compared very well, and the families should also be given an in-service training to help them understand the process. A little bit about the funds that they require for loaner, if that can be dealt with, or providing loaned laptops or tablets, if that can be helpful in future. Thank you.
Wonderful. Shall we go to Dr. Naushad now? Your take, a look at the future.
Yeah.
Thank you, Doctor.
Surgery, it has improved because post-surgical care of the patient, you can avoid the hospital, repeat the hospital visit, and the media, social, WhatsApp call and everything. I can see the post-operative care of the patient, give advice and everything. And as an owner of a hospital where I have got a very good audiology department as well as a rehabilitation department, my take is for the future, I think there is nothing to replace a physical therapy session, rehabilitation therapy. So I have a little reservation for that. The surgery and audiology mapping and everything, all these things will do. But the teletherapy for the rehabilitation aspect, I think it doesn't have a much in this time, and the pandemic time, it will help. But there is nothing to replace a physical therapy sessions. That is my take.
I will go to Ms. Vaidse regarding comment on this last comment by Dr. Naushad, and also your general comment on the look at the future, because you have been handling the therapy.
So I beg to differ from Dr. Naushad. The reason being that if the therapists at our end are trained well, then the follow through with teletherapy becomes very easy. In fact, evidence tells us that teletherapy is no better than physical therapy. In fact, it helps because the therapist is physically not there to take over. We as human beings have that tendency to jump in and do something if somebody else can't do it well. But here, if you're sitting behind a screen, you need your skills to coach and guide the parent. So I think that is my view on it. I think I would say this pandemic, though very unfortunate, has been a game changer for therapy, because very, very many new ways of working have come about. The therapists have put in huge efforts, and I think they are doing a fantastic job. And I think it is, if we change this mindset for ourselves, then this can actually become a very empowering way of working with all our families.
Wonderful, wonderful. I mean, that's a real look to the future, and I mean, difference of opinion will be there, and we'll probably have to wait for more evidence in the next 2 years, because more and more centers will now produce more evidence-based data on the comparison between tele and we'll also get to know the real challenges. And we have already heard from our panelists that not all patients, like Dr. Anuradha has said, not all patients are suitable. So we are not going to be able to replace the physical therapy, but probably a large number or large bulk of our patients will benefit from this kind of new apps and other things. Shall we go to Mr. Shrikant now?
Yeah.
In terms of diagnostics and audiology, how we are going to be hopefully handling the situation in future?
Yeah, we have already started doing it, and I think this is going to be the future. In addition to asking the patients to have extra cables, extra batteries, and extra dry bricks, we are also storing extra, because we don't know what happens when the lockdowns may come, when we will have a problem in the supply of the materials from the companies. So this is one thing we have already done, and this is going to be the future, I think. Then one more thing which we used to do we used to give only one program at switch on. I think most of the audiologists do, and we never used to give progressive maps. So now we want to reduce the number of visits to our clinic or the hospital. So now we are giving progressive maps, and we are asking them to contact us by video when to change it and how to change it. We can give a video demonstration. So earlier I used to give only one switch on map, so that the child or the parents are not confused how to change the programs and all at the first sitting only. Now I'm giving progressive maps, and then I'm giving a video demonstration as to how to change it, maybe once in a week or once in a month, so that the number of visits to the hospital is reduced, and we don't know whether they will be able to visit due to something like that.
Sure.
Then the switch on also has been, as I already mentioned, we go by, I have heard many professionals saying, kal kya hoga kisko pata. So do it today only. So we are trying to reduce the switch on from 4 weeks to 2 weeks, or maybe a little earlier if we have the permission from the ENT. Sanitization is here to stay. So unfortunately, we are now increasing the distance between the clinician and the patient or the recipient. We are trying to increase the length of the cables so that we maintain that 6 feet or 2-meter distance, and all these things are happening in many clinics, and it's happening in our clinic also. So then we are trying to find ways how we can overcome the effect of the mask. At home, the child is speaking with everybody without a mask, but when he goes out, then he has a problem. The child is having a problem with facing people with a mask.
Very valid point. Yes.
Said and done. there is an effect of the mask, how much ever the child is hearing well. In some cases, we have seen that maybe some children will be very easily cope with that, but just like the way we are having the problem, even the children are having the problem. So we are still working out the ways how to compensate for this mask effect in our mappings and this thing. Then of course we have started now more into remote programming, which we were a little hesitant before. Now we have to do it. We are forced to do it. Then we are also having backup processors now these days. We are asking our upgrade patients to give their old processors if they are not using, so that we can keep the patient with the processor always. Because this time the service issues also will take place. It will take time, more times there are lockdowns and other things. And of course, all the troubleshooting is through FaceTime or WhatsApp video.
Thank you so much. We would now go to Meenakshi. Firstly, on your take on doing the progressive map, as he said, what's your opinion? And then if you can add to.
Right. Hello.
Yes.
Yeah. We have been actually doing the progressive maps, and actually I agree. For progressive maps, as you said, that we are working out the ways to reduce the effect of the mask. So maybe we can give one of the maps as more like, especially when when the person is going out.
Meenakshi, we have just 3-4 minutes left. So
I will just take one minute. I'll just take just brief. So the future is more like non-contact programming, that is wireless programming systems. That is more like it, and that is something that we are looking forward to in future. Remote programming using a person's own processor, like we are able to do in hearing aids. We are able to do programming for a patient sitting at home. That is the future that we are looking at. We are also looking at the future of doing an assessments like speech perception scores and everything, because everything is possible, but if we are not able to assess the outcomes, then it becomes a waste. So a way to do speech perception testing sitting at home. And for habilitation, we have not just connected to our older patients. The future is hybrid mode of habilitation. Patient would come in once in a week to the session, and maybe we can support them 2 times at home, so that enabling the parents a better learning. Older patients are connecting back with us because of reduction of the time that requires to for habilitation, the ease of habilitation sitting at home. So these are all the futures, but the most important is, I would say, being able to, as the audiologist, being able to do mapping for a patient who's sitting at home without any additional hardware.
Perfect. That's a very good message. Dr. Kranti, just in 1 minute, if you could enumerate your thoughts.
So one thing is for sure that COVID is here to stay, and we don't know what else is here to stay. We know the climate change is coming. I don't know what is coming. So we just have to be prepared. And this pandemic has given us a wake-up call, I feel. In many respects, it's not only about the way we sanitize, the way we practice in general. Our surgical practice would essentially perhaps remain the same, other than some extra precautions. But one change which I think I would like to point out is people are connecting to us more on social media, on WhatsApp platform. We have given treatments to many patients on WhatsApp, but the legal system bounds us. So there are times when you get up you keep getting these messages that you are not supposed to write prescriptions on WhatsApp. So I think this is something which needs to be looked after. What is the modality of telemedicine which the patient can communicate with us, and how? So I think the government should also look into this, that me being in a government setup, will I be, for a malpractice if I'm prescribing something on social media? So this is something which has always disturbed me throughout the pandemic. We were totally always on phone, prescribing this, that, not only the COVID patient, but also to our normal patients. So this is something which I think government should help the doctors.
Very valid point. Very valid point.
Yeah, thank you.
In addition to what we have discussed.
Yes.
Just to summarize, these are the things that we have discussed, and I will just add 1 or 2 things which has come up in the discussion. First of all, the theme, what we have gathered here from all the panelists is that telemedicine, and practice. I mean, obviously surgery can never be telemedicine. Surgery has to be done physically, but most of the things we are going to transit more time to telepractice, but obviously keeping an eye on the legal aspect of this, like things should be recorded, consent should be correct. So we have become more reachable to our clients, to our patients in the COVID pandemic, which is good. Secondly, what I have observed is that I think one of the panelists said access to the best therapist in the world is possible today because of telemedicine. Access to the best surgeon, however, is not possible because to surgeons you have to come physically to us. Troubleshooting, I think it's a very valid point. The parents have learned and caregivers have learned a lot of troubleshooting to be handled by themselves because of hiccups they have faced, which is a good thing for us. Burden is lessened. And obviously, that's more, I think, and we must also understand one more thing which has come up in the discussion, that not every implanted child is a suitable candidate for telemedicine. So we are going to have children who will still need to be physically, treated in terms of habilitation and other things. But overall, we have done quite well. And I think since it appears we have all cleared our backlogs, but we should be prepared keep our antenna very high so that anytime it hits us again very badly, we should be able to come out with flying colors. I would conclude this panel with a big thank you to all my panelists for giving so much of valuable inputs, and I'm sure the attendees would have taken some take-homes from this panel. Thank you very much, and also to the organizer for organizing such a wonderful conference on a virtual medium. Thank you.
Thank you. Thank you, sir.
Thank you.
Thank you.
Thank you, Dr. Amitabh Roy Chaudhary, for conducting a wonderful program on this new norms of practice, CI practice in COVID situation. I think this was the panel need of the hour during this pandemic. And I would like to thank all the panelists who have contributed immensely for the understanding of this practice in the present situation. So thank you, all of you. And we'll move forward to the next topic. And I'm going to hand over to Dr. Sunil Narayan Dutt to conduct the next scientific session of invited talks. Thank you. You heard, no?
Hey, Sunil, how are you?
Hi, Prepa.
Hey, boss, how are you? I couldn't recognize you with your mask. Now I recognize you with a wonderful smile of yours. Hey, James, how are you?
Okay. So it's going to be a breakout session where we have in the surgical hall, which is where I am and you are with me, invited lectures from the GCIN steering committee, the Global Cochlear Implant Access Network. And as you all know, the GCIN is conducting world congresses in cochlear implants in emerging nations with a very specific focus on the challenges and issues that emerging nations have in the field of hearing implantation. I have all my dear friends from the steering committee of GCIN here. And so without further ado, let's begin this session, which is roughly about an hour and a half. Hopefully, all of you are here with me. I would like to begin by introducing my co-host, co-chairperson, Dr. Deepak Haldipur. I don't need to introduce myself, so let's just go. Yes. Deepak is a very dear friend of mine. I've known him for all my life, I think, and amazing and enterprising ENT surgeon and a wonderful human being. He's the alumnus of the Bangalore Medical College, internationally renowned for many fields, focus areas in ENT, including endoscopic sinus surgery, DCR surgery, stepidotomies. He's an authority. And now he's into the foray of cochlear implants as well. He's an ADIP empaneled surgeon Deepak has been a wonderful administrator, a healthcare provider. He's a partner in a very well-established corporate hospital in Bangalore, Trustwell Hospital. And Deepak, above all, has been a leader in ENT surgery with the Association of Otolaryngologists of India. He has been the past president and did some human service to the cause of ENT in this country. With that, I would like to invite our first speaker this afternoon. Again, another friend from Malaysia. I think he has Indian origins. You look at him, you can tell. Prabhakaran Narayanan. Hi, Prabha. Currently the senior professor and consultant in ENT and head and neck surgery in Faculty of Medicine, University of Malaya. He was the chairman of the National ORL Head and Neck Surgery Specialty Training Board. So he's a fantastic teacher, as you all know. He's come several times to India and taught us in workshops and conferences. Also the president of the Asian Research Symposium in Rhinology, very actively involved in research with numerous research grants. His interest, topics of interest include head and neck surgery, advanced endoscopic sinus surgery, does some crazy anterior skull base procedures, as well as lateral skull base procedures. Both of us have been fellows in skull base and neurotology with John Rutka in Toronto. He's also now into cochlear implants, hearing implants, Bahas, and bone bridges. So without further ado, let's hear Prepa speaking on CI surgery without the microscope. Now, there a lot of questions have been asked in our groups, in our CG groups, Prepa, and I think people are looking forward to how can you do CI surgery without the microscope. So go ahead.
Thank you, Sunil. So let me just share my screen first. Okay, perfect. Can you all see the screen?
Yes.
So thank you very much for having me. It's a pleasure to be here. Let me see whether I can expand. Okay, fine. So this is how we conventionally do it's called surgery. So this is one of the pictures of the surgery that I was doing for a lateral skull base, with a big bulky microscope with the IGS and so on. And this is the position that we do. So we were introduced to this VTOM, which is an exosystem that is used extensively by the head and neck surgeon. And this is how we do the surgery with the VTOM set. And this is the microscope itself. It's an exosystem, and it's got a sensor system to 2 by 4K. It's got a zoom of 1 to 4 times continuous zoom, the working distance of 20 to 50. And it's got a very, very clear view. So let me just show you how we did. We actually did a bilateral CI VTOM with 3D first, but because the videos of the 3D, I would not be able to play in the presentation. I will just show you the bilateral CD VTOM that we did first of all in December last year. So this is the setup. Again, you can see there's no more microscope, and you can see that this is the microscope that we are using. That's it. And the entire surgery is conducted by the screen, as you can see here. Again, this is the microscope up here, and the surgery is done without any microscope at all. So this is the microscope, as you can see. That's the VTOM, and it's projected into the camera system, exactly like how we would do an endoscopic sinus surgery. So this is a patient with the left CI, and you can see I'm going to go a bit quickly into this. I think all of you are expert surgeons, and this is all quite straightforward steps. But what it does show you is shows you the clarity of the image that we get. You get clarity almost the same as the clarity that you would get with a microscope. The only thing that you do not get is you do not get a 3D perception that you would get with a microscope. But those of you who are comfortable with an endoscopic ear or comfortable with a endoscopic sinus surgery, the 3D orientation comes almost automatically, because you'll be able to see the distance by having a suction inside, and you'll see that the clarity is the same as having a clarity of a microscope as well. So the whole surgery without a microscope took us the same length. The average time that we take before an electrode is inserted with a microscope is on half an hour, and this took about the same length as well. The beauty about the surgery was there was no need for any bulky surgery, and everybody could visualize the screen at the same time doing the surgery. I'll go a bit quickly in view of time so that we have more time for answer and questions. So again, you can see excellent response. And then this was the very first one we did was a bilateral CI VTOM because we wanted to be comfortable with the VTOM, with a 3D image before we even tried the 2D image. So this is the position of the surgeons. You can see that we are all wearing the 3D glasses, the surgeon and the two people who are assisting him. And this is the VTOM, 3D VTOM. You will find that the 3D VTOM is placed just above here. And again, the timing wise, it took us 8 minutes to fix the VTOM itself. And from the time of insertion, from the time to insert the electrode was 28 minutes. So there's no difference whether you do it with a microscope, with a 2D exosystem, or with a 3D exosystem. The duration of the surgery is exactly the same. So I'm just going to show you a video, but this obviously we can't make out the 3D perception simply because we're not wearing the glasses, we're not having the 3D monitor. But on the day of the surgery, what we see is exactly like how you would see with a microscope. And look at the clarity. Look at the clarity that the exosystem gives you. And this exosystem is now being widely used by a lot of specialty. So we do not have to buy it just for otology or cochlear implant. You can actually just use your head and neck colleagues or the gynae colleagues or the neurosurgeons who are beginning to use this for surgery as well. How did it feel to do a surgery with VTOM without microscope? It was like free and easy. You have nothing in front of you. Your neck can move in any direction. You can turn around and you don't sit stiff in one position for a long, long time. Now, let me talk to you about another endoscopic cochlear implant. So we were given a grant to do this, to do endoscopic cochlear implants. We also had a patient who had no mastoid at all. So the only option we had was an endoscopic cochlear implant. So again, the position, as you can see, the surgeon who sits in the center, a colleague who helps to hold the endoscope, and another colleague who uses the irrigation just to flush it without any microscope. So I'm just going to play the videos to show you how the surgery is done. Again, the same. You can see how clear the view is. This is without 3D. We can also do this endoscopic CI with 3D because the 3D endoscope is out. In another 2 weeks' time, I'll be doing a live surgery, 3D live surgery for endoscopic ear and endoscopic sinus in Malaysia, the first one as far as I know. And hopefully we will try to do cochlear implants as well with a 3D endoscope. So then what we need to do is to elevate the tympanoid middle flap and until we are able to enter the middle ear space. So now we are actually into the middle ear space and you have a very nice view of the middle ear space itself. The round window looks directly at you, as you can see. The next step is to drill the facial recess. Now, the biggest worry about an endoscopic CI is the migration of the electrode. And you can see a very nice view of the stay-piece of the round window, and there's the facial nerve, very nicely seen. But what is important is we need to make a groove or a tunnel. If we do a tunnel, then we do not have to worry about the migration of the electrode at all. So we drill a tunnel, make sure it's covered by the bone, except for the last few millimeters just above the annulus. So with that way, the tunnel will go straight into the middle ear space. I think it's very important that we do the tunnel technique and not just a groove, simply because by doing a groove, there's always a risk of a migration of the electrode. So once we have done that, we also need to make a bed and collect the bone patty, because the bed is where the electrodes will circle inside. So then now we are going to drill the Formant to the round window itself so that we will be able to go into the round window niche and go into the round window and then identify the round window membrane. And then you can just lift up the round window membrane. As you can see, the view that you get is fantastic. And this is the final video, this view of the round window membrane that's been lifted up, a close-up view as well. And then we are able to insert the electrode quite easily. Again, this surgery took us around 20 minutes or so, 25 minutes or so. make sure that the electrode goes through the groove, then goes through the tunnel. Therefore, we can avoid the migration of the electrode, and we are able to visualize very easily. The beauty of the endoscope is in a very seamless manner, you're able to go close and then insert the electrode very nicely. So this is a 2D endoscopic CI surgery, and we're looking forward to trying to do a 3D. I'm not saying that this is how the future is going to be. I don't think it makes a difference whether you do an endoscopic CI, a VTOM 2D, or a VTOM 3D. I think as long as the job gets done, the fact that when you start traveling to do CIs in other places and the microscope is not available or it's too bulky to bring, this is a very easy system. But the caveat for endoscopic CI, in my humble opinion, is you must make a tunnel. Otherwise, the electrode will migrate and there'll be issues as well. That's the final view after the after the insertion. Only a very small groove of a few millimeters. All the other electrodes are under a tunnel, as you can see. And that's the groove for the electrodes to be coiled up as well. No need for any mastoidectomy. And this is probably one of the most important slides. The bone pate that we took, we need to position the bone pate back from the patient himself. So don't use bone wax that will migrate. Don't use any artificial tissues. Use the bone pate that from the patient himself, and fill up the entire small groove that we had just close to the annulus. And then this is the view after the closure. Good impedance. This is the electrodes. These are the electrodes, the apex, very good response. Mid electrode and the final electrode, very good response. And the patient was well post-operatively and was discharged the next day. So this is CI without microscope, just the beginning. And let's see how it goes in the future. Thank you very much for the invitation.
Repa, that was fantastic. So beautiful videos, and you showed us what's possible. And many of us have taken to endoscopic middle ear surgery, as you know, with tympanoplasties and ossiculoplasties and even stepidotomies. Some with small cholesteatomas. Moaz Tarabishi, really encouraged most of us to do this. And I can understand the next would be probably to include cochlear implant surgery, and I really liked your videos. My worry is, and I'm sure Deepak will share his thoughts on this. My worry is if we train this way all our juniors, because if we train ourselves now at this stage at a senior level to do endoscopic work and even your VCOM 2D and 3Ds, I would like to. What would we train our juniors? Would they get rid of the microscope? And if wouldn't that be a de-skilling, kind of training process? If there are no microscopes and you have not trained them, there's absolutely no way they can use the microscope.
Excellent question. That is the same thing that ran across my mind as well. But there are 2 points here. If we do not try endoscope, if we do not go into endoscope, we are going to be left behind, because the junior guys are beginning more and more with endoscope. But the way I look at it is, it's not easy to do a VTOM 2D or VTOM 3D or endoscopic CI unless you have done so many cochlear implants with a microscope. It's not easy, trust me. So even I've done more than almost 800 cases in many, many countries. And even yet, for the few 1-2 minutes, it took some time for my mind to adjust. So I think before anyone does attempts an endoscopic CI or a VTOM 2D or 3D CI, they must have done at least 50 to 100. Otherwise, you need something to bail you out. So if you're not able to do with the VTOM 2D or 3D or the endoscope, you turn to the microscope to bail you out. It's like doing a lap chole. You do 50 cholecystectomies first, then you do a lap chole, and you do a lap chole with an open set just in case it's going to happen. That's my take on it. So when I teach, I always tell them, fine, you do 50 normal cochlear implants, you're comfortable with the cochlear implants, then you can go to 2D or 3D. And our VTOM 3D bilateral simultaneous cochlear implant has been accepted by JLO, and the paper should be out in very soon as well. And the way I look at it for the senior people like us, I mean, if we do not also venture into endoscope, we will get left behind. So I think we should be able to do everything. And as I've said, I've only done 2 cochlear implants endoscopically so far. I probably try another Vitom 3D cochlear implant. And after that, I might just stop. Now that my curiosity has been satisfied, I might just stop after that. I don't know.
Very nice. Deepak, your thoughts? Deepak?
I think spot on. Your question was the best one and the answer was apt. I think unless we know the overall anatomy, even in endoscopy, sometimes we can get caught. So I think just about nothing to add. Yeah.
Okay. We pressed your time, Prabha. We could keep going on. That was beautiful. Thanks a ton for that.
Thank you.
We'll move on to the next presentation, and this would be James Look. James was past president of the GCIN and conducted a very good conference in Cape Town a couple of years ago, three years ago. And his predecessor, Derek Wagenfield, was the reason why we thought of the GCIN. He had organized a conference several years ago, almost 15 years ago, in Cape Town, where we took part, and it had pretty much the same concept as the GCIN. So in some ways, Derek Wagenfield is the father of GCIN, I would say. James is currently the head in ENT and head and neck surgery at the University of Stellenbosch in Cape Town, and several interests, including otology with a special interest in middle ear surgery, cholecystoma, and cochlear implantation, has contributed to the rollout of cochlear implantation to financially less privileged patients in South Africa. His unit was the first to introduce this initiative in South Africa. He has particular interest in training of surgeons in ear surgery. His Cape Temporal Bone course runs annually and is now in its 20th year. A fantastic teacher, a very dear friend. James, over to you to speak on surgical techniques for hearing preservation.
Thank you very much, Sunil, and thank you for your fantastic organization of this meeting and for kindly asking me to speak as well. We'll see if I can share my screen. Let's see. Sorry. Ooh. Share screen. There we go. Let's see if this is being shared. Are you seeing the presentation now?
Yeah.
Great.
Yeah, very clear.
Okay, thank you very much. So I want to give you just a brief talk. I want to talk about hearing preservation, and particularly about an aspect of hearing preservation that I use, of atraumatically enlarging the round window when it needs to be enlarged. So I think we'd all agree that increasingly in the future, it's going to be about hearing preservation. We're increasingly implanting ears with residual hearing. We know that atraumatic insertion into the correct scala, the scala tympani, gives us the best cochlear implant outcomes. We want to preserve residual low frequency hearing if we want to use electroacoustic stimulation. We also know that if we preserve cochlear and neural structure, this is important for the long-term performance of any specific cochlear implant. And we also know that pediatric recipients are likely to undergo multiple implant surgeries over the course of their lifetimes in the future. So everything suggests that we should be paying careful attention to techniques of hearing preservation. So what can we do about this? Well, the manufacturers are developing less traumatic electrodes. They're significantly less traumatic than they used to be, and this is an area of competition for them. You could think about using a short electrode, but I don't think this is a very popular choice because we're often dealing with patients who have a progressive hearing loss. And while a short electrode might be good enough at the time, in the longer term, you might need a longer electrode. So I think this is perhaps where there's been a move away from this. We clearly use medical treatment, generally in the form of steroids, both systemic and local. before the surgery, during the surgery, and after the surgery. But what about hearing preservation and the surgery, the surgical technique? So I think it's pretty obvious that minimizing the trauma in insertion will give us better hearing preservation. And I would say that we could divide this into 4 aspects, thinking about how we do the surgery. There's the initial trauma on entering the cochlea, which one can minimize. There's then the insertion trauma when you're advancing the electrode. So in doing this, you can abrade the modiolus, you can abrade the lateral wall and the stria vascularis area, and you can cause pressure changes in the inner ear fluids, all of which can be damaging to the hearing and sometimes to the structures. And then having inserted the electrode, don't forget, of course, that movements, once it's inserted, can also be traumatic. So what factors are within the surgeon's control? Well, the thing we'd all agree on is that creating the entrance to the cochlea must be soft, whether you do it by cochleostomy through a round window membrane or an extended round window. The choice of electrodes is important for the particular cochlea that you're inserting into. And then the angle of insertion is something to bear in mind to avoid unnecessary abrasion of the modiolus in particular when the modiolus is in the way. So bear in mind the angle of attack to the insertion. And then we're taught that advancement of the electrode should be extremely slow to minimize intracochlear pressure changes. So I would argue that the round window is unquestionably the way to go. Not everybody agrees with this, but I really think that for me, it makes sense. And the more I've got used to using the round window, the more I've believed that I'm comfortable with it. Firstly, it's a clear anatomic landmark. You're not drilling into bone, trying to find the basal turn. Secondly, you're guaranteed to be inserting into the scala tympani, which is where we really want to be, not in the scala vestibuli. It minimizes the trauma of opening the cochlea. You don't have to drill and you don't have to suck. You don't end up with bone debris from drilling into the cochlea, which is then difficult to remove in order to see what you're doing. If you're drilling and you have bone debris, then you're required to use higher lathes perhaps to extrude the bone debris, and that in itself causes run-on complications. So it enables you to minimize perilymph loss, which is so important for hearing preservation. Finally, it of course gives you 2 millimeters more of spiral lamina for stimulation because you have that initial portion of the cochlea. You're not bypassing that initial portion. However, as good as the creator was in giving us the round window through which to insert, it's not quite perfect. Could have been a little bit better. The first thing is that, as we know, it's often rather posterior in relation to the facial nerve, which means that it's hiding a little bit behind it. Secondly, the round window may be small and need enlarging. The membrane may be angled, as indicated here at the top. It's generally, so if we regard this as being a left ear, it's generally angled a bit inferior and a bit anterior. So you don't get the full diameter of the round window nicely presented to you. You also have to deal with a cochlear hook as illustrated in this middle photograph here, where you're not straight into the basal turn of the cochlea. You first have to get around the hook before you then get into the basal turn. And this tends to push you onto the modiolus, so that you may find that the modiolus may be in your way. So if this is a left ear we're inserting into this bottom simple diagram attempts to show the situation where you have your basal turn visible with the fluid, but you may find that you see the white of the modiolus here a little bit in your way in a left ear. So the round window sometimes needs optimization, extension or enlargement. And this is really what I'd like to talk to you about is how I do this. And I'd like to hear how the rest of you deal with this situation. So clearly one optimizes the posterior tympanotomy, and I certainly have moved in the direction of always skeletonizing the facial nerve so that you can give yourself as optimal a posterior tympanotomy as you possibly can get, and you know exactly where the facial nerve is. Clearly, one has to remove the round window niche bony overhang in order to see the full diameter of the round window as it is in your particular patient. Now, this is what I would then do if I find that the situation is not optimal and I don't believe that the round window as I'm finding it is going to work for me for implantation. The first choice is, if you really want to preserve hearing, you could say, well, I've got a round window which is not ideal, but let's take a very delicate electrode, the thinnest possible, softest possible electrode, and let's use the existing round window niche, a round window membrane, which may be adequate for this. But if you want, for instance, a modiolus hugging electrode, a somewhat bigger electrode, and you need the round window enlarged, this is what I would do. I would eggshell externally the rim that I want to enlarge while leaving the membrane intact, not yet opening the round window membrane. Having done that, you then open the round window membrane, and I then use the little instrument which you may know called the Hirman knife to remove the little bit of eggshelled bone that I have created in order to enlarge the round window insertion. So this is the little Hirman knife. You can see in the main picture that it really is a very, very delicate instrument. And the picture above and the picture below show it at significant enlargement. And you can see it has a rather robust right-angled circle at the bottom end with which you can pick out little bits of eggshelled bone. So here's the video I'd like to share with you, just demonstrating that. We hope that it'll run. So here I'm measuring and seeing it's a bit small. I'm then leaving the membrane intact and removing the bit of bone anteriorly and inferiorly that I want to eggshell in order to enlarge the insertion. You can see the membrane's nice, it's good, but it's rather angled inferiorly and anteriorly. So we're taking away the bone in those directions so that we can remove the bone to insert the electrode. I think you might also be able to see, I certainly can, that there is an element of, there we're measuring it, there's an element of modiolus presenting itself to the left of the round window, superiorly. This is then, we've then removed the membrane, and we are now able to gently pick away at this eggshelled bone in order to enlarge minimally, but enough, the round window that we have through which we want to insert. And in this particular case, we wanted to insert a contour advance electrode, one that in fact had was modiolus hugging and was therefore a bit thicker and needed that bit of extra room in order to ensure atraumatic insertion. So we're just picking away slowly at this thin bone in order to provide an adequate opening for insertion. And there we are testing to make sure that it's good enough and that we've got enough space through which to insert. So there's been minimal enlargement, but there has been some enlargement of the insertion. So that's really what I wanted to share with you, and I'd be interested to hear whether you have any other alternative techniques that you might use when you want to extend your round window insertions. Thank you.
Well, James, that was absolutely fabulous. And I think that was everything you wanted to know about hearing preservation CI surgery and were afraid to ask. So I think you covered it all. You've done it really well. And I particularly liked your Hirman's knife and that eggshell thinning of the crista fenestra that you beautifully showed in your video. Thank you so much. We're pressed for time, so we will move on to the next presentation. And this would be by another dear friend of mine, Dr. Fatih Baki. Fatih is from Alexandria in Egypt, and he was the immediate past president of the GCIN, and he's the emeritus professor in the Alexandria Faculty of Medicine. Several positions he had held in the past. He has a number of publications, 50 plus in the field of otology and audiology. He has also published a book for undergraduates, Illustrated Conference of Otology, supervising more than 50 MS and MD theses. We have professors and fabulous teachers in GCIN, I must say. He also reviews several journals. Over to you, Fatih, to talk to us about cochlear implantation and otosclerosis.
Good morning, everybody. Thank you, Sunil, for this nice introduction. Let me first share my screen to try to share my screen. My talk today about, can you see the screen, Sunil?
Not yet, not yet.
You can see it now?
Yes, now. Yes, yes.
Okay, so it's a pleasure to see my dear friends, all my dear friends in one screen. And it's my pleasure to present today on cochlear implant in advanced.
Can you make it a slideshow, doctor?
I beg your pardon?
Make it a slideshow. Put it on slideshow.
Yes, sorry for that. Okay.
Yes.
So first, I would like to congratulate you, Sunil, and your team for this excellent, superb conference. The platform is super. So please give my regards to your IT team. It's a friendly platform, so it's very nice, actually. Some basic info on advanced otosclerosis. The most important thing to look in advanced otosclerosis is the speech discrimination score. So if the speech discrimination score is below 50%, this will need some interference. Luckily, the pure cochlear otosclerosis is less than 1%. And most of the cases are mixed otosclerosis, meaning it was fixation of the foot plate and then go to the cochlea, which can benefit from stapedectomy. In the pathology, the normal bone is replaced by spongy bone, the vascular bone. And this vascular bone or spongy bone, which usually appear as radiolucent bone. And sometimes this bone come to be mature and to be sclerotic, which might not show in imaging. So sometimes absence of findings in CT does not mean that this is not otosclerosis, but it could be mostly mature sclerotic bone, which don't show and need some densitometer or something like that. These are the most common site. Of course, it's the fistula antifenestrum, and then it comes to fix the foot plate, the annular ligament. It can and then the most important is to check the round window, because if the round window is obliterated, there is no way to do stapedectomy. And what is our target today is a cochlear otosclerosis, which sometimes remain in the lateral wall, but in other times it extends inside the cochlea, which can make some difficulties during insertion of the implant. For the pathology, the burden is mainly on the lateral wall. This is the hyalinization of the spiral ligament. This is the hallmark of the cochlear otosclerosis, this hyalinization of the lateral wall. Then to the lesser extent in the organ of the corti, and to minimal extent in the spiral ganglion. This is different from the meningitis, where the spiral ganglion are commonly affected much more than in otosclerosis. And this slide is courtesy of one of my friends, Dr. Ali Gamal. So to diagnose that this is otosclerosis is sometimes difficult, but there are some features like family history, symmetrical, and Schwartz sign, which can point you to that this mixed hearing loss is an otosclerotic lesion. The most important point is it's difficult sometimes to determine the cochlear reserve. You don't know if there is a cochlear reserve or not, especially in a blank audiogram, and this is difficult to determine except with an ECG. What are the imaging findings we are expecting to see? Of course, this is the typical radiolucent findings in the fistula antifenestrum. This is radiolucent findings in the round window. Another one in the round window, but in a coronal plane. This is the double ring, the halo sign, where the radiolucent is surrounding the cochlea and parallel to the basal turn. This is also a double ring, but in a diffuse form, in a pericochlear hypodense diffuse form. Sometimes you can see both lesions, the fenestral and the retrofenestral. A point to be maybe a differential diagnosis. Sometimes there is a radiolucent area beside the cochlea, and this is not an otosclerotic lesion, but it is a cochlear cleft. The MRI, the main role of MRI is the T2. T1 is diagnostic, but the T2 is mainly to look if there is a patency of the basal turn or not. For example, on the left side, there is a fluid, there is a patency, while on the right side, there is no patency, a fact which can let us do a scala vestibuli, maybe, or we can do some drilling. There are different classifications for gradings. It's ranging from 3 grades. The two most commonly adopted classifications are Simons and Rotiville. Without going into the details, both of them in grade 1 and grade 3 are the same. In grade 1, it's fenestral. In grade 3, it's diffuse. The difference between the two is grade 2. The first classification divided into anatomical region. Is it a lesion in the basal turn, it's a medial turn, or in both? Whereas the second classifications, the main difference is whether it is in the cochlea or it's intraluminal or both. And I can find that this is more clinically important, so that it can say whether the basal turn is narrowed or not. Fraisse and his colleagues, Kabara et al., suggested another grading system by staging, whether it's only the foot plate or it come to involve the endosteum, or the third point, which is a pericochlear lesion or round window, which are the stage 3, which will not be amenable to stapedectomy. What are our treatment options? The main treatment option will be the stapes surgery with a hearing aid or cochlear implantation. How can we make the decision between cochlear implant and stapes surgery? There are different algorithm guidelines, but they rely mainly on one fact, the speech discrimination, whether the speech discrimination is poor or not. I try to simplify matters to see what are the advantages and disadvantages of each technique. Of course, stapedectomy or stapedotomy, it's a low-cost procedure. It does not need training. It does after the surgery, the sound is natural, and one of the most important items is the binaurality. The patient can hear bilateral. And in countries where the resources are less, we have to offer the patient stapedectomy and hearing aid unless this will not be indicated. The point is when not to do stapedectomy. When we go to cochlear implant directly. Of course, if the airborne gap is less than 30 dB, you don't go for stapedectomy. If you find the round window is obliterated, there will be no double window mobile windows. And by imaging, if you see extensive lesions and you are afraid that the progress will be soon And in such a time, you cannot do cochlear implant later on, you go for stapidotomy. Although now the use of the bisphosphonate, which will stabilize hearing, might stop the process and will increase the window of opportunity to give you some chance to do stapidotomy, and if it fails, you go for cochlear implant. How we can say that this stapidotomy is successful? If with a hearing aid, the maximum speech discrimination score will be more than 50%, putting the patient outside the range of CI candidacy. When we counsel the patients, we have to tell him that the success rate in some cases may be less than 30%. The result may be insufficient, and with time, results can deteriorate and he will need the cochlear implant. The good thing here that the cochlear implant, the salvage cochlear implant, has the same result as primary cochlear implant. So again, in countries where the resources are limited, we encourage doing stapidotomy, and if it fails, we go for a CI. On the contrary, CI surgery you want to do will be the opposite of the contraindication of stapidotomy. If the airborne gap is less than 30 dB, if there is round or window obliteration, or if there is extensive lesion. And the salvage CI will be done in cases of failed stapidotomy or in case of progress of hearing loss. And as we mentioned, the results of salvage is as good as primary CI. Of course, CI surgery, the improvement in hearing is better and it's consistent. On the other way, the disadvantages, the procedure is expensive, it needs certain surgical skill, there are possible complications, and the programming and reprogramming may be a problem. Some points about the surgical technique. Here you have to be ready for subtotal petrosectomy in some case. You have to be ready with all types or some types of different electrodes, the perimodiolar, the short, the double array. Here we have to be ready for insertion in the scala vestibuli or the second, third, and of course, intraoperative imaging or immediate post-operative imaging is mandatory. What are the complications of CI surgery in otosclerosis? The most common complication is the forced tracking, the misplacement of the electrode. This is the halo sign, and it's easy that the electrode will go in this cavity instead of going into the basal turn. Or we go to the basal turn and it penetrates to the other cavity. Another complication, it extends to the internal auditory canal with the possibility of a CSF gusher. Or the most common complication is if the otosclerotic lesion is in the perigeniculate area, mainly there will be the facial nerve stimulation, which is in 25% of cases due to increased conductivity of otospongiotic bone. And it is to be noted that usually it affects the mid-array electrode. Why the mid-array electrodes? Because they are placed in the upper basal term. Why? Because it is closest to the labyrinthine facial nerve. How to manage reprogramming? There are companies which have the triphasic. You can reprogram the electrodes which are responsible for these facial nerve simulations. If not, you can deactivate them. If not, you can remove electrode and re-implant, and we advise to re-implant with a perimodiolar to be away from the facial nerve. There is a good hope from the third generation bisphosphonate. The studies are still limited. There is no long-term follow-up, but they are encouraging that it stabilizes hearing in some cases. Another procedure which might have a role, which are the active middle ear implants, especially the DACI or the vibrant sound bridge, which can be extended indication in some cases before doing a cochlear implant. Lastly, I would like to announce on the master class, we have a soft opening of the master class. And yesterday I had a meeting with Professor Thomas, and we have settled the minute details, and we expect to start from January to June 2022. So I encourage young generations to join this master class. At the end, I would like to thank you and congratulate the whole team for this superb conference. Thank you, Sunil.
Thank you very much, Fatih, for that very comprehensive lecture on CI in far advanced autosclerosis. I think we're pressed for time. We'll try and see if we can take some questions in the end. So I'll move on to the next speaker. This is Dr. Hisham Hamad, who will speak to us on cochlear implantation and cochlear hypoplasia. Fatih tells me Dr. Hamad is a professor emeritus of otology, skull-based surgery at Tanta School of Medicine in Egypt, and he has an extensive experience in the treatment of cochlear malformations, cochlear implants and cochlear malformations, including cochlear hypoplasia. Here's Dr. Hamad's CV available for you to have a look at even later in the recordings. So over to you, Dr. Hamad, presentation, cochlear implantation and cochlear hypoplasia.
Good afternoon. I want to thank Dr. Sanil and all organizing committee for the kind invitation. And I want to congratulate them for this great conference, organizing this great conference. Let's see, I'll try to share my screen.
Slideshow.
I'll try to go for slideshow.
Yeah.
Okay.
You're good to go.
Okay, it is shared by, you can see it now, okay?
Yes, very clearly.
Okay. I am going to speak about cochlear implantation in cochlear hypoplasia, and mainly how can measurement of normative value can solve many of the diagnostic challenges in this condition. Of course, we all know that the normal cochlea has 2.5 turns with cochlear duct length of about 25 to 35 millimeter. It's considered hypoplastic if it is less than 2 turns, or if its length is 20 millimeter or less. Cochlear hypoplasia is not uncommon. It constitutes about 15% of inner ear malformations. Cochlear hypoplasia in general is not one and the same disease. It is a spectrum of disease. On one end of the spectrum, the most severe forms are associated with more anatomical abnormalities like thick bony promontory wall, abnormal facial nerve and vestibulocochlear nerve, syndromic association. While on the other end of the spectrum, and these severe forms also are associated by poor speech outcome due to fewer ganglion cell population. On the other term of the spectrum, the less severe forms are easily missed as normal cochlea. So I consider them two different clinical entities grouped under the same heading. Sinaraglo classified cochlear hypoplasia into 4 types: type 1, 2, which are cystic, and type 3 and 4, which resemble normal cochlea. In type 1, it is a small ovoid structure with no modulus, no interscallar septa, and easily identifiable by visual inspection. While type 2, which is a mini version of IV1, it has a normal external outline, but defective modulus and interscallar septa. And CT measurement may be needed to differentiate it from IP1. In both these types, electrode length insertion depends on measuring the perimeter of the cystic cavity. So in type 1 and 2, the rule is to try cochlear implantation if there is anything to implant. It's better than ABI. In spite of the presence of the thick bone, which produces difficulty over the promontory, making cholesterol more difficult, as a lot of drilling is needed, in spite of the presence of hypoplastic cochlear nerve, stenosed cochlear aperture. And in these cases, we have to be satisfied with partial insertion, as if we try to insert more, the more we insert are not the better, because this will result in over insertion with crowding or bending of the electrodes and giving the shape of big tail appearance. A useful method is the rounded insertion described by Chen. In cochlear hypoplastia type 3, cochlear is dwarf, having only 2 turns and easily mistaken with normal cochlea. While in cochlear hypoplastia type 4, which is a mini version of IB2, the cochlea has a normal basal turn, but the middle and apical turn are severely hypoplastic and located anteromedially rather than in their central normal position, giving the shape of head on chest appearance in CT. And it should be differentiated from IB2. This is one of the early cases in our center. This child has a well-developed basal turn, apical abyss, was diagnosed first as IB2. Intraoperatively, only 11 electrodes out of 22 electrodes were introduced, and the post-operative CT scan showed that the cochlea was fully inserted with electrode reaching apical turn. So it turns out to be a case of cochlear hypoplastia type 4 rather than IB2. So we concluded that visual inspection of the CT may be misleading, and it has been reported to miss up to 1/3 of the less severe cases of inner ear malformation. So we need objective inner ear measurement in order to complement our visual analysis of the temporal CT. Looking for objective indicator of cochlear hypoplasia, the method described in the literature to measure the cochlear duct length are not helpful, because usually the different turns of the cochlea lies in different coronal branes. So multiplanar coronal reconstruction can only visualize one turn at a time, either the basal turn or the middle turn or the apical turn. Putting in mind that the basal turn constitute a fixed portion of the total cochlear duct length in normal cochlea, this length can be calculated indirectly by measuring the width and the length of the reconstructed basal turn as described by Scott. However, this works well for normal cochlea, but it's not suitable for hypoplastic cochlea, especially type 4, cochlear hypoplasia type 4, where the basal turn is normal in size, but the apical and the middle turn are hypoplastic. So in cochlear hypoplasia, we need other radiological indicators to measure the hypoplastic cochlear duct length. A 3D volume rendering can beautifully show the configuration of the hypoplastic cochlea, and hence we can get classified into small when it has less than 2 turns, X small less than 1.5 turn, and double X small when it has less than 1 turn. The curved multiplanary CT, reconstructed CT, this is commonly used by our colleagues in cardiology to visualize the coronary arteries. And here it can be applied here, where all turns of the cochlea are traced and marked in all different sections of the CT scan. And the real length of the cochlear duct in all turns can be reconstructed and unfolded into a linear configuration and directly measured. Although both 3D volume rendering and the curved multiplanary reconstruction are good methods to evaluate the cochlear hypoplasia, they are difficult to be implemented clinically by cochlear implant surgeons in developing countries. So in these countries, we need simple indicators for cochlear hypoplasia based on commonly prevailing axial and coronal CT. We conducted a study on 65 Egyptian children. All were candidate for cochlear implantation, or showing normal radiological cochlear anatomy. All had full insertion of FlexSoft or standard classic electrode intraoperatively. The preoperative CT scan were reviewed retrospectively by radiologists and otologists, and we calculate the following measurement: the basal turn length, the cochlear height in the axial and in the coronal view, the upper turn height, including the apical and the middle turns. The mean of these calculations were used and the standard deviation was calculated. The cutoff value to suspect cochlear hypoplasia was defined as less than 2 standard deviation below the calculated mean. The basal turn length, as you can see here, is measured in the axial view at the level of the round window as the longest axis of the basal turn. Our cutoff value was 7 millimeters. The axial cochlear height is measured here as the mid-modular axial view at the maximum distance between the midpoint of the cochlear aperture to the midpoint of the apical turn. Our cutoff value was 3.1 millimeter. The coronal cochlear height measured in the oblique coronal multiplannar reconstructed view, representing the maximum height that included the basal and the upper turns from the midpoint of the basal turn to the midpoint of the apical turn. Our cutoff value was 4.2 millimeter. The upper turn heights, including the middle and the apical turn, measured at the axial view and the mid-modular axis from the midpoint of the interscallar septum, separating the basal turn to the midpoint of the upper turn. Our cutoff value was 2.1 millimeter. Comparing our cutoff values indicating cochlear hypoplasia to those reported in the literature by Purcell, Pamuk, Mori, and Zahara, our values are similar, but only a fraction of millimeter less than that reported in the literature, which may suggest ethnic variation. At least 2 parameters must be abnormal to indicate cochlear hypoplasia. Again, insists cochlear hypoplasia type 4 may show normal basal turn length, but the abnormal cochlear height and the abnormal upper turn height indicate the diagnosis. Ethnic sex difference may exist. Standardization of the CT is a must. High resolution supplementary CT to show the best bony soft tissue interface during magnification of the image. And a multi-center study on large number of patients with inner ear malformation is being conducted now to validate by us, to validate our cutoff values on real cochlear hypoplasia cases confirmed by curved multiplannar reconstruction or CT. Conclusion: visual inspection may overlook cochlear hypoplasia, and cochlear measurement are helpful. Objective CT indicator for cochlear hypoplasia in Egyptian population are basal turn length less than 7 millimeter, axial cochlear height less than 2.1 millimeter, coronal cochlear height less than 4.2 millimeter, upper turn height less than 2.1 millimeter. At least 2 parameters must be abnormal to suspect cochlear hypoplasia. Cochlear hypoplasia type 4 is the most difficult to separate from IB2. Measurement of upper turns and cochlear heights are more significant as basal turn may be normal. In doubtful cases, we can order 3D volume rendering or curved CT. While on the other form of the spectrum, this is a different clinical entity. Severe forms of cochlear hypoplasia are associated with difficult surgery due to thick bone over the promontory, atretic cochlear aperture, hypoplastic cochlear nerve. Less severe form are easily missed as normal or IB2. In cochlear hypoplasia, we have to select thin and short electrode. We don't be depressed by partial insertion, otherwise over insertion results in bending of the electrode. In severe hypoplastic cochlea, expect lower level of speech performance. And last, cochlear hypoplasia, we should not forget that cochlear hypoplasia can be syndromic. So always exclude associated syndrome. Most commonly are bronchio-otorenal syndrome by doing careful neck and renal examination and charge syndrome. Thank you so much.
Thank you, Dr. Hamad, and that was really exhaustive, really liked it. And I think what we will do is we'll add you to the World Cafe, panelists who have discussed cochlear malformations just a week ago. And I think it would be great to include your inputs in that World Cafe. Again, time is of value here, so I'm going to move on to the next speaker. This is Dr. Mario Zanotti from Argentina. Mario is again a wonderful friend of ours. He's with us for the past 3 decades or so in the field of hearing implants, professor at Catholic University of Cordoba, hoping to organize a GCIN conference, CIN conference there in the near future. He's also a professor of ENT and otology and heads the department at Sanatorio Allende. He's a member of the hearing group. He's contributed immensely to this field. Mario is just unable to join us directly, so he sent us a video of his, a recording of his presentation. Let's try and see if we can play that, Anil.
Thank you, Sanil. I have a problem with my internet, sorry, because this is the reason to send you the pre-recorded lecture. Thanks.
You're welcome. So Anil, if we can play the video.
Hello, dear colleagues. It's for me a pleasure to participate in CIGICON 2021. Thank you, colleagues. Thank you, Professor Sunil, for this Congress. I want to share my screen with my lecture for today. And this is the lecture about the adhesive bone conduction device and long-term results in subjective benefit in children with atresia. As you know, usually our colleagues in general pediatricians and general practitioners don't consider that the conductive hearing loss is a problem. However, the World Health Organization said that a kid with conductive hearing loss has severe problems with their learning to the language, to participate in normal activities, and to access to a regular scholarization. We can see in this systematic review that the problem of the congenital aural atresia inclusive in unilateral mode is very important to the scholarization of the children. In these 2 studies, we can see that 15% of the children need special education and 36 of them use an individualized education program. In the second study, we can show that the 30% of the patients received special school intervention and 25% of these children have learning problems. Therefore, 60% of these children with unilateral congenital aural atresia is a problem for the health, the public health in our countries. Which are the tools that we have to improve this situation? As you know, the glass frames was the first option, probably the oldest option, but now it's not a very good solution because usually it's uncomfortable for the patients, and on the other hand, the pressure of the retroauricular region is not enough to give to the patients a good hearing. The second one is the rigid band. The rigid band are very common, but as you know, the rigid band can produce this kind of lesion, injury on the skin in these children, inclusive when the children used during a long time, this rigid band produces remodelation of the bone of skull. And finally, the soft band are very common now, but the soft band is a good option to improve the hearing in this patient, but unfortunately, in many patients, when have the soft band, the patient suffer from bullying in the school because the other children don't permit this situation with these children. Therefore, we need something else, a new tool. And the new tool is the Adhere. Adhere has two parts, is a bone conduction device, adhesive bone conduction device. As you can see, have two main parts. The sticker, the adhesive sticker, is a pad that you can put in the behind the ear position, and the audio processor that connect with the pad with the button click. And here is a very good alternative for this patient, and we have a long study with 15 subjects, all children with a mean age of 9 years. And the etiology on all of these children was congenital aural atresia. 8 of these had bilateral affection and 7 unilateral conductive hearing loss, as you can see. Regarding the syndromic situation of this patient, 73% of this patient only suffer from microtia atresia, and 27% of these suffer from a syndromic situation as Goldenhar or Treacher-Collins syndromes. Let me show you the audiometry, the previous audiometry to use the Adhere. The PTA4 was in air conduction threshold 67.1 dB, and the bone conduction only 12 dB. It's a normal situation in a patient with atresia, aural atresia. The air bone gap reached 55 dB. Here you can see the results 1 month later, 6 months later, and a year later of use the Adhere. The results in this audiogram, you can see in blue line the condition, the basal condition previous to the use of the Adhere in 67 dB, and after that in red you can see the results using Adhere 1 month, 6 months, and 12 months, and the functional gain reached 34 dB. What about the discrimination of this provide for these prostheses? In quiet, this patient in unaided condition reached only 31% of discrimination, while we use the Adhere discriminate 91, 92, and 93% 1 year later. When we compare the discrimination speech in noisy environments, you can see that the patients in unaided condition only discriminate 20% and move to 80% to 1 year later. And when the speech and noise is the same volume, 65 dB of noise and 65 dB of speech, the discrimination in unaided condition is only 12%, and with Adhere advanced is 65, 67 at 6, and 71% at 1 year later. Regarding the subjective satisfaction, we use the MICE questionnaire to assess the auditive dependence, the perception, and discrimination. As you know, MICE questionnaire, the maximum is 40 points. In the basal condition, all of these children only have 25 points on average, and move to 39 points 1 year later. And the MUSE is a very specific questionnaire to the voice control, the spontaneous use of the speech, and to evaluate the communication strategies. This patient moved from 27 points to 38 points 1 year later. The test APSQ is to measure the subjective satisfaction and all domains: wearing comfort, social life, usability, and device convenience are very similar. You can see that all patients relate a high subjective satisfaction at 1 month, 6 months, and 12 months, as you can see in this situation, and improved especially in social life in usability domains. When we ask to the children about 3 or 4 points very important, for example, how difficult is to use the adhere, all of them response that it was very easy. It's very important. When we ask about the experience in putting the audio processor back in the adhesive pad behind the ear, all of them, 15 patients, they said that most of the time they need only one attempt to put the adhere. Finally, regarding to the quality of sound, 15 patients, 15 children said that the sound is very, very good. Therefore, the result of this study is high acceptance, high subjective satisfaction, and low number of complications. This study was recently published in Audiology and Neurotology, and is the longest study with adhere in children with congenital oral atresia. In conclusion, adhere is an excellent non-surgical option for conductive hearing loss. That conductive hearing loss is a very important problem for children. Audiometric, the main functional gain in audiogram reached 34 dB, and the discrimination inquiry reached 93% of discrimination. The wearing time is very important in children, and the mean was 12 hours per day. Therefore, all working hours, the children use the adhere. The interval of change of the adhesive pad in a year was 4 days in average in winter season, and 3 days in summer and humid season. Therefore, it's very important for the usability of this device. Finally, adhere is a small device, easy to use, don't produce pressure on the skin. The personal management of the device for the children is very important, the on-off and the regulation of volume. And finally, only one battery is for each 12 days of intensive use. Therefore, in our opinion, the first step before the surgery of the bone conduction prosthesis is adhere, as you can see in this work. Thank you so much for this kind invitation. It's a pleasure to participate in this Congress. And thank you, Sunil, and greetings from Córdoba, Argentina. Thanks.
Mario, that was a very nice presentation. I just wondered, who looks after the non-surgical options in your country? Who pays for it? The National Health Service, the government, or it's a self-funded from out of pocket?
Thank you, Sanil. Usually in our country, from 5 years old, we can do the surgery of the implantable devices, and usually the insurance and the government cover the prosthesis.
What about adhere and the soft band Baha, and what about even the sound art Baha?
Usually, in my opinion, I prefer the transcutaneous active device like bone bridge, but sometimes we use the percutaneous option as Baja or Poncho, as you know. But in general, I prefer the transcutaneous option.
No, my question was, who pays for adhere? For example, is the patient paying for it or the government pays for it?
Usually, fortunately, the government pay for these prosthesis, but only in bilateral cases. In unilateral cases, no, unfortunately.
Yeah. Okay. Wonderful. Thank you so
Thank
much.
you.
And I think
Thank you and congratulations.
Thank you. We have 2 more presentations, but I'm not too sure if Moaz Tarabishi is joining us because he requested to be last today. I'm not sure if he joins. We definitely have John Greinwald here, all the way from Chicago. I'm not sure what time this is. Cincinnati, sorry. And I'm not too sure what time this is, probably very early in the morning. So good to see you, John. John Greinwald has been a GCIN steering committee member for several years now, a tenured professor of otolaryngology and pediatrics at the University of Cincinnati with over 20 years of experience, with a very specific focus on the genetic causes and the treatment of deafness as well. He founded the genetic testing for hearing loss team and co-founded Ear and Hearing Center at the Cincinnati Children's Hospital. You want to do a fellowship with John, you will be very happy to do so. He's published several publications, papers on minimal access techniques in cochlear implant surgery. He's spoken about, published about genetics of deafness, over 95 peer-reviewed articles, and a lot more of research. And again, a wonderful teacher, professor of otolaryngology, head and neck surgery. John Greinwald will talk to us on pediatric cochlear implants from genetic hearing loss to neural hearing loss. Over to you, John.
Well, Sunil, thank you so much. That's very kind of you. And can you see my screen okay? Get it on.
Yes, we can.
Go. Oh, perfect. So, well, it's obviously an honor, and I feel so horrible because obviously coming to your beautiful country is on my bucket list, and having the pandemic mute that, I hope, of course, pretty quickly we will be circling back around to the beautiful country of India. And thank you for you and the organizing committee for doing a phenomenal job. These are very challenging to do when you're doing them in this regard, but then to still get that education piece is truly wonderful. It's been my pleasure to be part of the GCIN now. This is my 6th year, so I've really enjoyed it, and I look forward, of course, being back in person, hopefully next time. So I've been tasked to talk about how genetics may be affecting us both on a sensory as well as a neural component. I want to give you greetings from Cincinnati, Ohio. And yes, it is dark here. It is still making our transition into morning in another hour or two. So that's why it's a little dark behind me. But we want to thank you. Anybody who happens to be traveling over here, hopefully once the pandemic is over, please stop by. We'd love to share our experiences here. I have to digress for a second, though, because I am a diehard Atlanta Braves baseball fan. So for those of you who don't know in the rest of the world, we just won the baseball World Series. So we're very excited down south about that. And actually, I got a chance to even go to the 4th game in Atlanta. So it was very exciting. So, you know, in these very challenging times, when, you know, we're just coming back to doing anything that looks like normal, hopefully we can, you know, sports is another way to, as well as our medical conferences, to get our communication from culture to culture. And so hopefully this will be the beginning of getting us back to whatever normal is going to be. So for my disclosures for this short talk, too, is that I'm actually, as a molecular geneticist, I'm involved in gene therapy. And I'm going to talk about that briefly at the end, because this may have a big impact, of course, on those of us who do cochlear implants. So we'll have to see how that pans out. Both autonomy and RINRI I have been involved with. Autonomy in the US and RINRI in the UK. So let's just start with a kind of a case report that sets the scene here. So we have a 3-month-old with a failed newborn hearing test, had an ABR which showed some profound, what we think is a sensory loss. There were no neonatal risk factors, the common things, prematurity, jaundice, ototoxic medications. The audiologists had already go ahead and they fitted hearing aids and start to place them. There's no real family history of hearing loss. So a relatively, what I call a boring medical history, relatively straightforward. So of course, treatment options, we all know we talk to the family, find out what their approach wants to be. This family wants an oral approach to language, and they are very open to early cochlear implantation, as it's been talked about in this conference. Now we are pushing the envelope to go earlier and earlier. And of course, one of the issues with that is that we have to be really sure that we're doing the right thing for these patients. So again, how do we predict success in this early CI group? If you're going to be implanting children by 6 months of age, you want to make sure that those children are appropriate, have appropriate criteria, and we want to help the families understand what is the likelihood of them doing well. Well, of course, as surgeons, we like to see normal imaging of both the IAC and the brain. We like generally kids who are non-syndromic. We want to make sure that our family support is set up well and that their early intervention services that they'll be accessing are going to be very robust. So all these things are the things that we kind of think about. Now, let's think about the genetic contribution, because we know genetics plays a huge role in all hearing loss, whether it's profound or mild. And we do know that non-syndromic hearing loss, of course, is the most common, and most of it is recessive. So normally there's not going to be a large family history. They're not going to, in most cases, they won't have an obvious syndrome that would tell us exactly what's going on. So here, of course, and as Sunil had commented on, my interest has been in genetics since my fellowship back at the University of Iowa for many decades ago now. And so we've been really in all over the world, we've been understanding what the genetic causes are. And now that genetic testing is now becoming much more available, both in all parts of the world now. Hopefully this will then help us as cochlear implant surgeons to understand what the etiology is, to know that yes, we're doing the right thing, particularly for this early implantation group. So, and of course, what we want to know is this patient in what I call the medically boring group, a classic autosomal recessive, non-syndromic kind of group, because, and we'll talk about that in just a minute, how important it is to make that diagnosis. Do they have some undiagnosed syndromic event? And we'll talk about that, because many of the syndromes that we get excited about in ENT actually are not craniofacial. You will not be able to determine them by looking at the patient. And of course, helping to understand in this little 3-month-old, is CI candidacy really the way to go? Because there are many, many papers that have been written, and we pioneered that work on GJB2 many, many years ago, that you can predict the hearing loss based on the genetic findings. And then now, of course, we're now getting extremely interested in neural hearing loss. And it goes by many names: auditory neuropathy, neural loss, synoptopathy, many different variations. And of course, that is becoming important because the genetics of that are now, of course, being unfolded. Here's somebody in the background. Okay. Okay. So there are, if you look at all the many, many genes that are going on that have effect in the human, there's really only a short list of about 10 that have a major impact, in which if you do studies and look at population studies, that these are the genes that are going to be the most prominent. We know that GJB2, the most common, SLC26A4, which causes Pendred syndrome. The ones that you see in red are going to be those that cause Usher syndrome. And oh, by the way, many of these genes can have a non-syndromic phenotype. They can still be deaf, but they won't have Ushers. Two that are very interesting, and I'll comment on one of these, TMPR SS3 and otoferlin, cause a more neural hearing loss pattern. Actually, in the US, we were one of the first ones to talk about auditory neuropathy and cochlear implants many decades ago, and how that those patients can still get a great benefit from cochlear implants. Now, this may be the money slide. So if you want to remember one slide, this may be the most important. And I borrowed this from one of my partners, Marley Kinney, in which we see that the various genes have an effect in various parts of our auditory system. And what's important is some of these genes can have a huge impact of how well patients will do with cochlear implants. Because again, the bottom line is, if you're talking about cochlear implants in children, we want to know how, the parents want to know how well is the child going to do. And as we can see here, in the neural partition, of course, clearly if you have spiral ganglion neuron degeneration, patients will not do well with cochlear implants. And so we're trying to understand the benefits, for instance, and you see the TMPR gene, which there's a lot of interest now in not only treating that with cochlear implants, but also hair cell spiral ganglion regeneration with that. On the sensory side, most of the genes we deal with are just classic hair cell issues or supporting cells, or all the classic cells in the scala media. One, though, that's very important is otoferlin, which actually has a problem right at the synapse. And so that's why we think those patients do so well. Now for GJB2, if you're going to pick a genetic defect to have, this is the one you want, mainly because it's relatively common. Again, about 60% of the patients will be classic cochlear implant candidates. And based on the genotype, I could look at a family and say, your first ABR shows profound loss, your genetic hearing loss shows profound loss, we need to go to early implantation. That's going to be the way to go for your child. The other nice thing is that generally there are no significant temporal bone anomalies that will affect us as CI surgeons. There could be some subtleties, but generally not really enough. There are now many papers that have gone over that patients with GJB2 have a very high success rate with cochlear implants. Now, we reported on this many, many years ago. These patients still can have other issues, though. They're not related to GJB2, but they have the same rate of other problems like autism that the whole general population has. So it's not a guarantee, but it gives it a very high chance of actually doing very, very well. Another group that's relatively common is going to be those from the Usher syndrome genes. As I said, most of these will cause Usher syndrome, and particularly type 1 is the one we're most interested in as cochlear implant surgeons. But a lot of these mutations may not cause the blindness problem, but may still have the hearing problem. Now, of course, as you can probably imagine, visual language in the long term would not be a good option for these patients. And again, manuscripts have shown that there is a very good success rate with restoring hearing, because remember, in the Usher syndromes, these are mostly hair cell, they're mostly found in, these proteins are found in the hair cells. So again, this patient population, ideal for early implantation. Now, the one that, of course, has been very tricky over the years is the auditory dysynchrony type patients. As I mentioned earlier, we were one of the first in the US to report that cochlear implants seem to work very well. We know that this is that difference between a listening and a hearing, right? They can hear tones, but they just can't hear complicated speech. One select group that you have to be aware of is the hyperbilirubinemia patients. And the reason is we've had patients up to 17 months of age that have had spontaneous improvement in their auditory neuropathy. And it's really, really important, because in those cases, you don't want to do a cochlear implant early on that type patient. For the auditory dysynchrony patients who don't have hyperbiliary and particularly have mutations in the otoferlin gene, those patients will always have very stable hearing. It will never get better, and early implantation might hold the key to have these patients do even better. Right now, our data shows that about 80% of these patients will do well with cochlear implants. Not quite as high as for classic sensory loss, but relatively good. Now, I just want to close on, what's on the horizon. Well, obviously, gene and regenerative therapy is now going to be in the forefront. And I think hopefully over the next 5 to 10 years, we're going to start to see this come about. And hopefully this will make its way, of course, to all parts of the world, because initially, though, as cochlear implant surgeons, I'm going to predict this is not going to have a major impact on us. mainly because most of these patients probably don't have enough hair cells left that gene therapy would be effective. So you're probably going to have to do a combined hair cell regeneration and gene therapy. Eventually, could this affect us as cochlear implant surgeons? Absolutely. But we'll have to see how that works. So, well, again, I want to thank everyone for letting me participate. This is an awesome forum, and Sunil, another great job as always. So look forward to seeing you in person, by the way.
Absolutely, absolutely. So John, a very quick question. There are over hundreds of deafness genes and thousands of mutations now. I think every other day there's another one added in terms of mutations. So how do you use this for counseling families? The genetic counseling, as you call it. How do you
Sure,
use
and that is critical. You actually, I didn't even talk about that. That is so important because the information the families get has to make sure that it has to make clinical sense. And so there's, I would answer it in two ways. The first is you have to work with a group who is very familiar with hearing loss genes, not just general geneticists who know general hearing, but they really have to make sure they know what do each one of these mean. Because as ENTs, if I'm giving this information back to my ENT colleagues, I really want to make sure they get clinically relevant information. How is this going to change the outcome? The second is that fortunately, even though there's 150 of these genes, the good news is, again, as I said in the talk, about 10 or 11 are the ones that make 90% of all the information. And we have really good genotype, phenotype correlation information on most of those genes. We can make predictive informations based on the genotype with those genes. So I would say that right now, we do have we're at the golden age now that we can really predict in this little 3-month-old who you don't have a good idea what's going to happen, that we can really then help with the decision of, do we do early implantation, or is this somebody who we want to wait a little bit longer?
One is that. What about questions on, will my next child have an issue?
Right. And so obviously for the recessives, the answer is going to be yes. It'll be 1 in 4. If it's, of course, a dominant, it'll be, of course, a 1 in 2. Most of these, though, overall are going to be recessive. So the good news is it's only a 25% chance, relatively modest. And actually, I've found that having the families understand what's going on, and then particularly do well with this first child with an implant, and all of us have many families where they have multiple kids with implants. I found that after they get through the first one and they are empowered by this information, honestly, I think they attack. If they have another child, they just attack it. They know exactly what to do.
Great. Deepak Haldipur, I hope, is still with us. And Deepak, your thoughts on all the talks this afternoon in this panel. Deepak, are you with us? Because one of the things I was thinking was for Fatih, if Fatih is still with us, what percentage of your patients, Fatih, actually need a cochlear implant, otosclerotic patients? What is your experience? How many of them really get to a far advanced otosclerosis requiring cochlear implantation?
Actually, it's not that much, Sunil. Most of them, we start first with stapedectomy, but the incidence, I don't have the exact incidence, but it's not that common.
Deepak, your thoughts? You're an expert in otosclerosis and surgery for otosclerosis.
Yeah. Well, boss, what do I say? The expert has already spoken. I wouldn't like to add anything, boss. It's up to you. But anyway, I definitely see with the MRIs and CTs coming in and more deeper investigations, definitely we're going to have more of combined otosclerosis cases where we'll end up doing more and more implants with more precision and prediction because of the scores and the tests available. Absolutely. Yeah.
Okay. Any other thoughts on any of the other talks this afternoon, Deepak?
I think Prepa's talk was an eye-opener. I think it was really good. So also was the extended round window technique for preserving. My question was the Heal-On injection, which Dr. Shankar Madikeri uses so often. I wanted to ask all you guys about Heal-On regarding this preservation of the residual hearing where the bone dust doesn't get into the inner ear.
Correct.
What is your take on
all
that?
Of us, yeah, all of us were trained to use Heal-On when we first trained for exactly the reasons you were saying. But today we've shifted from using Heal-On to steroid very classically, and I think James is there to answer that question too. So we insert the electrodes in a steroid lake or a steroid pond, and James, if you would like to elaborate on that.
Yes, thank you. I'd agree. I'm not crazy about the use of Heal-On because for a few reasons. The first is that it really distorts your vision. You get this fish eye lens view of the round window, and you don't really know what the reality is. And the second is that when you want to then remove it to see what the reality is, if you suck on it, you can easily suck out a lot of fluid. And the third thing is I saw a presentation, I can't remember where it was, which said what you were saying, Sunil, that in fact, studies have shown that Heal-On is not very good for the inner ear and for preservation of hearing. And therefore people have moved towards steroids.
Steroids.
But yeah, so that's what I can contribute. I'd be interested to hear what other people have to say.
Any particular steroid? What's your...
No, I must say I tend to use nothing. I tend just to try and avoid suction at all costs and not put fluids in, because if you put fluids in, you can have too much, then you've got to suck them out again, and you can make a mistake and suck out the inner ear fluid, which is the last thing I want to do. So I try to just use nothing.
Shankar Madikeri is sitting next to me, and he was saying, and he's right. Now that we've gone to round window insertions and only pure membranous round window insertions, so we just lift the flap or make a very slight incision and insert through there. No suction, no steroid, nothing. Yeah. Wonderful. I think we will have to end it here. We could go on, this could be an all-day GCIN symposium. But then thanks to each one of my dear friends on the GCIN steering committee, you were all wonderful, and we'll keep these conversations going. Deepak, thanks a ton for co-chairing this session with me. And I think we'll leave the platform to the next symposium, which is the Abbott Symposium on vestibular issues in cochlear implant children and cochlear implantation surgery. So I would request Shankar Madikeri to take over.
Thank you very much for all your hard work.
Thank you so much.
Thank you, everybody. So I welcome all of you for the last scientific session of today. That is going to be, as Sunil mentioned, it is an Abbott Symposium on vestibular issues in cochlear implants. We have two eminent speakers, Dr. Milind Kirtane from India and Dr. Alfargal Mohammad from Saudi Arabia. And this session is going to be moderated by Dr. Suhail Hassan. So I'm just going to introduce Dr. Suhail Hassan and then hand over the mic to him so he can conduct the further proceedings after introducing Dr. Kirtane and Dr. Alfargal Mohammad. So Dr. Suhail Hassan is a member of Head and Neck Cancer Working Group and consultant to the ICF, that is the International Classification of Function, WHO, in developing core sets in head and neck cancer. He is a visiting surgeon at HNO Clinic, Tübingen, Germany, and a visiting faculty at Kidwai Memorial Institute of Oncology, Bangalore, India. He has a fellowship with Professor Nobukiyo Ishiki at Kyoto University and Ishiki Clinic, Kyoto, Japan. He has been awarded the JLO Fellowship of UK in 1995, and he also had a AOI Travel Fellowship in Head and Neck Oncology at AIIMS, New Delhi. He's on the editorial board of the Postgraduate Journal of Medical Research, and is a reviewer for the Indian Journal of Otolaryngology and Head and Neck Surgery. So on the international panel reviewers of ENT News, and is reviewing the Indian Journal of Otolaryngology, Head and Neck Surgery. and he has been a research person and faculty at various workshops on phonosurgery, airway disorders, and laryngotracheal stenosis. He has been the co-author on chapter in textbooks of tropical surgery on oropharyngeal cancer, and he has published over 30 peer-reviewed publications in both international and national journals. He was the past president of the Association of Otolaryngologists of India, Bangalore chapter in 2003. Over to you, Dr. Suhail, to conduct the session and take it further forward. Thank you.
Thank you, Dr. Madikeri. Thanks so much for your introduction, and I think we'll get straight away into today's Abbott session. It's a special session on vestibular issues in cochlear implantation, and we have none other than Dr. Keertane and Dr. Al-Farghal Mohammed from Saudi Arabia, and I'm sure everybody in watching has heard Dr. Keertane speak on implants and various aspects over these many years, and lots to gain from him and hearing him. And today he's going to speak on these vestibular issues. His CV would run into many pages and take many hours for me to go through, but for the audience who's abroad, Dr. Keertane is one of our very senior most and distinguished surgeons and cochlear implant surgeons in India. And he's been honored with the Padma Shri, which is a big national award in India. And he's a consultant ENT surgeon at various hospitals in Mumbai, Breach Candy, Hinduja, and the Medical Research Center in Mumbai. He has, of course, an abiding interest in cochlear implants, and he's been performing these surgeries in Mumbai and elsewhere around the country and the world. He has over 2,300 cochlear implant surgeries and has done the first one in Mumbai. Dr. Keertane also is a winner of the B.C. Roy Award from the Government of India, and he was the first person from our country to be elected to the Barani Society in Sweden and the Neuro-Otological and Equilibrometric Society in India, in Germany. And he's on many editorial boards, the Neuro-Otological and Equilibrometric Society International, the ISRN Otolaryngology, and Archives for Sensology and Neuro-Otology in Science and Practice. Keertane is very active social activities too, and has many articles, and 50 of them, and many books to his credit on otology, neuro-otology, and endoscopic sinus surgery. I welcome Dr. Keertane again and request him to please present his views on vestibular issues in cochlear implants. Dr. Keertane, please.
Thank you very much for that kind introduction. Just one error in that which I need to correct. I was not the first to do cochlear implants in Mumbai. It was Dr. Sandra Adisa who did that much earlier. I started in 1995, and today our numbers stand at about 3,500. As you said, not all done by me, but mentored by me for quite a lot of times. Now, we are going to be discussing vestibular dysfunction after cochlear implantation. Now, I had a call from our president, Dr. Sunil Dutt, saying, could you speak on this? And I told him, look, we do not do this as a routine evaluation in our patients. And since you're asking me, I mean, you cannot say no to the president. So I said, I'll review the literature and tell you what the current concepts are. So here goes, talking about vestibular dysfunction after cochlear implantation. And it's not. Can I just
please make the slideshow?
Yeah, I'll do that. Is it going to slideshow? Okay, fine. Is that okay?
Yes, Dr.
Yes, that's fine.
Okay. And you know, the inner ear, the vestibular part and the auditory part are developmentally, phylogenetically, structurally and functionally really so closely interlinked that it is only natural to expect that a disturbance in one could lead to a problem on the other side. And this is, as ENT surgeons, we really know this to be absolutely true, because when you do a stapes surgery, for example, to restore hearing, you're on the vestibular side. But if there is some amount of error, you can have the patient getting out on the operation table with severe vertigo, vomiting. You can even have a complete hearing loss. Similarly, even in a tympanoplasty, where you do not open the inner ear, but if you move the ossicles a little more than they should be, handling, your patient could have post-operative vertigo in spite of the fact that the inner ear is not open. Suction in a mastoid cavity invariably leads to patients having vertigo. Then you look at pathologies on the vestibular side. For example, lateral semicircular canal fistula in a cholesteatoma case. You naturally expect vertigo, but these patients can also land up with profound sensorineural hearing loss. Superior semicircular canal fistula. So a disturbance on the vestibular side, but when we try to seal that fistula, very often you land up with especially a high tone sensorineural loss, high frequency hearing loss. Posterior canal fenestration is done as a surgical treatment for BPPV, and you occlude the canal. And also you find that in some of these cases, you could land up with a sensorineural hearing loss. So disturbance in one part, on the vestibular side, you land up with cochlear problems. So similarly, you would expect that if you do something on the cochlear side, you could probably have vestibular symptoms. You've talked about Tullio phenomenon and the vestibular evoked myogenic potentials. Now, these are both vestibular stimulation purely by an auditory stimulus. So you see how closely interlinked these are. And not to forget, in between, there was a lot of literature on this, the spontaneous round window fistula, which gave rise to sudden attacks of vertigo and not too uncommonly also sensorineural hearing loss. That arrow is pointing to a tiny puncture. I mean, this is from the literature that I picked up, a tiny puncture in the round window membrane, giving rise to patient complaining of severe vertigo. And we just heard Dr. Medicari saying, what do we do now? We shove in that whole implant through the round window, not just a tiny puncture. You slit open the membrane, sometimes even drill to make an extended round window. And yet, surprisingly, we find such a small incidence. Again, this is from the literature, and this is very, very surprising. Incidence reported in certain trials, 0.33%, less than 1% patients complaining of vestibular symptoms to 75%. Now, I can understand that in any report from different centers, different patient population, different surgical techniques, different implants being used, etc., should have some variation in the incidence reported. But less than 1% to 75% reported is something not quite right. I mean, it's really perplexing. And obviously, I think what seems to be happening here is that all of us know that most of our patients do not really complain of vestibular symptoms. And I'm sure that a lot of colleagues of mine who, like me, do not as a routine do vestibular investigations in patients with cochlear implant. In my series, as I said, we are over 3,000 cases now. Less than 8% are adults. And now we are finding children that we are operating are a younger and younger age. So if I operate on a 1-year or a 2-year-old child, even if the child has some amount of dysfunction, it's certainly not going to complain to me of vertigo. So what I feel is that this disparity that we saw in literature of less than 1% to 75% comes from different clinics, those that deal mainly with the pediatric population and do not do vestibular investigations at all, like us. On the other hand, those that deal more with adult patients and do vestibular investigations, including a detailed history pre and post-op, and note down the slightest vestibular disturbance that may be coming in. and therefore have a high incidence as high as 25%, saying there is some vestibular dysfunction after surgery. Now, going through the literature, I found these are the tests that most people do. This is handicap inventory, the bithermal caloric test, rotation test, the V-hit, posturography, and CWAM. And you know, it's really going to be very difficult to administer these tests to very young children. I mean, there have been reports where people have done bithermal caloric tests in very young children, or rotation tests, and it's not very easy. I know one of my mentees had done a trial on children. She said that the moment you started putting fluid into the child's ear, the child would start screaming and shouting, and the recordings were not really very clean and readable. So I don't know how accurately you're going to get this information in children. Of course, on the adult population, it would be much simpler to get this data and run these tests pre and post operatively. So coming down to the nature of dysfunction, or let's say the complaint of dizziness or vertigo that occurs in these patients, you can classify it into three main groups. One is patients who complain of vertigo immediately after surgery. The other group is those who go home fit and fine, and they come back weeks to months later saying now they've developed vertiginous attacks. And the third one is, of course, at the time of switch on or when there is electrical stimulation, because certain electrodes might be giving extra auditory symptoms and may be giving vertigo. So the one that occurs with the use of the implant or switch on of the implant. So let's look at the first one. Now, the immediate, as I said, you saw that implant going in, and you would expect so much of a disturbance into the cochlea, would disturb the vestibular organ as well. It could be a direct trauma to the vestibular end organ or to the primary vestibular neuron. But in whatever post-mortem studies that were seen in some of the patients who had died after cochlear implants, this was not really found in most of the cases. And there was no direct trauma to the vestibular end organ or the primary vestibular neuron. So the second possibility is that because you're opening up the inner ear, you're somebody's putting helon, steroids, sometimes a little blood might go in. You're putting a foreign body inside and initiating an inflammatory response from the inner ear. So a sort of serous labyrinthitis might set up, and therefore the patient may complain of some vestibular disturbance or vertiginous symptoms. And thirdly, of course, you're hoping that you're just purely opening up the scala tympani and going into the perilymphatic space. But at times, the transgression of the other space is leading to an upset homeostasis of the inner ear fluids at the time of surgery, could lead to the patients complaining of vertigo in the immediate post-operative period. So these are the three possible explanations which I found in literature. And they said that it's more likely to occur if you're operating on the only functioning ear. So for example, it is known that patients with profound deafness might already have vestibular dysfunction or hypoactivity on the vestibular side. Now, suppose a patient had a completely areflexic ear on one side, and there was a little functioning ear on the other side, which was helping with his vestibular function. And if you operated on that side, the only functioning ear is operated on the, when they say functioning, we're talking about the vestibular function, then the symptoms are more likely to occur. And if you do a simultaneous bilateral, that is the time we've had a few patients complaining of, especially mothers telling us that the children are walking, while walking, they're a little wobbly, but they seem to settle down. They compensate very, very rapidly because they are very, very young children. And it's less likely if you operate on the side where the vestibular function is already poor. So whatever disturbance you may cause if you operate on the poorer ear may not then give the patient too much of symptoms. And this is something which, as I will refer to later, that if you have a patient who audiologically is equal on both sides, radiologically there is nothing to choose from. If you do a vestibular function test, let's say you do a bithermal caloric test, and you find that one of the ears is functioning well and the other ear is functioning poorly, showing hyporeflexia or areflexia, then perhaps that might be the ear to choose to operate so that the vestibular symptoms theoretically would be much less. Vestibular symptoms, again, this is from the literature, are more likely to occur in patients if they already had some amount of preoperative dizziness, if the age at surgery was fairly advanced, because we are now operating on seniors of 80, 85 years. I think Senaroglu told me that he had operated on 100 plus patient. So if the age at surgery is advanced, the chances of getting vestibular symptoms is higher. Or if the onset of deafness was at an older age, then the chances are higher. And of course, if the patient already had, say, preoperative testing done and you find abnormal posturography, the patient is a bit shaky on his legs, then the chances that he would have symptoms post-operatively are higher. Then we come to the other variety where the patient goes home completely okay, no symptoms post-operatively, and comes back after a few weeks or months saying, I've started now developing vertiginous attacks. And this is thought to be because of endolymphatic hydrops, which may develop as a result of the implant. One possibility given is that the flow of the endolymph might be obstructed by the implant itself or by the inflammatory reaction that is set up, leading to fibrosis and therefore producing an obstruction of the endolymphatic flow, leading to an endolymphatic hydrops in the cochlea. So this has been shown in postmortem studies in temporal bones, that patients who had complained of vertigo and then succumbed to whatever other illness when the bones were studied, they did find evidence of not only endolymphatic hydrops in the cochlea, but quite often associated with that, a collapse of the saccule. The collapse of the utricle was much rarer, but collapse of a saccule along with endolymphatic hydrops was far more common. And one possible explanation for that was that either the implant itself moving a little away from where you had placed it led to the blockage of the ductus reunions, so which is the communication between the cochlea and the saccule. And that blockage led to the cochlea not draining out, therefore the hydrops, and the saccule collapsing because there was no more fluid coming in there. But more likely, they said, because they found, again, histopathologically, no blockage in the ductus reunions, more fibrosis because of the inflammation in the hook region. And that fibrosis leading to the blockage of the endolymphatic circulation, and therefore endolymphatic hydrops and collapse of the saccule. Because as you see in the picture, when you're going in through the round window or an extended round window, you're quite away from this region. Therefore, this is not going to be affected directly by the implant. But if this sets up an inflammatory reaction and therefore causes fibrosis here in the hook region, then you could land up with this problem. So we said blocking of the ductus reunions, blockage of the hook region. But there was another theory formulated, and that said that when you're putting the implant, very often you're going along the outer wall, and you may sort of damage the spiral ligament, which is supposed to play a very important role in the homeostasis of the inner ear fluids. So that accidental damage to the spiral ligament during introduction can affect the homeostasis of the endolymph and therefore lead to certain changes over a period of time, leading to cochlear hydrops and therefore symptoms of vertigo coming up as a delayed symptom. So this can occur weeks to months after surgery. As we said, hydrops in the cochlea, collapse of saccule, rarely the utricle. But don't forget that sometimes it's not just the hydrops that may be producing symptoms. These patients may also present to us with BPPV, which is known to occur after implants or any ear surgery, as a matter of fact. Then somebody suggested traumatic neuromas, which were not really found in the postmortem studies. And lastly, of course, progressive vestibular functional loss because of ossification attributed to the cochlear implant progressing to ossification. Because if you do a cochleostomy and you're getting some bone dust inside, you may get progressive ossification, which may lead to damage to the vestibular function over a period of time. At switch on, of course, electrical stimulation can occur in the vestibular organ. In certain circumstances, you may get saccular stimulation. But if you have cochleovestibular anomalies, then the chances of vestibular stimulation become that much higher and much, much more common if in such a cochleovestibular anomaly, the array has been misplaced. We have seen this in a number of cases. This is one of the reasons why whenever we operate, we insist on a post-operative imaging to make sure that we do not land up with this problem. But with misplaced arrays, when you switch on, patients get vestibular stimulation, and the only thing that you can do is switch off the offending electrodes. And if it's a grossly misplaced array, then of course you would have to go in and reinsert the implant or change the implant. So these are the tests which have been recommended to be done: the dizziness, handicap, inventory, caloric test, the rotation V, computerized posturography, and CWEM. But rather than do this only post-operatively, what I realized by going through the literature, that if you do it pre-operatively and then post-operatively, the same tests, I think you'll be able to get much more valuable information. And it has been shown that in a certain percent of cases that you go for cochlear implant, there is already a pre-op vestibular dysfunction existing. Now, if you don't do the pre-op test and only do them post-op, you will attribute that dysfunction to the cochlear implant, whereas it was actually existing before. So to get more accurate findings, do pre and post-op tests, caloric tests, posturography in patients who are old enough to get it done. And these post-operative findings of vestibular dysfunction is often shown on testing, but surprising, the patient discomfort doesn't seem to match the findings that you get in your vestibular testing, mercifully so. And that's why very, very few of our patients have come back to us complaining of vertigo after cochlear implants. However, having gone through this, I realized that especially if I'm doing a bilateral implant or implant in adults, I would definitely now change my attitude and counsel them pre-operatively about the possibility of developing vestibular symptoms, reassuring them that they're most likely to be temporary and nothing to be worried about. But in pre-operative counseling, I think we should be doing this. And as I mentioned earlier, choosing the year for a unilateral implant when both sides are audiologically and radiologically the same, if you do a caloric test and find that one of the years is hypoactive or areflexic, perhaps that would be the year to choose to operate. And of course, don't forget that the patients, especially the elderly who come for cochlear implant surgery in the advanced stage, may be having vertigo from other pre-existing causes and may have nothing to do with the cochlear implant that you're doing. Thank you for a patient list. Thank you.
Thank you. Yeah. Yes, thank you very much, Dr. Keerthane. You brought out lots of excellent points, and we don't usually give so much, weightage and in time and to select patients, considering vestibular issues. But excellent take-home messages that which year you could select and whom you would counsel, and then do pre-op vestibular testing and post-op. Then it will probably give us much more value. Though I mean, we are so closely linked while doing implants that rarely we get to see many post-op vestibular problems. And like you said, they compensate probably very well. And we don't seem to be troubled by them, and we don't give so much credence to those things because, of course, one thing is in kids, it's so very difficult to test them, this whole battery of tests. And I think with your number of cochlear implant surgeries, you would definitely know and pick up which child is not too well in terms of his vestibular function post-op, and maybe then try and do some testing for him. So have you ever noticed this on your post-op, that one child is definitely much more dizzier than the other? And then, of course, apart from counseling, what else would we be able to do at that time?
You know, have had a couple of mothers coming and telling me after a bilateral implant that the child is a little unsteady while walking, is tending to fall down. But when they come for the a visit after a month or so, they say no, the problem has settled down. So there is definitely vestibular affectation, especially in bilateral cases. And in adults that we've operated, surprisingly, they haven't really come back to us with. I mean, if we ask them, probably they would tell us that yes, I feel a little dizzy, but they haven't forthcoming with that information on their own. Has not been there. So I'm sure we are producing vestibular disturbances to some extent, but the patients are not coming back with those many complaints.
I'm sure they rehabilitate very quickly. So what we'll do is we'll have Dr. Mohammed give his talk, and then we can sort of pull up any issues which have come up, and then we can discuss them. And you've given us an excellent, very good pointers and an overview of vestibular problems. Our next speaker is Dr. Al-Farghal Mohammed. He is from King Abdulaziz Medical Hospital at City, Jeddah, and he's the director of AVISA Online Institute. He's from Saudi Arabia. Welcome, Dr. Mohammed. Good to have you with us at this conference. Just to read out and tell the audience, Dr. Mohammed is a consultant in audiovestibular medicine, and heads board of audiology and many other related diploma and degrees, certificates, extensively trained in audiovestibular medicine, audiology, and has a medical background. He provides local, regional, and online overseas expert consultations for hearing and balance disorders and electrophysiology and implant mapping. He's the author, reviewer, speaker, and instructor, and director of AVIS. So since 2011 to date, he's been in charge of the auditory vestibular units at the Institute, King Abdulaziz Medical City in Jeddah, which is a big center in Saudi Arabia. And we thank you for your time and sharing your views with us today on this particular topic.
Thank you very much, Dr. Sohail, for the nice introduction. Thank you for Dr. Sohail for the invitation, and thank you for organizing such outstanding conference. As you touched in my background, that I have a medical background, and at the same I do a lot of vestibular testing and management. I run a very busy vertigo clinic.
Your screen is not visible, doctor.
Really? For me, it looks okay.
Your slide share, I think.
Yeah, I put it. It should be. Don't know why it's not. So I hope it come now or still not yet.
Yes, yes. Now we've got your slide.
Okay, perfect. So again. So I run a very busy vertigo clinic, which receive patients from different ages, including pediatrics. And at the same time, also I'm in charge for the pre-operative, intraoperative, and post-operative care for the cochlear implant recipients. And I have been asked by Dr. Sohail also to talk about the vestibular dysfunction after cochlear implantation, and it seems clearly that there will be some overlap between my talk and what Professor Curtin presented in his talk. But I will bring a few points. So before I start my talk, I want to share with you, and I know that you are all of you eminent otology surgeons, that there is some limitation of the vestibular testing. If you look to the caloric test, it's a very old test, and for many years it has been the gold standard for vestibular assessment. But if you look carefully, you will find that the caloric test can be affected by factors other than the vestibular dysfunction. So the eviction current in the semicircular canals if there is a changes in the middle ear heat transmission mechanisms for any reasons, this is could make the caloric test not normal. So sometimes the abnormalities of the caloric testing is related to mechanical or other physical factors other than the physiological loss of the vestibular function. So this should be considered in mind. The other point that is a test like the cervical VIM, which is a very popular test for the assessment of vestibular function related to cochlear implantation. So you will find also if you use air conducted stimuli, that these air conducted stimuli can be affected by any change in the middle ear mechanics, any conductive loss as a result of the cochlear implant surgery or any other otological surgery. So it attenuates the stimulus. So it also, again, it could compromise the response. And also the technique for doing the cervical VIM, there is two major ways of the technique. It's just to do recording without rectifying the response, or just to use the rectified muscle response. So there is a lot of variation even in normal individuals regarding the CVIM responses because it depends on the basic myogenic activity or the muscle contraction or activation, which it could be variant. Is the subject sometimes got tired during the test or fatigue? So the muscle contraction will be weak. This is definitely will affect the test. So in the literature, you will find such a variation, and this is explains why there is this huge variation as mentioned by Professor Curtin. So the standard of doing the test, and it's recommended for the CVIM to have a more valid, a more reliable, less variable test result to use the rectified muscle technique. So and as Professor Curtin mentioned, that the frequency of such incidents is controversial, and it's as mentioned, it's from less than 1% to 75%. And the mechanism of vestibular dysfunction reported in the literature, it was highlighted by Dr. Curtin presentation. It's found that it's more common with cochleostomies and direct trauma caused by the electrode array insertion, changes in the normal fluid homeostasis of the inner ear leading to mechanical alteration in the vestibular end organs, intraoperative loss of perilymph, surgery-induced inflammation resulting in fibrosis or loss of hair cells, reaction to a foreign body, endolymphatic hydrops, and electrical stimulation. This paper is just published today, this morning, by Professor Jeremy Horenbroek, and it was clearly relating that is the blockage of ductus reunions. It can cause Meniere's disease or endolymphatic hydrops. This supports what have been mentioned by Professor Curtin, that it's one of the mechanisms that blockage of the ductus reunions, either due to bone debris or due to the drilling, it can lead to hydrops. Factors affecting vestibular dysfunction after the CI. So the surgical procedure for electrode placement, theoretically a soft surgery procedure could what warrants the least trauma also to the vestibular organs. The slow speed of insertion of electrodes seems also to help in preservation of residual hearing and vestibular functions. And in the literature, it's clear that the round window implantation is safer in terms of vestibular dysfunction, and more vestibular dysfunction was reported with cochleostomy. And here is a very recent paper comes from India from one of my dear colleagues, Dr. Niraj Singh. It was published yesterday, and he compares the cervical VIM in cochlear implant recipients with two different techniques. So the canal wall lifting technique and the mastoidectomy technique. And there was follow-up testing pre-operatively the day before the surgery, testing post-operative 4 months, then after 1 year. And the results showed that is the mastoidectomy is more safer regarding the cervical VIM preservation. I am sure that you are more expert than me for this anatomical relation, but it's the scala vestibular insertion is reported to have more association with vestibular dysfunction because simply the perilymph in the basal tier of the scala vestibuli is directly connected to the perilymph of the vestibular compartment. It is believed that there is a great occurrence of a clinically significant vestibular alteration in patients with bilateral cochlear implantation because those with unilateral implantation are more able to compensate for the vestibular injuries at one side. If we look to the natural physiological vestibular compensation or the compensation process, it depends with a major part about the functioning of the other side. So it's yes, in bilateral cochlear implantation there is more vestibular problems. Vestibular dysfunction after cochlear implantation, the occurrence of changes in the body balance, including all the pathologies in the post-operative period to the cochlear implantation from 31 to 75%. The changes can be classified in short term, intermediate term, and long term, exactly as Dr. Cretin highlighted. And the symptoms are often transient and short-lived. Post-operative dizziness did occur more frequently in patients with preoperative vestibular hypofunction than in patients with normal results. This is contradicts what Dr. Cretin told in his presentation, but this is in this topic there is a lot of variation in the literature. So the overall vestibular dysfunction after cochlear implantation, 27 studies were included in a meta-analysis conducted by Ibrahim et al. In 2017. Most studies performed caloric test and or VIM, with the studies investigating changes in head impulse test, posturography, or dizziness handicap inventory. CI surgery significantly affected the results of caloric and VIM testing. In particular, the saccule and the lateral semicircular canal has been the most commonly affected vestibular organs that are more likely to be endangered with cochlear implantation. Head impulse test results, posturography, and dizziness handicap inventory scores were more significant, were not significantly affected after cochlear implantation surgery. This is important point because the type of the test used to report the vestibular dysfunction could impact the result and the final impression. So the head impulse test was a physiological test. The posturography and dizziness handicap inventory scores were not significantly affected after cochlear implantation. The potential effects of surgery on the vestibular system should be discussed with cochlear implant candidates before surgery. At least 4 of the 5 vestibular sensors are vulnerable to impairment after CI. Only anterior or superior canal was not reported in the literature to be affected after cochlear implantation. The impairment varies from patient to patient with different types of vestibular end organs involvement and different combination of involved end organs. Now, as a clinicians, we do have the video head impulse test, which you can test the function of the 3 semicircular canals. We have the cervical VIM to test the saccule. We have the OVIM to test the utricle. So we can do testing, the vestibular testing to the 5 vestibular end organs. Half of the pediatric cochlear implant candidates have vestibular deficits, and 51% of implants induce modification of existing vestibular function. Each implant should be preceded by canal and otoless function test to assure that the least functional vestibule is implanted, and all of us agree about this. BBV incidence in cochlear implant recipients is of 159 per 100,000 per year, with a ratio higher than in the general population, which is 64 per 100,000 per year. So BBV is more common than the general population in cochlear implant recipients. Electrical stimulation and vestibular system dizziness and nystagmus induced by sound can occur in patients with CI, suggesting that it could have been caused mainly by co-electrical stimulation of the vestibular end organs. The impact after CI was studied in terms of dizziness and quality of life using the dizziness handicap inventory. Faisal Zawawi, one of my Saudi colleagues, studied in 2014, studied 122 CI recipients, and they found that the most common subtype of dizziness was the instability. And the dizziness was evidenced in 27% pre-CI and in 45.9% of the population after CI. In the majority of patients, symptoms were mild. Those also overlap with what Professor Curtin mentioned, but here I put a note that here, despite in the literature, a lot of reports about the cervical vein, but really you have to look if it's either tested with air or bone, because we expect some mechanical changes in the middle ear after the cochlear implant surgery. So one of the smart ideas coming now among clinicians or professionals doing the vestibular testing for CI recipients, that also we have to include the bone conducted VIMP in these cases, because it could be the absence of air conducted VIMP just due to conductive hearing loss created by the surgery or as the effect of the surgery. So we get a more reliable results of also include bone conducted VIMPs. And despite these tests are the reported one in the literature, but I added here from my side that in addition to all these tests, we have also to do video nystagmography to look for spontaneous or provoked nystagmus. We can look for spontaneous nystagmus. We can look for the nystagmus typical of BBV. We can do a fistula test and look also for any round window fistula after CI surgery. So this is, despite not clearly highlighted in the literature, but we do also routinely that when we examine the patients, we have to look for nystagmus. Preventive measures, preoperative vestibular evaluation can assist in the choice of the site to be implanted. Due to the high prevalence of vestibular dysfunction in unilateral implanted children, sequential implantation must be preceded by complete vestibular assessment to prevent complete bilateral vestibular areflexia and its potential consequences. This is traditional, or you can see how many references for this paragraph. But on the contrary, Sharon Cushing, she is a cochlear implant surgeon and also a specialist in pediatric balance and vestibular disorders at the University of Toronto, specifically as a sick children hospital. And she has a textbook and she has a lot of publication and a lot of work about vestibular assessment in cochlear implant recipient patient. And through personal communication with her, she believes that the children should receive bilateral implantation regardless for their vestibular assessment or results. Because, and also their work revealed or showed that cochlear implants could improve the postural control, and they explained that it could give a head reference cues. And here, this is also a recent publication from the University of Toronto, the team of cochlear implant, including Blake Babson and Karen Jordan and Sharon Cushing. They developed more about the concept that is the cochlear implant improves the balance and could improve the postural control by giving a head reference. And they used what's called the balance eye. And balance eye is they are using the smartphone. They are using the smartphone. They created an application which changes the head movement, very sensitive to the head movements. And it changes the head movement into acoustic signal, which is delivered to the cochlear implant system from the direct audio input. And they found that it improves the scores in the dynamic posturography test. So they believe that is the cochlear implant itself, it could give like a head reference, so it can help in the balance control and the postural control. And they showed many videos for their cochlear implant recipients playing acrobat and in the gym and in swimming. So it's clearly from their work that the cochlear implantation also can help the balance and improve the postural control. And they developed more in this by trying to implement this, the smartphone, and using like a head motion sensor, which convert this head perturbation into acoustic signal through the direct audio input of the cochlear implant processor.
Dr. Mohammed, can you just wrap up in the next 2 minutes, because we have a
Yes,
general
yes,
body.
I will do it, sir. Yes. So a smooth insertion of cochlear implant electrode over 1 minute, systemic and local dexamethasone administration before and during the surgery. I share with you one clinical case. It's a 41 years old male, lost hearing after CNS brucellosis, and he presented to our clinic 4 months after receiving bilateral cochlear implantation. He developed recurrent spontaneous attacks of vertigo. On examination, I found left beating spontaneous nystagmus. And on the video head impulse test, I found there is a left lateral canal VR loss. You can see here, there is a left lateral VR loss. So actually the direction of spontaneous nystagmus is unpredictable. It doesn't match with the side with a more VR loss. And so it could be some sort of a recovery in nystagmus, which also occurs with Meniere's disease or endolymphatic hydrops, or due to, it could be due to effect or endolymphatic hydrops in the right side. So anyhow, we, because the attacks are spontaneous and recurrent, lasting for like minutes up to half an hour. So, and with this finding where it looks the side of vestibular hypofunction is opposite to the side of not matching with the direction of the spontaneous nystagmus. So our final diagnosis was it most likely a secondary endolymphatic hydrops, and the patient instructed to do salt restriction and to receive beta-histidine, and his symptoms has been completely controlled over the last 5 to 6 months. Those are my references, and thank you very much.
Thank you, Dr. Alfargal Mohammed, for your excellent talk. And I would also like to thank Dr. Milind Kirtane for his contribution to this Abbott Symposium. And I thank Dr. Suhail Hassan for chairing this session and moderating. So thank you all of you. And we are going to close this scientific program now, because we are going to start off the general body meeting very soon. Thank you very much.
Thank you. Thanks to all, to everyone. Thank you, Dr. Madikeri.
Just wanted to compliment Dr. Alfred Mohammed on the fantastic presentation. Very, very impressive. Very impressive.
Thank you. Okay.
Thank you.
Venu, please stop live streaming and end the meeting. Venu?